We can start? Okay. So, good morning, everybody. It's really one pleasure to welcome you for this annual RCEP meeting to 2023. On-site at the Necker Institute and also remotely, because we get a web seminar and people on their laptop could also, with the chat, ask questions. We want first to thank the RCEP for the continuous support of this annual event, and especially Emmanuelle Plassard for the wonderful work she's doing for the whole organization. So this year, the organizing committee, Elise Bagnier, Anne Kerbra, Isabelle Berry, Eman Tourba, Bruno Stankov, and myself, we have chosen to address one important topic relative to the stratification of MS patients with imaging. So during the last 10 years, a revolution has occurred in the MS field concerning the efficiency of treatment to limit or even suppress acute inflammation in patients. But this gain in efficiency led also to potential increasing risk and the need also to get the trajectory of each subject in order to get the possibility to change the therapeutic approach. For decades, the different MS centers have acquired large database of clinical imaging data that allow to better characterize the different phenotypes of MS and to improve the diagnosis criteria. But now, we really need to be able to use this data at the personal level. And for that, we need to perform personalized medicine. So, to this goal, the second revolution was related to the progress of computational power, and this allowed to cope with big data, with access to machine learning approaches, and in a more generic way, artificial intelligence, and we can now use that to stratify patients. So today, we have internationally recognized experts of the field of classification, going today to give us a snapshot of a current state of the art concerning the stratification of MS patients using MRI. So I hope you will enjoy this day, and I let the floor to Professor Anne Kerbra and Professor Bruno Stankov for sharing the first session. Thank you very much.
So thank you, Jean-Philippe. So for the first speaker, I will introduce Valentina Tomasini. She's an associate professor in the Department of Neuroscience, Imaging and Clinical Science in the University of Chieti Pescara in Italy. And her talk is about predicting the profile of increasing disability in MS using MRI.
Thank you very much. Thank you to the chairman, and thank you to the organizing committee for inviting me to talk to you today. Good morning, everyone. I'm going to talk about, sorry, I'm not sure whether there is a way to keep this somehow. Do you hear me? No. Anyway. So thank you, and thank you for inviting me to talk about the relationship between MRI and disability in multiple sclerosis. I have nothing to disclose with regard to the subject matter of this presentation, and I would like to start with a premise. I'm going to talk about disability and MRI, and I would like to specify what I mean by disability. Telling you what I think it is and what I think it is not, the disability that we can, of course, relate to MRI. What we usually mean by disability in MS is an outcome of damage and a descriptor of current abilities, which is, I'd say a sort of shared thought of what a disability can mean. However, disability is not a static condition. because it is something that changes over time due to continuous remodeling induced by damage on one side and disability itself on the other side through maladaptation. And it is not a stereotypical response to damage because its expression varies based on the age of the patient, the sex of the patient as well, and the individual premorbid reserve. So it is highly individual. What I think that disability is the result of a process of response to damage that can be at least partially reversed by an intervention. It is the expression of an individual reserve that may vary dynamically among patients and over time due to disease-related as well as to patient-related characteristics. It is an indicator of disease severity rather than disease phase. Disability does not indicate a secondary progression or a primary progression. It indicates how severe the disease is. And it is a summary impact of MS on the patient's quality of life, or at least it should be. So, if we all agree that these are the dimensions of disability that can be predicted or should be predicted by MRI, the scope of my talk is to focus on disability in adult onset MS. That indicates, so I won't talk about pediatric MS or pediatric onset MS, disability that indicates disease severity rather than disease course. Sometimes the two, severity and disease course, coincide, some other times they won't. So I'm going to go over the next 20 minutes or so through my talk, asking questions and trying to provide answers to these questions. First of all, can MRI predict disability in MS? Well, it's a quite obvious question and has a quite obvious answer, because otherwise we wouldn't be here. So the answer is yes, but for this specific question, I cherry-picked a few evidence out of a bulk of evidence just to make a few points. What aspects of disability can MRI capture in order for MRI to be able to predict disability in MS? What MR measures can best predict disability in MS? Is there one measure? Is there, I don't know, are there two measures, a combination? Can disability be predicted entirely by MRI? Can we just see the MRI of the patient rather than the patient itself or himself or herself? So let's start with the first question. Can MRI predict disability in MS? As I said, I cherry-picked a few evidence, so don't get offended if I didn't mention, very relevant evidence that is obviously underlying what I'm showing here. So let's start from the hallmark of MS, white matter lesions. We know that white matter lesions and their location predicts long-term disability. This is a paper by Catherine Dalton from the Queen Square. It's a famous paper where she shows that the lesion location in the white matter is associated with the subsequent development of disability after 20 years from a clinically isolated syndrome. And she also shows that what makes the difference, or what seems to make a difference between milder and moderate/marked levels of disability is the location of lesions in specific parts of the brain, and specifically in the left internal capsule, or in the internal capsules anyway, and in the optic radiations. But also lesions and lesion locations in the grey matter can predict disability over the long term. This is a piece of work from Massimiliano Calabrese, who shows that about 38% of patients with EDSS progression that is not related to relapses, after 5 years of follow-up, show high numbers and volumes of cortical lesions at baseline, higher rates of cortical lesions accumulation, and higher increase in cortical lesion volume. All these factors are associated with worse disability after 5 years. And to this, it does not contribute the amount, the volume, and the number of white matter lesions, suggesting that the cortical lesion load, volume, and number is associated with progression of disability over a 5-year follow-up. Brain atrophy obviously is a major star in the world of relationship between MRI and disability. This is a very old paper, I'd say, more than 20 years ago, but it's one of the first who showed a clear relationship between brain volume, and here it was quantified as infratentorial-supratentorial brain volume ratio, that is significantly associated with an EDSS score. So the worse the patient is from a disability point of view, the smallest the infratentorial volume is going to be. And more recently, Veronica Popescu has shown that whole brain and central atrophy, as well as white matter lesion volume change, can predict, again, disability and also disease severity at 10 years of follow-up. But grey matter atrophy can predict also long-term disability at 20 years. This is again a famous paper by Fisniku, who shows that grey matter fraction and independently T2 lesion load can predict EDSS at year 20. However, grey matter fraction seems to be the strongest predictor of this change. And only grey matter fraction can predict another form of, or another measure of disability, which is captured by the MSFC score, suggesting that grey matter atrophy reflects disability probably to a greater extent than simply looking at white matter structures, atrophy, or lesions. The spinal cord. Well, Mara Rocca has recently shown that what we knew, but she did it in an elegant way, showing that spinal cord lesions can predict clinical worsening over time and over a period of 5 years. And in particular, it can predict, it's the common denominator, as you can see, across the disability milestones. So it is able to predict the EDSS increase, the EDSS milestones, and also, obviously, which is sort of related, the evolution to secondary progressive MS. There are other factors as well, and they depend, obviously, on the level of disability the patient is at. Clinical worsening is also predicted by spinal cord atrophy. Again, atrophy is relevant. Here we have a strong correlation between the cord area on the y-axis and the EDSS on the x-axis, as we would expect. Reducing the cord area increases the EDSS levels. So at an EDSS of 3 and at an EDSS of 8, there is an average reduction in cord area of 12 and 35%, which can be quantified in this. Again, this is probably one of the first studies by Losef on atrophy. MRI can also predict disability evolution on treatment. We know that if we quantify during treatment, this specific treatment was a moderate efficacy treatment, interferon beta at the time. If we look at the fate of these patients over time, we can identify at baseline some predictors of disease evolution. By disease evolution here I mean disability measured with a EDSS. And disability is not able only to, MRI is not able to predict only the fate of patients in terms of disability, but also in terms of relapse occurrence. Obviously, these are active patients. And the interesting thing, I think, is that MRI can also identify and somehow predict, to a certain extent, not only the response to treatment in terms of disability evolution, but also those patients who are partial responders, so patients who actually show some activity but without some subsequent relapses or EDSS worsening. And this is relevant because in the case of high efficacy treatments, where by definition patients at the start are highly active, this is important in order to persevere on treatment and wait for a response. MRI and specifically a combination of measures. Here we have a combination of non-conventional measures, microstructure, function, and let's say metabolism, CBF, can all contribute in task-relevant regions. We talk about recovery, so we have an experimental model that looks at visual-motor integration and inducing visual-motor changes to improve performance, while the combination of these measures contribute to functional recovery or proxy of functional recovery, which is improving in performance in patients with multiple sclerosis, suggesting that MRI and some of its measures, probably not the conventional one in this case, but the non-conventional, the advanced measure, can actually contribute not only to define disability, but also increase, but also reduction of disability. So MRI, with my sort of cherry-picked evidence, can predict disability in MS, MRI of the brain, MRI of the cord, but what aspects of disability can MRI capture? For the purpose of the talk, I thought to divide, to look at what can be predicted or captured by MRI. And I think that these could be valid aspects that can be predicted. The risk of disability development, the risk of disability worsening, the mode of disability evolution, which is in a way the profile of disability increase, which is back to my title in a way, and the determinants of disability. We all know, so I'm not saying anything new to you, that MRI is able to capture tissue damage, dysfunction, recovery, systems level, let's say plasticity, and maladaptation. So let's start with the risk of disability development. Here we have to go back to the risk, to the radiologically isolated syndrome, where we can see that asymptomatic spinal cord lesions can increase the risk of clinical conversion, so moving from risk to CIS, a risk that is independent from brain lesions on the MRI. But when we develop CIS, so in patients with clinically isolated syndrome, MRI can predict the conversion to MS. In this evidence, we have patients who will develop a relapse, or here there is also the development of new T2 lesions. Well, at baseline, they have higher number of, or a higher volume actually, of T2 lesions and activity, gadolinium, and they have smaller volumes of the brain and altered measures of tissue integrity. In patients who actually have MS, obviously we can look at what will happen, or we can predict what will happen in the future. We've seen the evidence so far. What I think is interesting, though, is that different in MS, so in patients who have already a diagnosis of MS, different disability levels present with different predictors of disability worsening. And in particular, brain central atrophy in minimally impaired patients, lesion volumes in moderate impaired patients, relapse onset, and whole brain atrophy in primary progressive MS, so here I'm introducing the course of the disease, can predict disability evolution over 10 years. Same applies to the grey matter, where different levels of disability, mild and moderate, show some thinning of the frontal and temporal regions, whereas higher levels of disability have also the involvement of motor regions, as we would expect in a way, suggesting that focal cortical thinning varies according to disability levels. MRI can capture the mode of disability evolution. Here, I will briefly mention a piece of work published by Dr. Eshaghi, but I won't dwell in it really because Dr. Eshaghi will be here. But what he has done, he has basically identified some biologically informed subset of a whole big cohort of patients with multiple sclerosis, and identifying these three groups. Lesion-led, so patients where predominantly the feature is lesion, predominantly the damage is in the white matter, normal appearing white matter, or in the cortex. He saw that the lesion subtype, which is shown here by the blue line, has a faster EDSS evolution than the normal appearing white matter-led and the cortex-led MS subtypes. And this same subset, shown always in blue here, is the one that shows the largest reduction in the rate of EDSS worsening with treatment and shows the significant treatment response. MRI can also predict different aspects of disability. So far, I've discussed disability as a whole, as a summary measure, but disability is much more complex, as you all know. So specifically, MRI is able to predict also disability that occurs in different domains or functional systems. Here is the motor system. And here is the expanded disability status scale, the Berg balance scale, the time up and go, and the MS walking scale. In this study, functional connectivity and gray matter volume can predict motor disability for all the 4 scales. And in cognition, we have a few more evidence, probably. Here we see that 2 structures that are relevant for cognition, so the mesial temporal lobe and the deep gray matter structures, explain different aspects of memory performance in patients. And we see that atrophy of the deep gray matter structures can affect specifically new learning and acquisition, whereas damage to the medial temporal lobe affects mainly the retention of recently acquired information. MRI can also show reduction in the hippocampal volume. And we know that hippocampal volume is decreased in MS. Looking at different levels of disability, which coincides with different course of the disease in this case, so EDSS-2 more or less and EDSS-5, we have a difference, okay, between or among these groups compared to controls. And also, in patients with lower levels of disability, we see, looking at the hippocampal region, selecting volume loss in CA1 in the region, the yellow region, in the relapsing or lower level disability patients, and the same applies even more to the higher EDSS levels or secondary progressive levels, who show, by the way, also a spreading of this effect in other regions of the hippocampus, as we can see here, suggesting that selective hippocampal atrophy is associated with different disability levels. MRI can capture the determinants of disability. We all know that MRI can capture damage. And here I report the evidence that I've shown previously. So the initial relationship or the initial study showing a relationship between brain atrophy and EDSS, simply because in this initial paper, quite old now, the authors report, by Andrea Paolillo from Rome, the authors report also the correlations between the MR metrics. These correlations show or suggest an interrelationship between metrics, which is nice, not just statistically. It is of interest because they suggest that there is an underlying pathological mechanism that is at the basis of clinical disability, and that these mechanisms can be quantified by imaging, even just with conventional imaging. MRI can capture tissue dysfunction. This is just an example that will recur later, where we have a cohort of MS patients followed up with functional MRI to look at a proxy of plasticity. Okay, let's take this as a proxy of plasticity on the Y. It's training-related signal changes. The cohort of patients before starting a treatment has a change in plasticity that it is different significantly from healthy controls doing the same task, suggesting that there is a difference in brain plasticity in inflamed patients when compared to healthy controls. Looking at what can explain this difference or these differences that we see in functional MRI, so differences that we see in brain plasticity, we can look at cerebrovascular activity, at what happens in the tissue itself, so at the capacity of the blood vessels to alter blood flow to brain tissue in response to the stimulus, so how well the tissue receives oxygen and nutrients from the blood. And we can see, using a breath-holding task, that compared to healthy controls, patients have an impaired cerebrovascular reactivity. MRI can also capture this. MRI can capture, for example, the fact that the tissue of patients with multiple sclerosis functions less, probably, and therefore demands less nutrients or oxygen, at least, for functioning. So we have examples here of cerebral blood flow, oxygen diffusivity, oxygen consumption, and oxygen extraction fraction. And the combination of these measures suggests reduced demand of oxygen by the brain tissue. MRI can capture that as well. MRI can capture tissue repair. This is work by the Rome group, Luca Prosperini, where a group of patients with multiple sclerosis undergoes a training with a Wii balance board to try and rehabilitate balance. And what Luca found was that in the cerebellum, so a structure that it is definitely relevant for balance, a measure, fractional anisotropy and radial diffusivity, actually change over time with the training and changes in a way that correlates with improvements in balance, suggesting that training can induce white matter plasticity, promoting clinically relevant myelination-related processes. And we can capture that with MRI. Going back to the slide I've shown you previously, this is just to make a point that MRI can capture also tissue function restoration, not just dysfunction. And using a medication, we can reduce, okay, or we can try to, let's say, sort of normalize, forgive me if I use this word, which is quite dangerous, but we can try and normalize brain plasticity, or the proxy of brain plasticity that we use, but going back almost to the levels of normals or healthy controls. Same applies to what happens in terms of cerebrovascular activity, where we can see that with reduction of active scans or activity as gadolinium-enhancing lesions, we can see an increase in cerebrovascular activity in the patients. Again, forgive me, a sort of normalization, okay? And MRI can capture that. And finally, we can capture tissue maladaptation and its restoration, partially at least. Here we have a work done by Esini Reggie in Oxford a while ago now. It's, in my view, it's a beautiful work where she disentangles the effect of impairment from the effect of disability by contrasting in a clever way different groups of patients with different levels of brain damage and different levels of disability. And what she finds is that what happens in the brain, this is functional MRI again, is that regions normally involved in higher motor control and learning in the normal brain are actually involved in MS patients for performance of simple tasks, simple hand movements. And what we found always in Oxford was that when we try to, I'd say, guide more than recover the function of the hand, because this is not obviously rehabilitation, it's an experimental setup, we can see that there is a reduction with improvements in the same areas. So definitely, MRI can capture lots of things that regard the function of the brain, the structure of the brain, the metabolism of the brain. So, is there a single measure or a couple of measures that we can use and can be the sort of magic wand to predict disability in MS? I think that, it depends. So we want to look at disability, but we have different perspectives on the disability. Or we can have, it depends on what we want to use to measure disability in terms of MR measures. And if we want to look at all the various aspects of disability, through damage and through MRI, we need to go beyond conventional imaging, as we all know. Perhaps we have to go also beyond MRI, as we will see perhaps later. And here is just to make the very well-known points that we have to look at non-conventional imaging if we just stop at MRI to look at the extent of damage, characterization of damage, improved characterization, and consequences of damage. And so here is just a list which obviously misses lots of different methods and metrics, but just to see what MR correlates could be that could be useful, at least to start a characterization of imaging. I marked the first 4 in red, simply because I want to spend a couple of words on them. First is for diffusion tensor, magnetization transfer imaging, and myelin water imaging, looking at tissue integrity very carefully. We couldn't find in the white matter, we couldn't find a single measure that was alone more sensitive to damage than other individual metrics, suggesting that perhaps they provide complementary information on tissue integrity and at least at the state of the art when we measured them and when we used them, and with the methods we used and the acquisition we used, perhaps the combination could be more helpful to define tissue integrity. Here, I won't go into the details because there are experts in the field who will talk to you shortly. But just to say that susceptibility-weighted measures, derived measures at a lesional level, and we'll see in the normal-appearing white matter as well, can contribute significantly to predict, in this case over 12 years, and these are iron limb lesions, can contribute to predict disability in a way that can be also, to a certain extent, quantified. Here, for example, the authors talk about 4 or more than 4 iron rim lesions. And the authors suggest that they can have a great impact on disability, probably greater than the white matter, the white matter lesion number and volume. And this is in the microstructure. This is in the normal appearing white matter, where QSM shows a relationship, a nice positive relationship with a delta change, with a change in EDSS worsening over a period of 3 years. Suggesting that imaging cannot just predict disability, but can also predict the risk of early disability progression or evolution. I couldn't at least identify a single measure that can answer the question, the best predictor of disability. So the next answer that spread to my mind was, can disability be predicted entirely by MRI? Here, I think that MRI promises to inform biologically the phenotypization of multiple sclerosis. We have a bulk of evidence that suggests that or supports that. However, we have to take into account what we want to measure, which is, in my understanding, not imaging for the sake of it, but disability, to help patients. And so we know that, I really like this paper, this is why I put it here, and we know that we are not, as doctors, very good at estimating the overall quality of life of the patients. This is an old paper by Rothwell. So efforts have been put to improve the ability to detect and fully depict disability through patient-reported outcomes, PROs. So I put this study here so that it can be also a source of discussion, if you like, because in this paper they perform a qualitative study on what they think a mass neurologist, this is a Danish paper, a mass neurologist think of PROs, whether they will advance somehow our ability to capture aspects, useful aspects of disability. And this neurologist, this set of neurologists actually says, yes, they are possibly valuable, but not without challenges. In fact, we all know that while on one side, these PROs bring forth otherwise hidden information on the patient's health status that we cannot in clinic detect with EDSS, there are some barriers. The first barrier, I'd say, is probably that various MS-related impairment may compromise the validity of PROs reported by patients. So here I give some example, and I'm going to the conclusion of my talk, of possible useful step forwards. Obviously, this is not conclusive, but just ideas. In my view, to improve the predictivity of MRI, we should work on MRI, and possibly we'll see definitely also on other methods of acquisition, perhaps revealing novel aspects of pathology, trying to profile the patients better, and looking, which is already happening anyway, at a phenotypization that is biologically informed. This is just an example of what we are working on at the moment. Also, I think that we should try at the same time to improve the way we measure disability. It is always difficult to decide whether to use summary measures. For example, for imaging, very often it's very useful to have a summary measure of disability, or to look at different domains, and so having measures that are domain-specific rather than global measures of disability. We also have to work on measures derived from the patients, not reported necessarily by the patient. And I think that we have to look at the patient in the world, not in clinic. So it would be nice to develop measures that are ecologically valuable rather than simply clinically or neurologically valuable. And here are some examples on what we are working on at the moment. In conclusion, conventional MRI, as you know, can predict disability over the long term. Non-conventional methods can extend this predictive power and can improve also the pathological specificity of this prediction. Different methods or metrics are often complementary to each other because they can, describe together pathology as well as its functional impact. An appropriate combination of different methods and metrics, and here I include also possibly measures that are not necessarily MRI, is likely to improve the predictive power of imaging. And some aspects of disability, I think, still remain elusive to MRI. So improving both the characterization of disability and the quantification of damage and dysfunction is likely to strengthen the predictive power of imaging. So I have to acknowledge the work of several people in Oxford, in Rome, in Cardiff, where I was before, and now in Chieti, and my funding bodies. And I thank you very much for your attention.
Thank you very much for this nice presentation. So is there some question from the audience? And if you are looking at the talk remotely, you can also ask your question using the chat, and we will read them.
So you show, so far imaging has been used like in a group level way. How do you envision using what you show for individual patient stratification? Which one of the biomarkers you are showing do you envision will be, useful in the clinical setting, in decision making, or in prediction? Yeah, difficult question. Just
So the straight answer, Martina, is I don't know. I think that the problem is twofold. So on one side, we have to ask what metrics, with all the issues around that specific metrics, the way we measure and so on, what metrics is more promising? And my answer would be, I think, a combination of measures. At least the more I deal with MRI, the more with different measures, function and structure, the more I think that there isn't really one that works for everything. No, yeah. And I really think that there are profiles, as the word I used earlier, that can be identified. And the second part of my answer is, in this respect, I think that probably machine learning approaches could be helpful. So to classify or cluster even when we don't know exactly what features are relevant, to identify profiles of patients. There are some studies, actually, I can think, in my world, which is mainly a recovery and plasticity world, I can think of single case publications. One, for example, from Aizini Reddy in 2000. She looked at functional MRI, looking at individual cases, actually one patient, and looking at recovery. And she could follow up recovery using, again, functional and structural imaging. So she didn't use just one. And actually, the structural imaging she used was a spectroscopy. So I'm not sure whether I answered your question. The summary is, I don't know, but I think that combinations of measures and the measures you'll talk about, I think, could be very promising in this respect, but you'll tell us. And probably novel statistical approaches can help us also to rethink of patients. The problem is that so far, the difficulty I have in answering your question is that so far, we've been used to look also with MRI at patients in ways that put a label on the patient. So rather than seeing what comes out of the patient, like, for example, Arman and Shaggy tried to do, we've always gave patients labels, exactly as we do with the EDSS. So now with the attempt to phenotype patients biologically, perhaps we can gain more information that can be helpful to answer your question. So I'm sorry.
Thank you very much.
Thank you, Bruno.
I have a question about blood flow and cerebrovascular reactivity. This has not been so much studied in the field of MS, but there are strong modifications. In your mind, what are the mechanisms underlying those changes and their reversibility? Are they only linked to the inflammatory environment, or do you think there is something else that we should pick up with these techniques?
I think that I'm not sure whether we can pick them up with these techniques. So perhaps other techniques would be helpful. So I think that it's a mixture. Definitely there is an inflammatory milieu that it's reduced and not entirely captured by lesions necessarily, by the lesions we measure with conventional MRI. And that contributes to change cerebrovascular activity either in naive patients or with the restoration in treated patients. I think that there are some cell types that are particularly interesting. So, for example, the astroglia is particularly interesting with regard to the cerebrovascular activity, and that perhaps is not easy to study, but the function of astroglia should be looked at. Has been looked at partially in NMO, but in MS only partially. There are just a few groups. It is true that is not looked at, fully. There is evidence, but is sort of scattered here and there. Yeah, not sure whether I answered your question, but.
Thank you for the excellent talk. I've got a question. So we all working for a long time to take some advanced MR parameters to capture the different phenomena. But the real problem is to move to the really individual aspects. Is to get norms and to get, let's say, lots of data that can be used with these advanced techniques on a multicentric approach. So what technique do you think that we will be able in the next future to use in a multicentric way without, so not taking into account T2, T1. So there are some multicentric approaches with diffusion, but it's also considering, for example, the functional aspects, the spectroscopic aspects. What, to your mind, be the next possibility?
So thank you, Jean-Philippe. So I'm biased because I'm interested in specific aspects, also imaging aspects. I've become more skeptical about bold fMRI, if I can say, simply because it is it's a summary of lots of things that are happening in the brain. Although it's a measure that has been demonstrated to be useful in multicentric studies, can tell us something, but cannot really tell us about mechanisms. And you can argue that MRI cannot tell us about mechanisms, but BOLD has been used. So there is, on one side, measures that have been used and can be used multicentrically to look at function or structure. And in this regard, definitely bold fMRI is useful on a functional side, and diffusion, I think, is useful on a structural side. Particularly, I think that looking at diffusion in the cortex would be very nice, and myelination in the cortex and this type of work. On the other side, I think that probably it is also helpful at the same time to investigate, and that can not necessarily be done multicentrically, some mechanisms. And for that, probably you don't need massive numbers. You need proof of concepts. Studies like what we do using perfusion and measures derived from perfusion and BOLD to look at oxygen, to look at the tissue metabolism or physiology and so on, cannot be at the moment easily done everywhere because they are under development and they require a lot of post-processing and sometimes, if I can say, creativity. So at the moment they are not ready, but I think that we should move at the same time trying to collect data and combine data from different centers, and for that we have to use some qualified measures beyond conventional imaging. On the other side, I think that they are still very valuable single center studies where you look at specific questions that have to do with the way the brain functions or is structured.
Okay, so you better think that for a personal approach, it will be more single centers, and then when you get the methodology, perhaps to disseminate the way to do it, to get something on each center that allows to follow the same procedure, but not perhaps mixing all the data.
Could be a way forward. Thank you.
So maybe I have one question. It's the same kind of question. So from your point of view, to extract metrics, different metrics from MRI in order to predict disability, at that time it's like too early to have recommendation to change the protocol in clinical practice in order to introduce other sequences and other quantitative MRI sequences?
I think that it is, and this is what we are, thank you for the question, this is something that we are doing as well. I think it is valuable to add new sequences. I mean, for example, work by Martina has inspired, and some of the sequences that can be added. They are valuable to add in clinical practice, not because necessarily we have to make a decision on them, but because if we don't add in clinical practice, this is my view, of course, we never get the feeling of what the relationship could be with the clinic. So we've added, for example, susceptibility-weighted imaging. And at the moment, the difficulty is also that to make a decision based on these new approaches, you have to have an exit strategy. So I measure something because I think is important and I want to get some experience on that specific imaging methods or metrics. But then what do I do with it? Once I know the result, what do I do? Do I have a treatment, for example, that can somehow be changed using that metric? So to answer your question in a sort of straight way is, I think it would be useful to add to protocols sequences that are more promising. What we do with it, whether we make a clinical decision, I'm not sure.
So thank you.
Thank you.
Is there other questions from the audience?
I managed to confuse everyone.
So if there is no more questions and there is no question in the chat, so maybe we can move to the next speaker. Thank you very much again.
So it's now my great pleasure to introduce Martina Absinta. Martina Absinta is a neurologist and researcher in San Raffaele Institute in Milan. You probably all know her. She has done a pioneer work using ultra-high field MRI to characterize all the biological features of MS lesions and their dynamics. So she will move toward the explanation about what can be done with susceptibility weight imaging to characterize some of those lesions and to stratify patients. Thank you very much, Martina.
Thank you very much to the organizer for the invitation to this meeting. I would like also to thank Valentina for the nice introduction, so I can skip a few things, my disclosures. So we all know now that clinical progression is a major unmet need in MS. In terms of biological understanding, possibility to prevent or treat clinical progression, and growing data, I mean, even the clinical phenotypes have been challenged recently, since growing evidence are suggesting that progression is actually starting from the beginning of the disease, but the manifestation, the clinical manifestation are occurring maybe later on, a certain point, so they manifest later. So if we want to think about the sort of neuropathological framework of MS progression, we need to understand that we have a shift from a localized acute injury and then to more widespread inflammation, compartmental inflammation and neurodegeneration. And here I try to summarize according to the topography. So we have definitely understand that it's important how the lesion in the white matter behaves. So in terms of unresolved chronic inflammation in some lesion versus remyelination, of course. We know now from several years what's happening in the meninges and the meningeal inflammation, cortical demyelination, but also a much more widespread damage. I want to underline the synaptic pathology occurring actually pretty early in the course of the disease, and it's clear that this can affect long-term the functionality of the cortex. The same can apply to the basal ganglia with the thalamus. Again, occurring, the damage can be seen even in MRI in pediatric MS cases, for example, the spinal cord pathology, of course, and a more diffuse white matter inflammation. So all these features need to now be taken into account with time as a variable, not only in terms of accumulation of this type of lesions or damage, but also in the context of aging immune system and also central nervous system aging. So I think that in the next few years we'll see more about the biology of aging and the complex interplay with MS pathophysiology, because we need to think about MS as an evolving inflammatory disease with inflammation playing different roles at different time over time. And as Valentina was mentioning, there are, of course, over time failure of the compensatory mechanisms in the cortex in terms of functional reorganization. So for this presentation, I will focus, as you can imagine, on and the talk was about susceptibility and the role in stratification, so I will focus mostly on the chronic inflammation and the chronic active lesions. So also because I've been working on this in the last 10 years. So we know already that these chronic active lesions from a pathological point of view are one of the possible types of chronic lesions. So these are chronic lesions with a demyelinated core with a different degree of axonal damage and loss. But the typical feature is this dense inflammatory infiltrate, the chronic active edge, here the leading edge, mainly composed by microglia, macrophages, inflamed astrocytes. But the typical feature that is different from other types of lesions is the ion accumulation within the myeloid cells, so both microglia and probably macrophages. Two big pathological studies have understand that this type of lesion is frequent, 30% of plaque autopsy. And these initial studies with autopsy cases, they underscore the prevalence in progressive MS cases. So until recently, it was not possible to visualize this type of lesions, at least with MRI. But the advent of these susceptibility-sensitive MRI sequences made this more easier, at least, and this is because, as you know, susceptibility-sensitive sequences are able to measure or to see the magnetic susceptibility shift in the tissue, and because ion is extremely paramagnetic, can be easily seen as this dark edge here. This is a 7 Tesla image, but now we can see this type of lesions at 3 Tesla and also 1.5 Tesla MRI, so bringing this to a more clinical settings, of course. So we call them paramagnetic rim lesions because of this paramagnetic signal at the edge that is really mimicking the macroscopic structure of the pathology. So far, 11 studies have validated the biomarker, so in about 160 lesions. So today we can say that this biomarker is able to see at least a subset of the chronic active lesions, so those with the iron, actually. And there is one study from Susan Gauthier that did also cross-correlation between the MRI and the TSPO PET biomarker. So in terms of, so here we come with the confusion, because here, in terms of sequences able to see these paramagnetic rim lesions, there are several of them. We did a workshop last year with the NIMS consortium, so the American consortium, try to understand which sequences are sensitive to the chronic active lesion, which one we should use. So there is no consensus at this point. And you can see there are several sequences away to see this type of lesions, 7 Tesla on top, 3 Tesla on the bottom. And there is also the possibility to quantify the tissue magnetic susceptibility shift using QSM, that is the quantitative susceptibility mapping, as shown here and here. Also for the QSM, there are several tools. So no one is the best one at this point, but the important thing is that we are able with SWI sequence or even SWI PI sequences to see them also 1.5 Tesla. So that's, I think, is an important feature. So regardless of the sequence you're using or the magnetic strength, here we pull together some data from 31 published study, and you can see that these type of lesions are specific of MS, so very rarely see in mimics and non-inflammatory condition. The only exception is the Sousa disease, but I mean, there are 11 cases studied, so I mean, we need to think more about these data here, but overall I will say that the paramagnetic rim lesions are specific of MS. And they are frequent, so about 50% of our patients, they have at least one visible. And again, remember that the imaging biomarker is showing just a subset of the chronic active lesion, probably in pathology, okay? And we have a little bit higher proportion in the progressive MS cases, and this is in line with the pathological studies I mentioned you earlier. But what the important thing, and here we're coming with the stratification topic of this meeting, is that the relapsing remitting MS patient harboring several of these chronic active lesions, and I mean, one possible cutoff is these 4, but you know, it depends, and you know, in the future study, this cutoff might change, of course. But using the cutoff of 4, more than 4, we were able to see that in relapsing remitting MS patient with several chronic active lesions, there was an association with worse prognosis in terms of more aggressive clinical and radiological course, and also lower cognitive performances. And other 2 independent groups using short-term and long-term longitudinal data show that having this type of lesion is a predictor of disability after 3 years or 9 years. So this is quite encouraging, but now we need to ask the question about, so how do we explain having, you know, few of these chronic active lesions being predictor of disability or progression? So we try to understand the reason, of course. So first of all, these lesions do not remyelinate. Here you can see the transition from an active lesion with the opening of the blood-brain barrier to a chronic active lesion. Now the barrier is closed, but you can still see the rim over time. This is persistent, so lesion with this behavior, so with this persistent rim over time, or bigger and more hypointense on T1 weighted sequence, meaning that they were more destructive. And this was further confirmed by a multiparametric study led by Cristina Granziera in Basel, where they use NODDI, and you can see here the yellow dots are these paramagnetic rim lesions, and they have lower neural dispersion index and also myelin water fraction, suggesting these lesions are very destructive. So this is something to keep in mind. But then, if we are going back to the biology, this inflammatory infiltrate at the edge is exerting damage to the periplaque, so the surrounding, supposedly spare white matter. And indeed, there is a clear, slow, and smoldering demyelination of the edge. With this in vivo to post-mortem study, we follow lesions over time in this specific case. And you can see that the lesions here are from 3, they're becoming confluent over time without new breaks of the blood-brain barrier, of course. Age 59, the patient died, donated the brain. And so we start doing, the imaging post-mortem, 7 Tesla, you can see the rim, and this is exactly this piece of tissue. And we confirm that this lesion was chronic active. So the periplaque is really unstable surrounding these chronic active lesions. So this is another piece of information. But the most important in terms of irreversible, if you want, disability is probably the axonal damage. So you need to think that this type of lesion, this chronic inflammation, is persistently over time damaging axons. And we know that this leads to Wallerian degeneration and eventually also neuronal damage and loss. So this is irreversible in a human brain. And from a pathological point of view, it's clear having this axonal end bulb full of APP. This is amyloid precursor protein, but just to say that you can use other axonal proteins. So when an axon is transected, you can see this type of axonal end bulbs. And again, this is in collaboration with Cristina Granziera in Basel. We did this study looking at the serum neurofilaments levels in non-active MS cases. So, and you can see that the neurofilament light chain, the elevation of them is explained by the number, part of the elevation is explained by the number of chronic active lesions more than other factors known to be involved in serum filaments light chain elevation. These data are, of course, age-corrected. So I want to bring you to this conclusion that there is this association. So maybe, accelerating the resolution of this paramagnetic rim might be useful and might indicate that we are somehow affecting the chronic inflammation in this type of lesions. So the provocative question is, can this type of lesion be cured? And there is a piece of evidence that says that this biomarker is dynamic, actually, because in some types of lesion, we can see the biomarker going away. So the rim and the iron then is not a brain tattoo, but is actually very sensitive to the underlying pathology. So when the microglia with iron is going away, we don't see anymore the biomarker. So we estimated in this 7 Tesla longitudinal cohort over 10 years follow-up that, the median survival of the rim was 7 years. And this was also, similar data were shown also by the group in Vienna. So this is good because now we can think about using the PRL as a biomarker. And we can think about how to measure a possible treatment effect on this type of biomarker. So we can think about different potential measures. We can, if you think about in a clinical trial setting, you can think about, measuring the number of disappearing rims over, the follow-up, or you can measure, as I said, the susceptibility shift. So with the QSM, you can measure the PRL size because of this enlargement or shrinkage of the lesion that is associated potentially with this smoldering demyelination, or also looking at the core of the lesion to see if there are any signs of remyelination or further axonal damage, myelination damage. So the bad news is that we don't have so many data so far about the role and the effect of the current disease-modifying treatments on this type of lesions and so on chronic inflammation, let's say. Using cross-sectional data, you can see that patients with several rims are seen in patients treated with very highly effective disease-modifying treatments such as B-cell depletion, natalizumab, and so on so far. So, but we don't know from a longitudinal point of view. And there are studies looking today at the effect of current disease-modifying treatments on this PRL. I'll show you 2 of them. So this one is published from Susan Gauthier group, and they compare the effect of the dimethyl fumarate versus glatiramer acetate over time on this type of lesion, and they use the QSM, so the quantification of the shift as the outcome measure. And according to their data, so I mean, the study is not very big, but is encouraging because it seems that the dimethyl fumarate is accelerating the resolution of the paramagnetic shift in this type of lesions in comparison to glatiramer acetate. I say is encouraging, need to be replicated, of course, and also if you look at the individual trajectory, you can understand that maybe the follow-up is a little bit different in the 2 arms, and then there are definitely lesions that are driving, I would say, the trend. But again, it might make sense. Dimethyl fumarate is affecting the NF-kappa B pathway, so might have sense. It would be nice to replicate this data. We recently presented at ECTRIMS our study looking at the effect of B-cell depletion with anti-CD20 antibody treatment. This is retrospective. We added a control cohort from untreated MS cases, and also we added the comparison with non-PRL in comparison to the study from Susan Gauthier. And if we think about our, let's say, primary outcome measure, so the disappearance of the rim over the follow-up, that in this case was 2 years as a median, but we have data until 5 years now. We had only 1 PRL disappearing, but in the untreated arm, so doesn't count. So we measure all the other measures, so the volume, the QSM, and the quantitativity one as a global measure for tissue destruction within the core of the lesion, and using a mixed model with random lesion and participant effects, we didn't see any effect from the B-cell depletion on this type of lesions. So, I mean, this is maybe in line also with the reanalysis of the clinical trials where a percentage of the patients still progress, so are experiencing the so-called PIRA, even in very highly effective disease-modifying treatments such as B-cell depletion. So there are a few proof of concept clinical trials going on to use this as biomarker for treatment effect, and also they are using now as an exploratory outcome in clinical phase 2 and phase 3 clinical trial, and for sure they are doing for the BTK inhibitors. So I would like now, so this is where we are going now. There are 2 aspects about this biomarker. So we would like to use for individual patient stratification to say this patient might, in 15 years, have the risk to accumulate disability and progress. But at the same time, we want to use this for understanding treatment effect on chronic inflammation. And so we decided to perform a very deep neuropathological study on the chronic active lesion to understand the mechanisms operating at the chronic active edge from a biological point of view. And for this reason, we implemented the single nucleus RNA-seq approach. So the idea was to look also for new targets, potentially therapeutic targets, since the current disease-modifying treatment maybe are not so effective in modulating the compartmentalized chronic inflammation within the central nervous system. So I'll show you the study we did. You probably know what the technique is, but we dissociated the human brain tissue, frozen tissue at different locations, so the edge, the core, and the periplaque. We compare with control white matter from non-neurological controls, of course. So we used nuclei because this tissue is frozen, so we couldn't use cells. And what the technique is doing is providing the full transcriptome profile, so RNA full transcriptome profile for each nucleus. And here in this map, after the bioinformatics analysis, you can see that there are dots. Each dot is a nucleus, and we know the full transcriptome profile for each nucleus. And nuclei close by have similar transcriptome profile on this map. So now you can see that we have clusters, okay? So I want to make this story short because this is an imaging meeting, but what we did was to try to understand, first of all, the critical population of the chronic active edge, and then to understand how these populations are speaking to each other with the object to look for new pharmacological targets and potentially treatments. So here we reconstructed the glial interactome. And you can see, I mean, there are a few interesting things, I guess. So first of all, there are still some lymphocytes at the chronic active edge, mostly T cell and plasmablast, 75% and 25%, I would say. There are few, but according to the reconstruction, they're still able to drive some glial, let's say, expansion activation. These are the microglia activated population we call iron and foamy, because in this case, there was an upregulation of all the machinery and the ferritin genes, light chain, heavy chain, so on and so forth. These are very inflammatory cells. And this is important because it's related to our imaging biomarker, of course. But there are also a huge percentage of microglia activated with a foamy profile. So these are probably those cells that are cleaning and engulfed by the myelin debris and probably not able to clean enough, let's say. And so this is even facilitating the unresolved inflammation of the chronic active edge. And we have the inflammatory astrocytes. So looking at this network, we focused on the hubs of the network, so definitely the microglia activated and the astrocytes. And we immediately noticed that there were upregulation of the early complement genes, such as C1q and C3d. We even make some validation from a protein point of view. And in this setting, the C1q and C3d were, we think, at least not there to fix the complement, the antibody, to make the classical complement cascade to the MAC complex, but we think are behaving like inflammatory mediators. And we did 2 animal studies to prove that C1q in the microglia as a autocrine acting, probably, pattern. So it's very important for the microglia activation. So it's produced by the microglia, but is important for microglia activation because in a C1q conditional knockout for microglia, the microglia was not able to activate in early AE. And also we use a C1q blocking antibody in a late model, and also here we saw the reduction of the ferritin positive ion, so the ion microglia if you want, so suggesting C1q might be implicated in microglia activation and potentially also in the one with the ion that is the one we see, of course, with MRI. So there is a plan now for a clinical trial, but the drug is not easy to administer at this point. And so we'll see in the future if we will be able to do the clinical trial using the PRL as biomarker and testing on humans this aspect. So going to the last 2 slides, using this single cell data, we also try to perform a drug in silico interaction analysis. So we use the transcriptome profile of these activated ion-activated microglia, and we tested the known pharmacological compounds. And here you can see some of the hits. And so drugs that are potentially able to inhibit this kind of ion-laden microglia. But the interesting thing is that the majority of them have been already tested in MS. So it's not something very, very new, but probably with the wrong outcome measure. Not the wrong outcome measure. I mean, not an outcome measure that is able to show the effect potentially on the activation of the microglia. So these studies used clinical outcome measure or brain atrophy or new lesion formation that is not what this microglia probably is doing. So it's not involving new formation of new lesions. So it will be very interesting now to, test again proof of concept clinical trials or, small studies, try to use now these drugs against the biomarker for which we kind of know the underlying biology. So these paramagnetic rim lesions are, at this point, histologically validated biomarker for at least a subset of the chronic active lesion, probably not all of them, but those with a strong ion-laden myeloid density at the edge. And according to, let's say, the topic of this meeting, we think that they might represent a good opportunity for visualizing, of course, and monitoring the glial activation, the microglia activation in MS, but also potentially for stratification and identify patient at risk of early clinical progression. And in case we will have a drug able to, they will be candidate, of course, for a drug slowing down this type of chronic inflammation. Are currently used to evaluate the efficacy of the available disease-modifying treatments in treating chronic inflammation. That unfortunately at this point are really modulating mostly the peripheral immune system rather than what is within the central nervous system, I would say, and potentially testing new treatments and eventually new classes of agents targeting the glial activity. With this, I would like to thank you for your attention, and I'm happy to take your questions.
The talk is open for questions.
Okay, thank you very much, Martina. Wonderful. I have two questions, if I may. So, quick questions. The first question is, do you have any evidence with your work, the sort of non-imaging work, do you have any evidence that oligodendrocytes are actually just victims and do not participate in damage somehow? This is the first question. And the second question is, well, it's actually sharing a thought, if you agree. I was wondering whether in the view of personalized medicine, perhaps we should personalize the acquisitions also based on what we treat the patient with. So you showed that actually the use of CD20 treatment does not really substantially, in my understanding, change the lesions, the rim lesions. So would it be part, I'm wondering, and I ask you, would it be part of the personalization also, perhaps to vary the type, it's a bit provoking, the type of acquisitions also based on what we treat the patient with, so changing the target or the measure of the target based on the treatment. Thank you.
So according to the first question, the oligos are stressed, definitely there. But in terms of comparticipation, what we have seen that the OPC, so the oligoprecursors cells, that there should be the cells that are helping with the remyelination process. Actually, they have at least a subset of them. They have an inflammatory phenotype. So they, first of all, they put on the machinery for self-antigen presentation. So we saw upregulation of the HLA genes and also some of the genes that you usually think about for the immune system. There are a few studies done in the last few years using animal models in which they call these immune-like OPC. They seems to contribute to the damage instead of being able to differentiate and becoming oligo and myelinating oligos. So it seems that the cells that are actually should be beneficial and we often try to push differentiation to promote remyelination in this very inflammatory environment are maybe not necessarily doing their proper job. So I think we need more studies to understand the role of these immune-like OPCs. But this is kind of interesting in the optic that all the cell types are involved in this chronic environment, and so we need to think more broadly when we think about this type of chronic inflammation. And yeah, so thank you for your question. For the second type of question, in the optic of personalization, I think it will be great to be able to have treatments that can, you have a patient, you see there are, 15 chronic active lesions, so this patient may be, a candidate for treatment that maybe is affecting more the compartmentalized inflammation than, you know, but probably we need both. So definitely we need to shut down the peripheral immunity. And so in my mind, I think something that is behaving on, a drug is behaving on both compartments, or I don't have treatment.
Yeah, like
so
the BTK inhibitors and so on, which will come here.
I don't want to sponsor anything, so. So the idea is to, you know, or use, you know, multi-drug, or something that is able to affect both compartments. But definitely, so what imaging, I think, is showed us over in the last 20 years is that, first of all, you need to shut down new lesion formation. Because every time you have a new lesion, you are, and there is the breakdown of the blood-brain barrier, there are also lymphocytes. They are going there, and probably they are stuck there. So at the end, you have, because we can see still in the chronic active lesion, but also in some chronic inactive lesions, you have still some lymphocytes there. They might become resident, tissue memory resident, whatever. I mean, there are theories about what they are doing there. But so first of all, shutting down the new lesion formation, and I think we have several treatments now that are very able to do that. But then we need to shut down a little bit what's happening within the central nervous system, I guess.
Thank you.
To further prevent.
Thank you.
Thank you very much, Martina. Wonderful talk. So I'm asking you a question with regard to your competencies, your expertise as an imager, but also as a pathologist. So in our TSPO studies, what we are seeing a subset of lesions which have TSPO binding, increased surrounding the lesion in the rim, but there are plenty of them, really a large percentage of lesions, up to almost 60%, that are homogeneously active. So they are characterized by a chronic inflammation that is really widespread inside the lesion. So I was wondering two things. First of all, in your experience as a pathologist, what do these lesions correspond to? Is there a phase after the acute phase where lesions are homogeneously active, and then some of them become rim-active lesions, or not, or we are missing something there? Second question, which is somehow related to this, why, or can you see actually with these techniques some lesions that may correspond to this type of lesions? Meaning, like, can you see like some iron inside the lesion itself, and what does it mean to you?
Yeah, so no, these are very important questions, because they are, the PET studies are, of course, I'm not an expert of PET studies, but they are definitely complementary to these susceptibility studies, of course. So first of all, the TSPO tracer, and you should tell me more about this. So they are specific for the microglia activation, but also for the astrocytes activation. There are some studies showing that TSPO can be expressed by both. According to my single-cell study, the TSPO, at least the transcripts, so the RNA, was much more expressed by the microglia than the astrocytes. But still, there are studies showing that it's also astrocytic activation that might elevate the uptake of the TSPO tracer. So that's the problem. So we are seeing in this homogeneous one, maybe, also an effect of astrocytes that are at a certain point filling out the center in terms of gliosis, but this gliosis might be a gliosis, dysfunctional gliosis, so with some kind of activation. So I don't know. So probably we need to maybe do some pathological radiograph studies with the PET to better understand this. So the other thing, this is also according to the Susan Gauthier study, what she saw as a lesion with a rim, the uptake of the TSPO was central, was not at the edge. So, and I don't know if it's a matter of resolution of the PET, and it's not, so only in a very big lesion you can see the rim, because you have enough space from the core and the rim to see that the tracer is just at the edge. But also in Susan Gauthier study, and we work a little bit with her also for the consensus statement we did with NIMS. We asked her, cases, to show us cases, and the majority of the rim lesion on susceptibility they have a central TSPO capture. So, so I think that definitely these are lesions with some or microglia or astrocytic activation. So maybe the PET is able to identify more of them than the susceptibility, you know what I mean? Maybe also chronic active lesions that are not so rich of iron, for example, at the edge. So I think it might be the time to have, you know, several comparative studies. So to my knowledge, the study from Susan Gauthier was the only one. There is someone in Finland is doing now the show extremes and stuff. But I don't have, at this point, my personal idea about the percentage of overlap between the two the lesions. Definitely when I agree about the evolution of the lesion. So we clearly saw the cutoff was at the time of the opening and closure of the blood barrier, where we see that the rim was persisting. But we need to think that these lesions are part of a spectrum. Even the chronic active and chronic inactive are part of the spectrum, and so you might see probably more in those late active, let's say, than we do with the rim. So this is what I can say at this point. So the mix astrocytic activity and the microglia activity, so they can, make you detect a little bit more. So in general, glial activity, that is in any case absolutely valuable because, and then issue about resolution and if iron is sometimes in the center, sometimes yes. Sometimes yes, not often, not according to my personal experience on the tissue, but you can see sometimes there are dots, even with MRI, with susceptibility, there are big lesions, sometimes with dots, and these are ion accumulation within also the center of the lesion, sometimes around the central vein, for example. So I think there is like a full spectrum. And definitely the MRI and the PET should be seen as complementary in providing this type of information about the glial activity.
Thank you for the beautiful talk. I was wondering, when you said that 1.5 Tesla is able to detect paramagnetic ring lesions, do you think that in clinical practice protocols we can be able to look at these lesions at 1.5 Tesla? And is 1.5 Tesla able to detect just some of the paramagnetic, all of them, the biggest ones? What do you think about that?
So as an experience now in San Raffaele in Milan, the routine for not just MS, but for all neurological cases is the SWI. So the standard one, so from the machine, from the vendor, so without changes, so it's taking like 3 minutes. And so looking at this data, we were able on the phase unwrap, so not on the SWI, the one, but the other image that usually they are providing, so the phase. We were able to see them quite clearly. And so, the fact that it is in the clinical protocol is of course, as you said, important for then using them in the routine and potentially in the future in the decisions. I don't know yet about the capacity of the 1.5 to detect all of them. I think that already MRI is able to detect some of them in comparison to pathology. So probably they will be, a little bit less performance than a 7 Tesla, okay? But still, if we are able to make, like criteria or guidelines for 1.5, then you see, maybe this 4, maybe it's 3. So it always enough to see 2 because they are the most, visible. So, but it's possible, and I think it's will be very easy because there are already the sequences provided by the vendors, so by the scanners. Because usually they are using these sequences for bleeding. So it's a sequence that's being used in the dementia fields, in the stroke field for very long, and we are using the phase because it's more sensitive to this less paramagnetic, because of course the deoxyhemoglobin is super paramagnetic. So I think it's a possibility for the future. Yeah.
Okay, Martina, thanks. Thanks a lot for the great talk. It's more a potentially provocation, but with clinical implication potentially. It's pretty frequent, I would say, even if it's pretty clear that the presence of paramagnetic rim lesions constitute an important prognostic factor. It's pretty frequent also to find paramagnetic rim lesions in patients that have relatively low levels of disability and are relatively stable during time, across time. Do you have any explanation of this phenomenon?
Everything is compensated until it's not compensated anymore. So if you have like, we have like CIS patients, radiological isolated syndrome patients, okay, pediatric MS patients with these rims. But the small demyelination and the slow axonal but relentless, axonal injury is then manifesting their effects when, the aging problems are coming up with all the other issues are summing up. So I would like to highlight that is, of course, cannot be considered, the chronic activity should not be considered the only disability predictor. So this should be put in place, as I show you in the initial slide, with all together, the cortical lesion, the spinal cord damage, the cortical, the synaptic plasticity, and all this kind of stuff. So I think that to make sense, I mean, how I explain to myself, this fine, patient very stable over, or at the beginning of the disease, they have these lesions, but I mean, if we are right, the effect should be seen after 20 years. And this is the two studies, at least, showing the short-term and long-term predictor effect of these lesions on disability. But again, if you use just one parameters, as Valentina was mentioning earlier, maybe is not enough. But should be, I mean, since it's easy to see on the clinical scanners, I think we can get used to use this over time and see, like spinal cord lesions, no? If you have a CIS patient with spinal cord lesion, I bet you are putting on high effective disease-modified treatment. So, in the same way.
Thank you for your great talk. As you were talking about spinal cord, I wanted to ask you, can we identify rim lesion in spinal cord? Is it possible to do susceptibility imaging on spinal cord? Because we know the importance of spinal cord lesion on the future population. And so has said Valentina for the kind of personalized treatment, future treatment. So
thank you. Yeah, thank you very much. This is a very important question. I took out a slide about this. So thank you for the question. So first of all, we don't know, I mean, there are chronic active lesions in the spinal cord from pathology. So someone says no. There is a preprint from De Luca in the UK. He did it's a preprint, so it's not published yet. So it's showing that there are chronic active lesions in the spinal cord. And actually, in a cohort of 92 autopsy cases, progressive autopsy cases, like 89% of the lesions in the spinal cord were having like an inflammatory activity, chronic active or even active. So if this is confirmed, I mean, it's quite powerful as a data, I mean, because we are measuring the brain, but of course the spinal cord is very, clinically eloquent. So first of all, I think we need pathological studies to further understand this point. and also in my group, we are now looking also at the spinal cord for this reason. In terms of susceptibility imaging, the spinal cord is very, very difficult. So the expert in the imaging will say, so to my knowledge, there isn't at this point evidence of the visualization of the rim in the spinal cord using these sequences. What I'm doing in collaboration with Danny Reich at the NIH, we are doing the postmortem first. So we have the fixed spinal cord, and we are doing the postmortem 7 Tesla to see if at least a 7 Tesla postmortem we are able to see something. And then if there is something promising, we will try to set up and create some sequences that are able to see also in the spinal cord. So at this point, there is a lot of unknowns in this topic, but I think it is extremely important, so it should be a matter of further research, of course.
I have two short questions. The first one, we can see a paramagnetic rim lesion in Susak syndrome also. Do we know what is the pathological substrate of this compared to MS?
So there are, what I think is that, so in the Susak's syndrome, those lesions in the corpus callosum are stroke-like, meaning that are probably related to the microangiopathy associated with this disease. And so I think is hemoglobin, let's say, degradation products that are stuck there, and for some reason they're looking like a rim. So if you see these lesions, they don't have a central vein, so they are not inflammatory as we think the MS lesions, so starting from certain vein, and then they grow, and then there is this persistent inflammation at the edge. But probably there are lesions that have more vascular genesis in terms of interruption of the flow, and then there is extravasation of probably hemoglobin products that are at the edge. So that's my personal explanation. But again, the Susak syndrome is quite rare, and we need more data. The 11 cases were done at 7 Tesla, and even the lesion is not like, completely round or ovoid as we see in MS, but with a little bit also of irregular margin. So my explanation is that there are hemoglobin products due to the small stroke-like.
And maybe, but it's a general question about the session. We have seen that most of the techniques are available at 1.5, 3 Tesla, or 7 Tesla. So if you want to stratify a patient in clinical practice, what are the arguments to go towards 7 Tesla instead of what we have to date? Would, rim positive lesion one argument to push to develop 7T, or other structural methods that would allow to better stratify? What is your opinion on the one on Valentina?
So what I've seen so far is that the 7 Tesla was able at the research level really to make things easily visible. But then we optimize the sequences to be able to see the same biomarkers, central vein and the rims, for example, at 3 Tesla and 1.5. So it was very important because it's very obvious, given the magnetic field and everything, was very obvious, at least for these susceptibility biomarkers, to see them at 7 Tesla. It was so obvious, then you say, okay, I want to optimize at 3 Tesla and 1.5. So I think the 7 Tesla at this point is, I think is very useful research tool. In terms of clinical tool, I think will be very viable for the clinical trials. Because if you want to see probably a not so large effect, like disappearance of the rim, but a reduction in a trial time frame that is 1 to 2 years, you probably need something that is very sensitive. You can measure, for example, the quantity, the QSM, in a very precise way. So at this point, instead of clinical application like every day, I think is research and clinical trials if you want to use this biomarker. That's my personal. And so you need to have clinical 7 Tesla to do clinical trials. but not like for, the yearly follow-up of your patient in the clinic. So my personal, maybe in the future everyone will have a 7 Tesla, that will be great.
Not
but
sure.
Today I see the use for this still research and...
Can I ask you a question, Martina? Thank you for the talk. So in line with this question, so of course the 70 has a greater sensitivity, and I was just wondering what this sensitivity, what is the gain of this sensitivity for the evolution of a lesion? So you said that there is a survival of a PRL lesion for 7 years. So this has been done at 70, 3T, and so we're going to see, of course, iron with QSM or susceptibility, but there are also other species that can be paramagnetic or diamagnetic. For example, zinc has been demonstrated to be also accumulated. So what do you think, so perhaps increasing the effect of susceptibility and also the spatial resolution, is it really important to follow the evolution?
Absolutely. From a research point of view, I think, the 7 Tesla is magic in this context. So it's really able to high resolution, high magnetic field to show you this kind of features. So I will definitely, sponsor 7 Tesla for everyone for research. But if we think about, the clinical follow-up of a patient, or the lesion follow-up of a specific patient in our, clinical setting, they will be very difficult to achieve. In terms of the other possible diamagnetic or paramagnetic substances, definitely there are other, way in addition to QSM that are coming up to a little bit, discern the different potentially, contribution and substances. So this will be a great field for further research, to disentangle or even potentially with the presence of zinc or other metals has been shown also in pathology. Claudio Lucchinetti did a lot of work with XRF and this kind of stuff to show that not only iron is there, but also other metals. So maybe with the algorithm, we will be able to discern those. A 7 Tesla will be the machine to do this kind of studies, of course. Yeah.
And what do you think about the design of your clinical study if you want to test your new targets, therapeutic targets?
So the clinical trial, that's is quite. I mean, I am quite involved in try to also with Maria Pia Sormani. So we have meetings to try to understand the design, because this is a new design, of course. So, and I was trying to highlight, possibilities in terms of outcome measure. So you can, over the follow-up, decide to, measure just count those disappearing. And I try to make a power analysis with that. Since in 2 years, the disappearance is a very rare phenomenon. A drug able to make, X number of lesions disappearing, just the rim, of course, just the rim disappearing, will be a very effective drug. And the arm, the number of people in the arm will be, I calculated, 16 per arm and 50-something lesions per arm. So, but because these are at the moment, we think this is a very rare event. So this disappearance in 2 years. So probably this drug doesn't exist. And so you need to think about other potential outcome measure to combine with, so QSM, so try to see if there is at least a shift in a good way, so less paramagnetic or volumes or other quantitative measures. But it's not easy to design a trial like that. The most important, the data we are in need now are natural history longitudinal data to power properly potentially these features and calculate the power. Yeah. But this is, ongoing.
So, okay, maybe it's the last question.
Quick answer.
Yeah, try to be quick. Yeah.
So thank you very much. Two quick questions. First one, you said that these iron rim lesions came from really destructive new enhancing lesions with this pupillary enhancement and larger volume. So do you think that maybe the lesion fate would actually largely depend on the baseline characteristic of these lesions, and as that above a certain level of damage, a lesion tend to do not resolve and become smoldering? This is the first. And the second question is, to which extent do you think that the MIMS activation is actually independent from the adaptive immunity, or is actually driven, like at least for a certain amount, by some adaptive stimuli, as for example immunoglobulin, like binding the Fs gamma receptor on microglia? Thank you.
You're making good questions. So I try to be super short, if I can. So in terms of, it's very difficult to, let's start with the second question. So the second question was about the MIMS activation is, still related to the adaptive immunity, so the T cell and plasma blast or the immunoglobulin being there, or is self-autonomous? I don't know. I try to use the data and use making virtual knockouts with the single cell data, so in silico analysis, to see what's happening if you're removing the lymphocytes in terms of glial activation. And of course, as we can expect, if you remove those lymphocytes in this virtual context, so, okay, making virtual context, thanks, of course, this will affect the microglia activation. But as I show you, it's much more complicated. So I would like to have a drug who is able to completely ablate the T cells or the plasma blast in the central nervous system to see what's happening in vivo. I think there is also a little bit of self-autonomous activation, and then the cross-talk with the astrocytes, and then and the OPCs. So the environment is very inflamed and complex. So if we have a drug that is able really to remove the lymphocytes from the central nervous system, I bet something will do on the rim. But I guess also because they are very, the microglia cells are very reactive to everything. So if you are still a lymphocyte producing interferon gamma, you will have the activation of the microglia. But these lymphocytes are few, and this rim is very at the edge. So even if when I look at the pathology, I can see some lymphocytes in the perivascular spaces, but it's not like a continuous presence. How can I explain, the fact that it's very at the edge, continuously at the edge? So I think that both. The first question was, sorry? The lesion, yeah. No, definitely. And there are one study at Penn University looking at the predictors. I think they will publish. They present already meetings. So they look for baseline characteristics of the acute lesion and which characteristics were predictive of the rim. Also, we did something like that. So larger lesions are, in any case, larger active lesions with the ring enhancement are more prone to become chronic active than nodular enhancement, for example. So definitely it's important. You're asking, underlying your question, there is the question, is important how the immune system at that point during the lesion formation is injuring the brain. I think it's important, but it's also important how the brain reacted to the injury. So if, for example, for some reason we are looking at the GWAS and the SNPs, your microglia, because you have your variants, is a little bit more reactive, the injury, the same injury, will produce different effects in different brains at different age of the patient for comorbidity. So it's very complex, but I think you got the point. Thank you for your question. Okay?
Okay.
Thank you.
Thank you very much.
Yes, thank you. So thank you for these night talks. It's now the time for the coffee break, and we will start the next session at 11 and 10 minutes, I think.
to talk about quantitative imaging of disease mechanisms and stratification. But before starting, I would like to have a word for my colleague Olivier Mokomovic. I don't know if some of you have known him. Maybe you read some of his papers. He sadly passed away on Christmas Day, so I have a few words for him. So Olivier was an INRIA researcher in the MPEN team since 2009. He made significant contribution to MS lesion segmentation, developing segmentation methods, and organizing 2 international challenges allowing to assess existing methods for MS lesion segmentation with artificial intelligence method and lately deep learning methods, and using the structured data from the OFSEP database. Olivier also made important contributions to diffusion imaging and lately myelin water fraction imaging. He would have loved this workshop. He passed away, as I said, on Christmas Day after fighting during 3 years. We will remember his dedication to his work, to the community, as well as, if you have met him, his sense of humor was quite peculiar. All right. Now we will move on with the first talk by Alessandro Cagol from the University of Basel. Alessandro will talk about quantitative MRI of myelin and iron. The floor is yours. For those that are online, do not hesitate to ask questions in the chat that we'll be able to repeat after the session. Thank you.
Okay, do you hear me? Yeah. Okay, thanks a lot for the kind introduction. It's a great pleasure for me to be here, and I want to thank the organizers for the invitation. The title of the presentation is Quantitative MRI of Myelin and Iron and Stratification, and in the next 40 minutes I will try to give you an overview of the recent developments in the field of quantitative MRI with a specific focus on the techniques sensitive to myelin and iron, which can be potentially useful in clinical practice. As it is well known, and as it is already presented before, conventional MRI plays a crucial role in the clinical management of patients with multiple sclerosis. And indeed, images like the one represented here in the slides are routinely acquired and used. They are useful for MS diagnosis since they can prove the dissemination in space and the dissemination in time and can support the MS differential diagnosis. Conventional MRI is routinely used for monitoring disease activity and treatment response, mainly through the identification of new and enlarged into lesions and contrast-enhancing lesions. To a certain extent, as we have seen before, conventional MRI can also be useful for predicting disease severity, and it is useful for safety monitoring. So overall, the role of conventional MRI is undeniable in multiple sclerosis. However, something that we need to consider is that when we look at conventional MRI, we are assessing pathological changes through the identification of contrast changes in weighted images. And the nature of the intensities in such weighted images is purely qualitative. On the contrary, quantitative MRI provides us with the unique opportunity to directly measure in vivo the microstructural integrity. And this means, for example, that the intensity in each voxel of our quantitative MRI images reflects directly the magnitude of a specific electromagnetic property. And this also means that, for example, the intensities are expressed in terms of physical units, which, for example, for T2 relaxometry is milliseconds and so on. And importantly, we can exploit different biophysical properties of the tissue, of the brain in our case, to derive indirect information about the changes in key components of the tissue. And this is extremely important to try to disentangle the different and complex pathophysiological processes occurring in multiple sclerosis. Quantitative MRI can also be extremely useful for providing us with biomarkers sensitive to the detection of the subclinical disease progression, which is something that we are still missing in clinical practice, and therefore can be extremely useful and promising for better stratifying patients in clinical practice. As I said before, we can exploit several different physical properties of the tissue to try to infer, to derive information about the tissue structure and the integrity of the tissue. And indeed, we have, for example, techniques that are sensitive to the myelin content, which can be useful, for example, for assessing demyelinating and remyelinating processes. We have techniques that are sensitive to a certain extent to the axon and dendrite density, and there are techniques, for example, sensitive to the iron content. And all these techniques can be extremely useful, especially when considered together to try to disentangle the complex processes occurring in patients with multiple sclerosis. And indeed, several of these quantitative MRI measures have been recently used and studied in patients with multiple sclerosis, both for trying to characterize the heterogeneity of MS lesions and also for assessing the pathology in the normal appearing tissue. It's important to try to characterize MS lesions because, as we know from the pathology, not all the lesions are the same, and indeed they can be characterized, for example, by different degrees of edema, of demyelination, remyelination, and neuroaxonal loss. And this is something that we cannot do to distinguish these processes with conventional MRI. But on the contrary, quantitative MRI could be potentially extremely useful in separating these processes. And the same also holds true for the assessment of the damage in the normal appearing tissue. As we know, normal appearing tissue is thought to be normal, at least at the macroscopic evaluation, but indeed in pathological studies it has been shown that it is significantly associated with neuroinflammatory and neurodegenerative microstructural changes. And of course, these changes cannot be detected, cannot be identified and quantified with conventional MRI. But on the contrary, quantitative MRI could be extremely useful also for this purpose. Before going into detail and describing which are the quantitative MRI measures that can be useful for assessing the myelin and iron content, I would like to stress and focus on which are the determinants of the MRI contrast in the central nervous system. And these include, for sure, water, which is the first fundamental determinant of the MRI contrast in the brain and in the body in general. And this is due to the fact that what we do with our conventional MRI is to image the hydrogen nuclei, which are mainly contained within the water molecules, and therefore water is a fundamental determinant of the contrast also in our central nervous system. Another important determinant of the contrast is the content in iron. And as we will see later, iron has a huge impact on the magnetic susceptibility of the tissue, and we can exploit specific techniques in order to derive information about the iron content in the tissue. And a third fundamental determinant of the contrast is the presence of lipid and proteins, which in the central nervous system are mainly contained within the cell membranes and in myelin. Of course, myelin is a fundamental component of the central nervous system, which consists nearly in 50% of the dry weight of the white matter, and it plays a fundamental role in supporting the electrical conduction of the axons, but also in providing trophic support and protection to the axons. And of course, myelin is extremely important in multiple sclerosis since it is the main target of the pathophysiological processes. And due to the importance of myelin, both in the physiology and in pathology, and especially in MS pathology, this is the reason why it's so important for us to develop biomarkers potentially sensitive in measuring the content in myelin in vivo, in order to better characterize the demyelinating and remyelinating processes. And of course, the thickness of the myelin sheets is in the order of micrometers, well below our spatial resolution on MRI. But what we can do is to infer, to derive information about the myelin content by exploiting different biophysical properties of the brain which are influenced by the content in myelin. And indeed, several different quantitative MRI techniques that are represented here systematically in this figure, which is taken from a meta-analysis that I strongly recommend, have been proposed. Importantly, for quantitative MRI measures and for the validation of the quantitative MRI measures, what we use as the ground truth is histology. And indeed, it's extremely important for the validation of a quantitative MRI measure to prove a significant association with the actual pathological proved myelin content. And here in these slides, it's represented with different shades of color, the association, the strength of the association between the different quantitative MRI measures and the pathologically proved myelin content. As you can see, there is a large heterogeneity across the different measures. During the presentation, we will focus mainly on 5 of them, which are more promising for a potential clinical application. And let's start with T1 relaxometry. T1 relaxometry is a measure, fundamentally the recovery of the longitudinal magnetizations of the spins. And importantly, T1 relaxation time is, among the other factors, influenced by the size of the macromolecules and also their freedom in dissipating energy. And importantly, macromolecules such as myelin are characterized by significantly shorter T1 relaxation time compared, for example, to the free water. And this is the reason why, for example, in the image that you see on the left, which represents a T1 relaxometry map, white matter, which has, of course, a higher content in myelin, has a darker signal, a lower signal, reflecting a shorter relaxation time compared to, for example, gray matter, and even more evident compared to the CSF. Now, when we look at T1 relaxometry data, it's important to stress the concept that T1 relaxation time is not only influenced by the presence of macromolecules and myelin, but the signal is also severely influenced by the total water content and the iron content. So overall, T1 relaxometry provides us with a measure that is overall sensitive to the macro and macromolecular structural integrity of the tissue. And this measure is indeed highly sensitive for the myelin content, but it shows only low specificity for myelin. Nevertheless, it has been shown in several studies conducted in MS that T1 relaxation time could be extremely useful to characterize the damage in patients with multiple sclerosis. And indeed, already several years ago, it has been shown that lesions characterized by a longer T1 relaxation time are more destructive in nature, are more associated with severe neuroaxonal loss. It has been shown that the volume of lesions with long T1 relaxation time correlates with clinical scores, and this correlation is stronger compared to the correlation with the total T2 lesion volume. The T1 relaxation time in cortical lesions proved to correlate with the severity of the cognitive impairment. And interestingly, it has been also shown that the decrease of T1 the relaxometry in lesions over time, potentially reflecting, of course, the subsidence of edema, but also remyelination, is associated with clinical improvement, both in terms of physical disability, as assessed with the EDSS, but also in terms of cognitive disability, as assessed with the single-digit modalities test in that study. Interestingly, T1 relaxometry is not only useful for characterizing the damage in the white matter lesion, cortical lesions in patients with multiple sclerosis, but it has been shown that T1 relaxation time is significantly altered in patients with MS, also in the normal appearing tissue. And these alterations importantly correlate with disease progression and also with neurodegenerative changes such as brain atrophy. Therefore, as I said, T1 relaxometry is potentially a useful tool also for the clinical practice, but we need to consider that there are still significant obstacles for an implementation in clinical practice, which includes, among the other, the relatively long acquisition time, the lack of a consensus on the best approach for acquiring T1 relaxation data, and the overall still limited reproducibility of such approaches, even if new sequences and new approaches have been proposed in recent years that can potentially overcome at least some of these limitations. And the importance and the value of the T1 relaxometry in multiple sclerosis has further been stressed by this study published in 2021, and it was conducted at 7 Tesla, where the author showed that it was possible to disentangle and subdivide the white matter lesions according to the T1 relaxation time. And importantly, they found that the lesions associated with a short T1 relaxation time were significantly associated in the post-mortem analysis to remyelinated lesions, while on the contrary, lesions with long T1 relaxation time were associated with demyelinated lesions. And they also conducted an in vivo study where it was shown that lesions with long T1 relaxation time, so the demyelinated lesions, were more likely to be characterized by the presence of a paramagnetic rim that, as we said before, it's associated with a chronic inflammatory activity, so lesions that are more destructive. And the value of T1 relaxometry has also further been recognized by this recent paper from the International Advisory Board on Clinical Trials in Multiple Sclerosis, where 7 Tesla T1 mapping has been reported as a potential and promising biomarker for assessing remyelination in vivo. Another way to look at the myelin content is by using magnetization transfer imaging. Magnetization transfer imaging includes different approaches, all of them based on the magnetization transfer phenomenon. The signal in the magnetization transfer imaging is mainly determined by the presence of macromolecules, and this means that indeed it is sensitive to the presence of myelin, even if it's not completely specific, because indeed what we are measuring are all the macromolecules, so not only myelin. The concept behind magnetization transfer imaging is not straightforward. I will try to simplify it. The idea is that the hydrogen nuclei in the tissue are contained in two pools, the ones that are bound to the macromolecules and the ones that are free to move. And what we can do is by using a radio frequency to selectively saturate the signal of the hydrogen nuclei contained within the macromolecules, and then as a consequence of the magnetization transfer, this energy is transferred to the free pool, and this process is directly proportional to the macromolecular content. So therefore, we can indirectly infer about the concentration of the macromolecules in the tissue. And it has been shown that the magnetization transfer ratio, which is the easiest approach among the umbrella of the magnetization transfer imaging techniques, displays a very strong association in pathological studies with the myelin content, but also with the axonal content. However, we need to consider that there are still important limitations, which include, for example, the sensitivity of the magnetization transfer ratio to the total water content. And when this is, of course, an important limitation, for example, for evaluating new lesions in multiple sclerosis, which, of course, are characterized by an important edema. And we also need to consider that several technical factors need to be accounted in order to provide reproducible data. Nevertheless, magnetization transferation has been extensively studied in the recent years, and it has been also used as an outcome measure in clinical trials assessing the effect of disease-modifying therapies in multiple sclerosis. Why is that so? Because magnetization transfer ratio is for sure sensitive to the damage in the white matter lesions of patients with MS, and indeed white matter lesions exhibit a reduced magnetization transfer ratio compared to the normal appearing tissue. And the same holds true for cortical lesions compared to the normal appearing gray matter. And it was also shown that potentially longitudinally we can track and describe the changes and the different phases of the acute lesions. And indeed, in this study, it was shown that the signal in magnetization transfer ratio already decreases before the occurrence of gadolinium-enhancing lesions. Then, at the time of the enhancement, there is a dramatic drop of the signal, which then recovers to a certain extent, at least, which is function, of course, of the subsidence of the edema, but potentially also of the remyelination. Interestingly, magnetization transfer ratio is not only useful for assessing the damage in MS lesions, but it is sensitive also to the damage in the normal appearing tissue. And here in this study, for example, it has been shown that patients with secondary progressive MS compared to patients with relapsing remitting MS were characterized by a significantly reduced magnetization transfer ratio in the outer layer of the cortex compared to relapsing remitting patients, potentially implying a more severe subpial demyelination in the group of patients with secondary progressive MS. Another way to measure the myelin content in vivo is by using myelin water imaging. And myelin water imaging is an extremely promising technique since differently from T1 relaxometry and differently from magnetization transferation is highly specific for the myelin content. The most common approach to obtain myelin water imaging is by using T2 relaxometry. So before we spoke about T1 relaxometry, now we are speaking about T2 relaxometry, which is the phasing of the spins in the transverse plane, and importantly, this T2 relaxation time, also here I'm trying to simplify the concept, but the T2 relaxation time is a function, among the other factors, of the motility of the molecules in the tissue. And this means that the hydrogen nuclei contained within the macromolecules have significantly shorter T2 relaxation times compared to the free water. And the T2 relaxation time actually of the macromolecules is too short to be imaged with our conventional MRI scanner, with our conventional techniques and sequences at least. And indeed what we do with myelin water imaging is to image water. But importantly, imaging water, what we can do is to distinguish two fundamental pools that are contributing to the signal. The first pool, as you see in the graph on the left, it's the pool of myelin, of water contained within the myelin sheet. So this is the water that is entrapped within the myelin sheets. And the second pool, which is the intra and extracellular water. And importantly, it has been shown that myelin water fraction, which is the fraction of water contained with myelin compared to the total water content, is a significant biomarker which is associated with very high sensitivity and very high specificity to the myelin content in pathological studies. However, also for myelin water imaging, there are still important obstacles for the clinical implementation, which include the long acquisition time, or even if also here new simplified approaches have been proposed. We need to consider that myelin water imaging is to a certain extent sensitive to the total water content and potentially also to the iron content. However, it has been recently shown that also in acute lesions, which of course are characterized by a significant accumulation of water, this accumulation of water indeed has an impact on the myelin water fraction signal overall, but this impact is relatively negligible compared to the effect that is driven by changes in the myelin content. Overall, the MS lesion exhibit a significant reduction of the myelin water fraction. On average, it has been estimating a 50% reduction, but importantly, there is a large heterogeneity in the degree of the reduction of myelin water fraction in MS lesions, potentially reflecting different degrees of demyelination and remyelination across the different lesions. And the potential and the importance of myelin water fraction to disentangle the different pathophysiological processes occurring in MS and specifically in MS lesions has been further stressed by this study, where it was shown that lesions that exhibit the paramagnetic rim, so lesions associated with chronic inflammatory activity, as Martina mentioned before, were characterized by significantly reduced myelin water fraction values compared to lesions that do not exhibit the rim. And finally, myelin water imaging is also potentially sensitive to changes in the normal appearing tissue of patients with multiple sclerosis. And indeed, in this study, it was shown that patients with primary progressive MS compared to healthy controls exhibit significantly reduced myelin water fraction, both in the brain but also in the cervical spinal cord. And this reduction was also, to a certain extent, correlating with clinical scores. Other measures to potentially infer information about myelin content are diffusion tensor imaging-based measure. DTI is a well-known technique, and it's probably the easiest way to model the diffusion signal in MRI. Diffusion signal and diffusion in general exploits the diffusivity of the water molecules and the restriction of such diffusivity due to the presence of macromolecules and cell membranes to derive a contrast in the brain. And probably among the different DTI measures, radial diffusivity could be potentially the most interesting for assessing myelin, since it has been proposed that since radial diffusivity represents the diffusivity in the plane transverse compared to the main axis of the axon, as displayed in the cartoon over there, the radial diffusivity is generally hindered, is generally limited by the presence of myelin sheaths. And therefore, an increase in radial diffusivity is thought to reflect potentially a damage of the myelin sheaths, so potentially a reduction in the concentration of myelin. However, we need to consider that this is very, there are several limitations in this approach. The first important is that diffusion is not specific to any myelin properties, so we can only infer and derive indirect information about myelin content. And the second important consideration, and of course it is very well known, is that tensor models does not apply to regions of fiber crossing, which on the contrary are the vast majority of the boxes inside our brains. So we need to consider that indeed DTI is an oversimplification of the diffusion model. And indeed, DTI measures in this meta-analysis were also the measures that correlated the less compared to the histopathology. The last technique that I would like to mention, and actually it was already mentioned during the presentation before mine, is quantitative susceptibility mapping, or QSM. QSM is a measure, is a technique that measures the magnetic susceptibility of the tissue. Magnetic susceptibility is a fundamental property of each substance, and it mainly represents the response that each substance has when it is applied a field strength. And indeed, with quantitative susceptibility mapping, we are able to both quantify but also localize the presence of this magnetic susceptibility. And importantly, the determinants of magnetic susceptibilities in the tissue are several, but something that is really important is that the main driver indeed are iron and myelin, but they do play the opposite roles in this contrast, because iron is a strongly paramagnetic substance, while myelin, and especially the orientation of myelin, the anisotropy of myelin, have a diamagnetic effect. And this means that iron is essentially increasing the signal in our QSM images, so in the image represented here, for example, while myelin does the opposite, so reduces the signal in MRI. And indeed, this is also confirmed in pathological studies, where you can see here that indeed the signal in QSM is negatively associated to the pathologically proven myelin content and strongly positively associated to the iron content. So even if QSM is fundamentally influenced by the iron content, still can provide us with extremely important information about myelination. And this is a study performed by our group where was shown that first it is possible to subclassify white matter lesions according to their signal on QSM. And indeed, this classification included, it is displayed here on the left, iso-intense lesions, hypo-intense lesions, hyper-intense lesions, lesions exhibiting the paramagnetic rim, and also lesions exhibiting a hypo-intense rim. But notably, what has been shown is that lesions that are iso-intense or hypo-intense on QSM are significantly associated on pathology with lesions that are remyelinated. And indeed, as you can see here in the table, iso and hypointense lesions were predicting the remyelinated behavior at pathology with 100% specificity and 89% sensitivity. And in the same study, it was also shown in vivo that the hypo and iso-intense QSM lesions were significantly associated with higher levels of myelin water fraction compared to the other white matter lesions. And there was also an increase in this lesion of the myelin water fraction over time. In multiple sclerosis, not only important, of course, from the pathological point of view, myelin, but also iron homeostasis plays an important role. And we have seen before the value of assessing iron in vivo in order to characterize and identify the paramagnetic rim lesions where an accumulation of iron in the activated macrophages and macroglia occurs. But importantly, there might be in multiple sclerosis patients also changes involving the normal appearing tissue. We need to consider that in the brain, the vast majority of iron is contained bounded to ferritin in the oligodendrocytes. And indeed, due to a depletion of the oligodendrocytes, there might be a reduction of the iron content, potentially both in white matter lesions, but also in the normal appearing tissue. There are, from the technical point of view, several different approaches to quantify iron in vivo. All these approaches are based on gradient eco-acquisitions, and we can provide both qualitative and quantitative images. The qualitative images are T2 star and SWI, which are currently frequently used also in the clinical routine, but it is possible also to obtain quantitative MRI measures. And indeed, for example, by using a multi-eco gradient eco-acquisitions, we can obtain the R2 star, which quantifies the susceptibility, the magnetic susceptibility of the tissue, but we can also derive the QSM by using the phase. And the phase, importantly, is an image that is always produced at the scanner, at least, and for a long time it has been not so considered, but now we are more and more recognizing its value, because indeed can provide us, of course, after an important post-processing step, these QSM maps, which are extremely useful for many purposes. And importantly, these QSM maps can also distinguish between a diamagnetic and a paramagnetic effect, which is not feasible with the others. As already mentioned before, and as already described before by Martina, it's important to look at the iron homeostasis in patients with multiple sclerosis, especially for the presence of paramagnetic rim lesions, which actually constitute a subset of chronic active lesions. Indeed, as we know, a chronic lesion can be either completely inactive or can show a chronic inflammatory activity, as already mentioned. And this chronic inflammatory activity is smoldering and is associated with a progressive demyelination, failure of the mechanism of remyelination, and also neuroaxonal loss. And therefore, the paramagnetic ring lesions are considered to be one of the potential driver of progression in multiple sclerosis. And indeed, here you can see that they are well visible also on QSM, but it was also mentioned before. Indeed, paramagnetic ring lesions prove to be more frequent in patients with progressive disease, prove to be predictors of conversion to definite MS in patients with CIS and even in patients with radiologically isolated syndrome, and they do associate with physical disability, cognitive impairment, and more aggressive disease course over time. But as I said before, changes in the iron homeostasis are not only limited to the paramagnetic ring lesions, but indeed significant alteration can be found also in the normal appearing tissue and especially in the deep gray matter. And indeed, several studies have found and reported a reduction of the iron concentration at the level of the thalamus, particularly evident at the level of the pulvinar. And interestingly, this difference was not only evident in patients with MS compared to healthy controls, but also in patients with progressive MS compared to relapsing remitting MS patients. And these alterations were also correlating significantly with clinical scores in terms of physical disability. And also recently, these data were further supported by another study which showed that not only the concentration of iron is reduced in the thalamus, but also the, indeed, actual iron content. I think we don't have too much time to go into detail, but what's important is that, as I said before, with quantitative MRI, we can exploit different biophysical properties of the tissue in order to infer and to characterize the macroenvironment. And it's extremely promising, extremely useful to combine together different quantitative MRI measures in order to try to disentangle the complex pathophysiological processes occurring in multiple sclerosis. And even more importantly, it's extremely promising to combine different approaches, such as the case of this recent study published by the group of Paris, where they use both PET imaging and quantitative MRI. And I think perhaps Benedetta will talk more about this later. But I just want to mention that they found that there is a significant failure of the remyelination in the periventricular lesion, and this is interestingly associated also with neurodegenerative changes evident at the level of the cortex. During the presentation, I have mainly focused on brain MRI, but of course, most of these techniques can be also applied to spinal cord. Of course, the imaging of the spinal cord is a lot more challenging due to the size of the spinal cord, due to the presence of susceptibility artifacts, due to the presence of artifacts due to cardiac pulsation and respiration and so on. But still, some studies have shown that indeed it is possible to find and to describe pathological changes in patients with multiple sclerosis compared to healthy controls by using diffusion MRI, magnetization transfer, and milliwater imaging. And to a certain extent, some of this damage is also associated with clinical scores or with more severe disability. The ideal quantitative MRI measure for a potential clinical application should be accurate, should be reproducible, should be specific, identifying a specific component of the central nervous system and without sensitivity to other components, should be available both in terms of technology, in terms of time of acquisition of the images, and so on. And it's important also for a potential clinical application to establish cutoffs or thresholds that distinguish the physiological from the pathological changes. However, there are no measures with sufficient evidence at the moment, and the clinical maturity of our current quantitative MRI measures is limited, but it is likely that in future at least some of them will become potentially useful for the clinic. Coming to the conclusions, I hope that I show you during the presentation that imaging demyelination and remyelination, as well as iron homeostasis in vivo, is possible by using quantitative MRI. Histological studies are fundamental to assess specificity to myelin and iron, and multiparametric studies can help us in improving our specificity and in better disentangling the complex pathophysiological processes occurring in MS. Despite the limitations that are still present, quantitative MRI measures have an enormous potential to improve clinical management of patients with multiple sclerosis. And next important steps include potentially the conduction of multicentric reproducibility studies, potentially also with longitudinal design, and studies aiming at assessing the sensitivity of the quantitative MRI measures to the treatment effects. And with this, I want to thank you for your attention. I would like to thank all my colleagues, and I would be happy to answer to your questions.
Thank you very much for this beautiful talk, very comprehensive. Are there questions in the room?
Thank you very much for this very global and comprehensive overview. I have a comment or a question, or it's in between. We have seen from what you have covered that there is no perfect solution from the MRI point of view to assess myelin. There are many good opportunities, but none are really specific. And most of them have been, in terms of specificity, validated against myelin content using coloration or staining of myelin in the normal appearing white matter. But we also need a technique that is specific in an inflammatory environment. So the first question is, from what you have heard or seen, do you know anything about one technique that would have been validated against myelin in an inflammatory environment that would be of interest for MS?
Okay, no, I agree with you that this is a crucial point. I'm not specifically aware of any study performed especially in patients with multiple sclerosis or especially in MS lesions. I think the vast majority of the study that I showed in the meta-analysis were indeed performed with normal tissue for validation of the metrics themselves, but of course this is an important source of...
One way of thinking would be also to select the one that is less sensitive, you know, to inflammation. And, some of them are known to be sensitive, such, I don't know, MTR, for instance, is more or less sensitive to inflammatory. It's not meaning that it's not a good one, but we have to keep this in mind.
Yeah, sure.
And the following is that as none of them are perfect, is there any combination that could be of interest, not, you know, including everything in every study, but maybe selecting two or, I don't know, two specific metrics that could add specificity in a model that would be of interest for clinical trials?
Yeah, I really think that it depends on the scope of the investigation, but in general, what we do in Basel is to use at least one measure that is sensitive to myelin, at least one measure that is more broad, such as, for example, T1 relaxometry, which of course includes also the signal from myelin, but is a more broad measure of the microstructural integrity. And then, of course, to assess iron and to assess neuroaxonal density, we use other approaches. For iron, we use the QSM indeed, even if always there are mixed signal, and even QSM, of course, is not 100% specific on iron. But and for example, for neuroaxonal density, what we use are diffusion-based metrics, such as the ones derived from the NODI model. And of course, I agree with the fact that all of them have significant limitation, important limitation, but the idea is that potentially by performing multi-parametric study and integrating the different techniques, we can try to indeed disentangle the complexity of the pathophysiology, or at least this is the goal.
Thank you, Alessandro. Very, very interesting talk. So I would like to continue discussing about the best specific metric that we might use. During your talk, you said that marine water fraction, in your view, seems to be more specific than MTR. I would like you, if it's possible, to elaborate on that, if this is because you can actually exclude the effect of the extracellular water, if that's the case. And the other question I wanted to ask you is, because of course our reference is of course always the post-mortem study with MRI, I was wondering whether, based on the study of Marcello Moccia saying that the effects of different physiopathological processes is different according to the region that we are studying, shouldn't we be able to explore the specificity of this type of techniques in separate regions of the brain, typically in the gray matter versus the white matter, where the inflammation is lower?
Mm-hmm. Okay, coming to the first question, which was about...
Which was the marine water fraction versus MTR.
Yeah. Sorry, which are the main, specific measure for measuring marine. Yeah, probably, as I said, presentation, marine water fraction is the most promising to this end because differently from the others, it's more specific. Indeed, as we said for T1 relaxometry, it's a very broad measure that is influenced by several different factors. I mean, an elongation, an increase in the T1 relaxation time in T1 relaxometry is, of course, a function of the myelination, but also iron depletion, water accumulation, axonal loss, and so on. So for sure, it's definitely not a specific measure. To what concern magnetization transfer ratio, it is already more specific compared to T1 relaxometry because it is sensitive to the signal from the macromolecules, but of course not all the macromolecules are myelin in the brain. So we can in the end achieve a moderate specificity with that approach. And on the contrary, marine water imaging and marine water fraction is considered to be potentially more specific because indeed what you do there is to calculate the fraction of water that is directly entrapped within the myelin sheath. So, of course, it's still an indirect measure, but it is considered to be reflecting more a property that is characteristic of the myelin itself. And it's less influenced by other confounding factors. But of course, as I mentioned before, still the total water content influences at least to a certain extent, the signal in marine water fraction, and this is something that we need to consider. And there are also seminal studies that show that even iron can have an impact on marine water fraction. And another thing that we need to consider is that marine water fraction is mainly developed to be used in white matter, and it's extremely difficult to apply this type of metrics to the gray matter, for example, both due to the lower concentration of myelin, but also to the fact that the peaks that we saw in the curve of the decay of the T2 relaxation time are switched, are moved, and it's difficult, and it's more difficult in the gray matter to disentangle specifically the two components of the myelin, the water contained in myelin and water contained in the intra and extracellular space.
So this is very interesting. You wouldn't suggest to use a myelin water fraction to explore myelin content in the gray matter, in the cortex?
Yeah,
no.
I would not.
Not a good idea. Okay. Thanks.
Thank you for the very interesting talk. You said that DTI is not, the tensor model is not specific enough to see the crossing of fibers. I was wondering if there are studies that have looked at the constrained spherical deconvolution based tractography to identify better the crossing fibers. If we have data on MS, I know that other neurological disorders.
Yes, there are several studies that investigated, let's say, more complex models to model the diffusion signal including, for example, NODI that has been extensively applied both in white matter lesions in the brain, but also in the normal appearing tissue, and also, for example, in the spinal cord, where it was shown that indeed it's performing better than the conventional DTI for the detection of white matter lesions in the spinal cord. But for sure, I mean, they are more, they need more computational steps. They are far more complicated as a model, but for sure they can provide us with better explanation of the data that we have. For sure, as I said before, DTI also for, and especially for quantifying myelin is a very oversimplification of the story, I would say. Also because diffusion is not directly specific to the mind.
Thank you. Are there any other questions? I have one, if I may. At the beginning of your talk, you mentioned that there were no consensus acquisition for T1 relaxometry. I know it's the same issue for myelin water fraction. What would be your recommendations there? What do you feel is the most promising method?
For T1 relaxometry, what we use in Basel is MP2-RAGE, which actually has a pretty acceptable, even clinically acceptable acquisition time. I would say it's nearly 8 minutes. Okay, not that short, but not even so long.
Also with the spine?
Only the upper part of the cervical spine, yes. And for example, for MP2-RAGE, it has been proven that the intra and interscanner reproducibility is much higher compared to the other approaches. So this is potentially one of the answer. Also looking at potential clinical application.
And what about myelin water fraction?
For myelin water fraction, there are several different approaches. Of course, the assumptions are pretty different one with the other. I think that there is no consensus also there to which is the best one, and probably should be tailored according to the purpose of your study. What we are doing in Basel, for example, is to acquire T2 prep, which is based on T2 spiral contrast, which is relatively fast, but comes at the price of very low resolution. So in the end, it's always a trade-off. I mean, saving time, but having data less accurate.
All right. I think those methods are vendor-specific, though, right?
And most of them are vendor-specific, yeah, definitely.
All right. Thank you.
Perhaps one question. So you mentioned that it is important to get multi-parametric approaches to characterize. I was wondering if you review the techniques that allows with a single sequence to get multiple contrasts, such as, for example, MR fingerprinting or some variant. So do you have some insight into comparing the results with what we are all doing, so with optimized sequence to get one parameter and this multi-parametric approaches?
So to derive from the same approach different metrics, you mean?
Yes, from the same sequence you can derive T1, T2, division, and so on.
Yeah.
So there are some different possibilities.
Yeah, sure.
Perhaps to have an idea about the comparison between what we can obtain from, let's say, specific or contrast. And
I really think that this totally makes sense. This is something that we are not currently doing, but it's extremely promising, I would say, even considering a potential clinical application indeed in terms of acquisition time and so on. So I think it's really extremely promising. Yeah.
Thank you. Is there other questions? No? Okay, thank you, Alessandro. Yeah. Now, I have the great pleasure to introduce Professor Benedetta Bodini. She's from the Paris Brain Institute, the Paris Sorbonne University, and Hôpital Saint-Antoine. Her work has largely contributed to the understanding of the mechanisms of demyelination and remyelination using molecular imaging. So thank you very much. And the title of her talk is Molecular Imaging of Disease Mechanisms and Stratification.
Thank you very much for the introduction, and thank you very much for giving me the opportunity to be here today. So we'll try to discuss about the role of molecular imaging in all this. On one side, in trying to understand the pathophysiology of the disease, and in particular the mechanisms leading to neurodegeneration, and on the other hand, in trying to stratify our patients according to mechanisms. So I will first try to identify the reasons to use molecular imaging for this, and then I will try to explore, I will try to describe you all the achievements that have been obtained using PET in particular and the sodium imaging, trying to understand the physiopathology and also to stratify patients. So I will start from the need that we now know that we have to redefine the clinical course of MS, in particular in terms of neurodegeneration, because of course we know that neurodegeneration does not only occur is not limited to patients with a progressive course of the disease, but starts right from the beginning of the disease. And what it has been clearly identified in this recent study is that really the mechanism, from the qualitative point of view, the mechanisms leading to neurodegeneration, they are present in every patient with MS from the very early start of the disease, from the RIS stage down the line to the secondary progressive stage. What changes is the quantitative contribution of each mechanism at each stage of the disease and in each single patient. So the idea is, of course, that we need to develop imaging techniques that are able to get as close as possible to the biology of the disease to be able to really define the contribution of each mechanism at each patient and in each individual. So I will try to focus on three of the main mechanisms that you can explore with molecular imaging and which largely contribute to neurodegeneration and therefore to the accumulation of clinical disability in multiple sclerosis. So of course the innate immune cell inflammation, we have discussed a lot about this in terms of smoldering plaques and of diffuse damage in normal appearing tissues. We have also mentioned the persistent demyelination and the failure of remyelination, so the failure of this key compensatory mechanism in the physiopathology of neurodegeneration. And finally, I want to mention energy dysregulation as an early marker of neurodegeneration. So why use PET to measure chronic inflammation and myelin content changes? Because PET offers really the highest possible specificity for this type of mechanisms. The reason is that PET, differently from MRI, it is based on the use of radiolabeled compounds, which are targeting specifically some cellular or tissular components. And we can obtain absolute quantification of tracers, which reflect the concentration of the biological target. A little bit more indirect, but still very specific for energy dysregulation is the sodium imaging. So what we know, I will try to describe quickly what's the rationale of using sodium imaging to explore energy dysregulation, is that of course following demyelination there is a reorganization of the sodium channels along the demyelinated axons. So they accumulate along the demyelinating axons as a compensatory mechanism to allow the signal to be transmitted in demyelinated axons. But this, of course, requires more energy. And simultaneously, while we need more energy for the signal to be transmitted, we also produce less energy because of the mitochondrial dysfunction, which is linked, which is in relationship with the inflammatory environment. So there is this imbalance between the energy demand and the energy supply, which is able to compensate for this problem up to a certain stage. And then the neurons enter into this phase that has been defined as a virtual hypoxia phase. So the neuron is still alive, but is suffering from the energetic point of view. And then after a certain amount of time, where we still can reverse, at least theoretically, this process, the neurons start to irreversibly degenerate. So the principle is that we can be able to identify with sodium imaging, to measure with sodium imaging, this intracellular accumulation of sodium, which is really the earliest phase of neurodegeneration that we can possibly identify from the functional point of view. So I will try to discuss now how we can use PET to target innate immune cell inflammation and myelin loss and repair. And I will start from innate immune cell inflammation. So, of course, the PET tracers that we can use, that is mostly used to explore innate immune cell activation, are the tracers targeting the TSPO. The TSPO is a macromolecular complex which is localized in the outer mitochondrial membrane, and the expression of TSPO is mainly, even it's not exclusively, but it's mainly driven by innate immune cell activation. There is also some expression of TSPO in astrocytes, as was previously mentioned by Martina, even if it's very reduced, the expression on astrocytes, and also a little bit on the endothelium. And the first reference ligand for PET studies is the PK11195, but now there's been many years that we have been using second generation tracers which have a much higher affinity to the TSPO, and they are also provide a much better signal to noise ratio. Among these tracers there is the PBR28 and there is also the DPA714, which is the one that we use in Paris. So there are several groups, and it's been really a number of years that they are all in a series of group studies. They are all the message is always the same. Is really that there is an increased banding of TSPO reflecting innate immune cell activation everywhere. So in lesions, perilesions, normal appearing tissues, normal appearing white matter, normal appearing gray matter, the gray matter all together. So every region of the brain and at every single stage of the disease, from CIS to secondary progressive MS. Always at the group level, it has been demonstrated that microglial activation in CIS, normal appearing white matter, is higher in those subjects who will then develop multiple sclerosis, clinically defined multiple sclerosis at 2 years. And more recently, this is a study performed by the team led by Laura Airas in Turku, in Finland. She showed that on a large number of patients followed up for 4 years, that the activation of innate immune cells in the normal appearing white matter and perilesions was able to predict clinical progression at 4 years, or independent of clinical relapses. But what we wanted to add in Paris is really what is really the topic of this workshop today. So we wanted to move from a group level analysis to an individual single patient level analysis. And for this we developed a pipeline which is based on the comparison between patients and controls to define the threshold of significant difference, and then to apply this threshold to single voxels, comparing each voxel in patients to all the voxels in healthy controls localized at the same, in the same localization, therefore suffering from the same level of partial volume effect. This allowed us to generate binary maps of innate immune cell activation, which are really patient-specific, so to define the individual profiles of innate immune cell activation for each patient. So this is a study that we have done 3 years ago on 37 patients with MS, and we were able to define individual profiles in normal appearing tissue and also in lesions. At the normal appearing tissues level, we were able to find an heterogeneity of innate immune cell inflammation with PET, even in patients with the same form of disease. Again, confirming that we really need to look at the mechanism rather than simply looking at the disease course. As you can see, these are 3 patients with secondary progressive MS. In this one, there is a very reduced innate immune cell inflammation, whereas in this patient here, there is a widespread activation of innate immune cells. Based on these maps, we were able to identify lesions which were defined as active lesions based on DPA PET and inactive lesions. And while only less than 2% of total lesions would be defined as active based on gadolinium T1 weighted sequences, we found that almost 40% of total lesions were active based on the DPA PET. And also, the number of these active lesions correlated with the clinical trajectory of patients in the 2 years preceding study entry. Again, meaning that the closer we get to the biology of the disease, the more precisely we can profile our patients, phenotype our patients, and find interesting and relevant clinical correlations. But the question, of course, was,
can we find even more sophisticated markers that can predict patients, which patient will enter into a more severe phase of the disease? And this is the study that has been very recently completed by Mariem Hamzaoui and Jean Garcia from our team. So Mariem looked even in much more sophisticated way at lesions, and she defined lesions which are characterized by an activated rim, which should correspond to the paramagnetic rim lesions that Martina talked about this morning. But she also identified a very specific subsets of lesions, which are lesions characterized by an active center, an homogeneously active center. And finally, she defined the non-active lesions. And what she found was that almost 60% of lesions, of T2 lesions, had a smoldering component, whether localized homogeneously inside the lesions or around the lesions. And this was very important from the mechanistic point of view, looking at neurodegeneration. From the point of view of cortical atrophy, patients who had a higher number of homogeneously active lesions were those developing pathological atrophy compared to the others. And there was a very significant correlation with the DSS clinical evolution, so the stepwise change over the 2 years following study inclusion. Which means that actually we could conclude that this technique allowed us to really reveal an unexpectedly high proportion of lesions with MS, and the hypothesis characterized by this innate immune cell activation and characterized by a smoldering component. So we were wondering whether really following the acute phase, the majority of lesions in MS actually develop a chronic inflammatory component that then remains localized in the rim only in a subset of lesions that then we can see as rim-active lesions. So this is an ongoing hypothesis that we are trying to explore. We also looked at the regionalization of this innate immune cell activation. This is a study from Émilie Poirion from the team. So she looked at innate immune cell activation with regard to the distance from the ventricles, and she found that this activation predominates in periventricular regions, and also that this activation around the ventricles is associated with more severe microstructural damage. And more recently, Vito Riciliano, again from the team, he looked at innate immune cell activation in choroid plexuses in multiple sclerosis, and he found that choroid plexuses are inflamed in MS since the pre-symptomatic phase of the disease. And this was because the first healthy control of our study on DPA, she actually developed MS, the first relapse of MS 8 months after being included in the study as an healthy control. So we had her DPA PET, which showed already inflamed choroid plexuses, as it is the case in patients. So we were discussing about stratifying patients, and also, of course, the interest would be to see the effects on DPA PET of treatments. There has been very few number of studies with very limited number of patients indicating that natalizumab and fingolimod are able, at the group level again, to reduce innate immune cell activation in lesions and in normal appearing white matter. So what we are trying to do now in a study with ocrelizumab is try to look at the effects of ocrelizumab on innate immune cell activations, but again, starting from individual maps of innate immune cell activation and seeing whether patient by patient we see an effect after the treatment. So this is a design of the study that we can propose for phase 2 trials targeting microglial activation, and so 6 months trials, treatment with placebo, so individual profiles before and after, and comparison between them, and a preliminary tentative sample size calculation that we have done is 58 patients per group. The problem is that, of course, TSPO is not completely completely 100% specific for microglia, and most interestingly, most importantly for us, is that it does not discriminate between pro-inflammatory and homeostatic microglia. So there is now a big effort in trying to develop new and more advanced PET tracers, including PET tracers targeting the macrophage colony-stimulating factor 1 receptor, which is completely exclusive for microglia, and also the targeting the purinergic receptors, which can identify homeostatic microglia in the case of the P2Y12 receptor, and the P2, for example, X7 receptor, which would identify pro-inflammatory microglia. So these are ongoing studies. Let's move on to the use of PET to explore myelin. So the idea of using PET to explore myelin came from the first observation that BMB, which is an amyloid tracer, PET tracer, was also able to stain myelin in experimental studies. And following this first observation, a number of further observations has been made always in the same sense. Amyloid tracers are able to stain myelin in experimental models. And among these tracers, there is also the Pittsburgh compound B, which is what we commonly use to explore beta amyloid plaques in patients with Alzheimer's disease. And this is the tracer that we used a few years ago now in the first study exploring demyelination and remyelination using PET in patients with MS. So it was a small cohort of 20 patients with active multiple sclerosis. And we performed the PET at baseline and also MRI, and then again after 2 or 4 months. So this is a typical MRI scan of a patient with MS. You can see a lesion here, and then you can see a reduction in the tracer binding reflecting demyelination corresponding to the lesion. And these are the group results at baseline. As you can see, the tracer binding decreases from normal appearing tissues to perilesions to lesions, and then the lowest levels of tracer binding and therefore of myelin are found in black holes, reflecting the same gradient that we can find in histopathological studies. But again, the most interesting results came from the longitudinal study, where we did the same thing that we did with the TSPO. So we generated individual maps of demyelination and remyelination. And we could find, this is an example of a map of demyelination. We found, even in the same patient, a large heterogeneity. So there were lesions completely demyelinated, other lesions that were relatively spared. The same for remyelination. Even this is in the same patient. So lesions that were not remyelinated, other lesions that were very extensively remyelinated. And we found a very important heterogeneity across patients. For example, this is the case, very illustrative case of 2 patients of our cohort, 5 years of disease duration, both of them, very high lesion load, both of them, very high level of demyelination, both of them, so they both actively demyelinate over time. But the real difference is that this patient here on the left does not remyelinate at all, as you can see from the blue voxels, whereas this one here on the right remyelinates extensively. And the other difference is their clinical level of disability. So this one, after 5 years, already walks with a stick. This one has, after many years and many active lesions, she still has EDSS 0. So when we looked at the clinical correlation, we confirmed this observation because we found no correlation between the index of demyelination and clinical disability and the strong and inverse correlation between remyelination and the disability levels of patients. Meaning that, again, remyelination is patient-specific and really reflects the way each patient responds to a demyelinating insult through reconstruction, and that this remyelination potential is critical to determine disease evolution and disability. Following our first observation, other groups have reproduced the same results, in particular at the group level, showing this reduction in PIB uptake from normal appearing tissues to lesions. So we use the same approach in the brain study that Alessandro just talked about. This is a study, Matteo Tonietto is the first author, again from the team. So he explored a discovery cohort with relapsing remitting MS with PET, and then a validation cohort explored with MTR, looking at the regionalization of myelin repair and about the impact of this regionalization on neurodegeneration. What he found was that whether patients were good remyelinators or bad remyelinators, their level of remyelination failed around ventricles in everyone. So there was no exception. Whereas the opposite was for demyelination. So demyelination was the highest close to the ventricles, and then it decreased and with distance, whereas exactly the opposite was for remyelination. To the point that the probability of voxels to remyelinate over the follow-up increased by 2 0.2% for each millimeter of distance. So really, the more you get distant from the ventricles, the better you remyelinate. So what is the explanation for this? We tried to formulate a number of hypotheses. Maybe there is a low arterial blood supply and therefore a subsequent increased OPC's vulnerability to hypoxia in this region, or maybe there is a blockade within the oligodendrocyte linear maturation exactly in this side of the brain. Or finally, there is one of very popular hypotheses stating that there would be CSF-derived factors affecting remyelination in the surrounding tissues, so in the periventricular regions, possibly through the activation of microglial cells. The very interesting result that he also obtained was that this failure of remyelination in periventricular regions was strictly correlated with neurodegeneration, because what he did, the disconnectomic study, and he found that the failure of remyelination only of periventricular regions was associated with a very significant reduction in cortical thickness in connected regions. And this was not the case for subcortical lesions. So really, the failure of remyelination in periventricular lesions seems to be crucial in determining neurodegeneration. Which is the best tracer that we should be using in future studies to explore myelin? It's not PIB, I can tell you. This is what Sylvain Oviti and Matteo Tonietto found in a study on baboons. So they compared different PET tracers, and they found that the floor beta Ben and the floor beta PIR seems to be much better than the PIB in terms of providing a better white matter-gray matter contrast. Sorry. And indeed, it is the floor beta PIR that has been used in another study from the London group to explore differences between lesions and normal appearing tissues. Again, we propose a design of phase 2 trials of promyelinating treatments, and we will actually be applying this exact design in a study about Ifemprodil, which is a promyelinating treatment. So we are starting it right now with PET. So there is a running phase, because of course we need a longitudinal study to define the baseline level of spontaneous remyelination in patients, and then again 6 months comparing treatments with placebo and seeing whether individual profiles of patients change after the treatment. The future is possibly not amyloid tracers. There is another field of research very interesting, which is about tracers targeting axonal potassium channels, which actually provide a positive signal, so they become exposed upon demyelination. So very interesting way of seeing things. And there is myelin loss demonstrated in rodents and monkeys. There are not data available on humans, so I will be able, I hope, to give you something more if this team will produce data on humans in the next future. And then I will just move towards another way of using molecular imaging with sodium imaging to target energy dysfunction. There has been many important works made by several groups using sodium imaging. In particular, there is the New York group, the London group, and also the Marseille group, who basically found that there is an increased total sodium concentration at the group level with important clinical correlations. There has also been loss of interest in the gray matter, because it has been shown that there is an association between the total sodium concentration in the gray matter and clinical and cognitive scores independent of gray matter atrophy, which is very important, and which maybe indicates that really total sodium concentration reflects an energy dysregulation which precedes neurodegeneration. And then this is a very recent study from the Marseille group showing that these gray matter sodium abnormalities and thalamic volume, and only these two metrics, were able to differentiate benign patients from non-benign patients. So again, really we are able with this technique to capture really important and clinically relevant information. What we are trying to add to the table, so once again, is trying to move from the group level to the individual level and trying to develop a way to stratify patients and to define individual profiles of energy dysregulation using sodium imaging at 7 Tesla. So this is the work that is currently being performed by Juliette Dufour from the team. So we have so far reconstructed the images, calibrated the images, and then applied partial volume corrections. And then what we are trying to do is really to establish maps of comparing, again, patients with controls. Voxel by voxel, we generate a healthy controls-based atlas of normal values of sodium imaging, and then comparing voxel by voxel patients with controls. We define for each one individual cartographies of voxels showing more than 2 standard deviations of sodium concentration in that specific voxel. So this is an example here. And this is an example, 2 examples from our cohort. So 2 patients, 2 progressive patients with the same disease duration since the onset of clinical progression, so 3 years in this case. But as you can see the colored voxels are the voxels characterized by elevated and increased amount of total sodium levels. And you can see that this patient, compared with this one, has a very different level of energy dysregulation reflected by total sodium concentration in all tissues. And indeed, this is separating gray matter, normal appearing white matter, and lesions. So this one has extensive damage, extensive with really increased levels of total sodium concentrations in all tissues compared with this one, with the same disease duration. We are starting seeing some clinical correlations, so it's really the beginning of the statistical analysis, but we're finding correlations in particular with the total level of sodium in the gray matter with the evolution of clinical scores, but also in lesions. So we are trying to look at this in further detail. Because, of course, what we are interested in is, of course, total sodium, but more than this, we are interested in intracellular sodium. What we are trying to do for the first time is using the information provided by NODDI to separate intraneurite and extraneurite fraction of sodium in order to be able really to focus specifically on the individual profiles of intracellular sodium concentration. This is exactly what we are doing now. So in conclusion, we can say that really molecular imaging offers us a unique opportunity to really get close to the biology of the disease. So on one hand, to understand the physiopathology of the disease, and on the second hand, to really define and phenotype patients on a mechanism-driven framework. And of course, this use of this technique can really help us to stratify patients and may accelerate really the development of specific treatments targeting each one of these specific mechanisms. And with this, I would like to thank all my team, which is led by Bruno Stankov and Katrin Lubetsky, and I would like to thank you all for your attention.
Are there any questions? Yes, please.
So
Martin.
I have a question about the controls you're using to make the threshold. So just thinking about the myelin, you're using age might affect myelin. So you have controls for each decade. You are making a threshold for each decade. Maybe for innate immunity is maybe easier. I don't know. There is the age issue in making this threshold, I guess, as has been, used for other biomarkers. You are taking account these or?
No, of course we are using, these are small studies, so we made sure that we used, of course, controls which are age matched with our population of patients. And also we are, of course, adjusting for age every single statistical analysis that we make. This is a good observation, but we are doing nothing more than actually correcting at each single step and making sure that the healthy controls are age matched.
So at this point you don't have like an atlas of controls?
No.
No,
we are using
like group studies and you are matching.
I'm matching for age, and of course using Z scores, I'm taking into account voxel by voxel. So we are doing voxel by voxel, not only the mean, but also of course the standard deviation. And I'm taking only those that are certainly demyelinated and then therefore certainly remyelinated over time. And I am so taking into account all the standard deviation of all the across the whole.
Okay. you very much.
Other questions? Christine?
Thank you for your very nice talk. You mentioned twice this rim lesion with active center, and you asked for a question earlier. Is there any way to detect this active rim lesion in conventional MRI or susceptibility imaging, or is in clinical practice?
The homogeneously active lesions.
Yeah, yeah.
This is exactly what I asked to Martina, because I was very interested.
But do you have any insight of the answer?
No, I don't have any insight of the answer. What we are doing now is that we are looking for it ourselves. So what we are now analyzing the data from a study where we have PET, and we have also the QSM. So where we are looking at, there is a student who just joined us exactly to look at this. What we are looking at is what is the correspondence on QSM scans of the sequences of the what we define as homogeneously active lesions. It might be lesions that Martina was just describing just before, lesions characterized by dots of signal inside the lesion. So it might be that. So I hope in a few months to have the answer.
I have a question, Benedetta. It's related to the fact that the very interesting finding that you showed with the decrease of remyelination in the periventricular regions. It's known that the accumulation of myelin debris would impede or might impede the remyelination process. Do you think that this could be an explanation for the decrease of remyelination in the periventricular regions? And do you have any data about the fact that it's a decreased region with microglial infiltration or macrophages that would not clear these myelin debris?
Actually, I don't think that this is the case, because we have got the other study from Émilie Poirion showing that in the periventricular regions there is more activated microglia than in the rest of the brain. So possibly it's not that. Well, I mean, what we think and what is really the most popular hypothesis is that of something related to the CSF. There might be components or cytokines that really activate microglia, and through that, through an abnormal and pathological activation of microglia in the surrounding tissues, there is a sort of inactivation of remyelination. But other hypotheses remain also viable, such as, for example, a problem in perfusion that might really impact on the OPC function and in myelin repair.
So again, the energy failure, you think, or when you say perfusion, is that because of the decrease of the oxygen?
It might be because of the decrease of the oxygen, but again, we don't have any evidence of this. We are exploring this in much further detail. We are trying to see, there is another study that we are conducting right now, where we are trying to look at the impact of low perfusion and hyperperfusion on lesion formation. So again, we are trying to see how these two variables really interact with each other, and we are finding very interesting results, actually, because it seems that there is a phase of hyperperfusion that precedes the lesion formation. So there is certainly an effect of changing perfusion levels in lesion formation, and therefore we have reason to think that there might be an effect also in the failure of repair.
Of remyelination. Okay, thank you.
Arterial, or which level of the
arterial
perfusion?
Yes.
They have blood support, I imagine. Blood support.
Thank you, Benedetta. So it was really interesting. So perhaps I'm a little bit curious about your model using NODI in order to separate intra and extracellular sodium. Do you use also for the acquisition, for sodium acquisition, some methods allowing to separate mobile and restricted sodium, or do you take only the VTSC with your model?
No, we don't. We don't actually. So that was the real challenge, is trying to do it after the acquisition, trying to separate the two. And so we have started a collaboration with Mara Cercignani in Cardiff, who actually developed an approach to use NODI, simply acquired on the 3 Tesla, so this is acquired on the 7 Tesla, in order to separate the intraneurite and extraneurite space. So this is very interesting and very useful for the white matter. There are challenges, further challenges for the gray matter. We were discussing the other day with Juliette, because it's really about neurites. But in the gray matter is much more complex than that. So we will ask for your help to find some other solution which is viable for the gray matter.
So, thank you.
Thank you.
No. C'est toi qui gères.
Okay, thank you very much. So we finish with the last session of the morning, which is dedicated to short oral communication of the RCEP community. And the first talk will be given by Ismail Koubir from Amsterdam. So, please.
Yes, so good morning. First of all, I would like to thank the organizing committee for inviting me to present our work here today. So I'll be talking briefly about our work on pixel-based white matter degeneration that could predict future cognitive impairments. So as we all know, we know that MS has been vaguely and for a long time described as an inflammatory and disseminated disease of the central nervous system, but with more and more important role, as we have seen, for neurodegeneration in the last years, such as neuroaxonal loss or damage. And we know that during the course of MS, many patients will experience cognitive deficits, which will profoundly impact their quality of life. And this association between cognitive impairment and brain atrophy has been shown in a lot of studies. And we have also seen that there was probably a greater contribution from gray matter atrophy compared to white matter atrophy in explaining this cognitive impairment. But we have to keep in mind that so far, white matter atrophy has been assessed using some conventional volumetric measures. And these conventional volumetric measures, as we heard, they do not consider the full complexity of the white matter architecture. And so currently we have diffusion-weighted imaging that allows us to investigate the white matter tract architecture in vivo. And we know now that the white matter architecture is very complex with many crossing fibers, and that these crossing fibers can represent up to 90% of the whole white matter voxels that we have. And so the majority of MS studies have used DWI using the diffusion tensor model, as we have seen. But this model is very limited in terms of extracting the right measures for crossing fibers, and they cannot be very specific to certain fiber pathways. And so our aim here is to try to circumvent these problems using a novel approach, the pixel-based analysis, which will allow us to really have some statistical analysis on the tract-specific pathways, using what we call the pixel, and basically the pixel will just refer to a specific fiber population within a certain voxel. And here, as you can see, for example, in certain regions here, you have some crossing fibers. So here you have 3 different fiber bundles with like superior longitudinal fasciculus, corpus callosum, and here cortical spinal tract. And we can see that with this method, you could really differentiate the different fiber bundles. Maybe to compare it quickly to DTI models, you can see here that in certain cases where you have crossing fibers, what could happen is that you could have some damage to one specific bundle. Let's say here the superior longitudinal fasciculus, here in green. Once you have that certain damage, what could happen is that you will have less amplitude here in that tract, And what could happen is that you will have more directionality in the tensor, right, for patients. So what you will get at the end is that you will have an increase, for example, of FA in that certain region, while what's really going on is that you have some damage that you are not capturing with your model. So this model will allow to maybe circumvent these measures. So the aim of the study was to investigate, using this novel pixel-based approach, specific patterns of white matter degeneration, their evolution over time, and the manifestation across different stages, and finally also their role in explaining cognitive impairment. And to do that, we have used a cohort of 327 MS patients, 95 healthy controls, and with a large subgroup that was followed over 5 years. We have acquired some MRI for them, using, most importantly here, the diffusion. And also we have, these patients also underwent some large cognitive testing and have been classified afterwards as cognitively preserved, mildly cognitively impaired, and cognitively impaired. And here, just to show you quickly the measures that we will be using. So here you have an example of a representation of a normal fiber bundle. And here you have the first measure, which will be the fiber density, which is basically a microscopic estimate of the density of the axon, proportional to the intra-axonal volume, and a decrease could, for example, indicate the axonal loss. You will have also a fiber bundle cross-section, which is more of a macroscopic change in the cross-sectional size of the fiber bundles, which is closer to what we know about like the white matter atrophy, which could be induced by the narrowing of the extra-axonal space here due to axonal loss or demyelination. I have to specify that here, as it has been said before, diffusion is really not specific or very sensitive to myelin. So. And finally, we have a combination of the two previous measures, which will be incorporating both micro and microscopic changes, which is thought to be very sensitive to the capacity of white matter to transmit information. And so we started by looking at the whole brain level, and what we saw is that first, we just compared MS patients and healthy controls at baseline, and we saw that FC decrease was more spatially extensive compared to the fiber density, but with smaller effect sizes. And as you can see here quickly, the majority of streamline segments that were associated to altered pixels were spatially independent from lesions. Then what was really important for us is to go and look at tract-specific analysis. And what we did is that based on the whole brain analysis, we considered the significant pixels, and based on an atlas of white matter tracts, we only considered the tracts that had or included significant pixels. And those were included in our further analysis. And what we saw, for example, at baseline here is that SPMS patients had the highest alterations among the groups, followed by PPMS, which in the majority of cases showed similar damages compared to relapsing remitting patients. And if you go and look in a longitudinal way, what we saw was that PPMS patients showed more changes compared to relapsing remitting patients, which could indicate a stage-specific spreading of damage. And finally, we also saw that FD showed more severe changes compared to FC, and the reduction of FC was specifically detected in secondary progressive MS patients. So probably a reduction of FD might probably be present maybe in the early stages of the disease, while measurable changes in FC, for example, cannot be seen yet. And these changes in FC might probably occur and be more pronounced later in the disease, leading for probably some irreversible large-scale axonal loss. If you go and try to look at the difference between the different cognitive profiles, as expected, you will find that there is a continuously lower integrity from CP to MCI and to CI, both at baseline and follow-up. And finally, what was important for us also was to see if we could predict some future cognitive decline. And that was the case. We were able to predict cognitive decline 5 years after with baseline pixel-based measures. And here, as you can see, there was an important role for the inferior and superior longitudinal fasciculus, cingulum, which are very important. Why? Because we know that these are tracts that are connecting the default mode network that is very also important for functional reorganization and cognitive functioning. And so to summarize, here I hope I convinced you that functional pixel-based analysis could allow the extraction of measures that are directly associated with single fiber populations with more sensitivity and specificity, especially considering complex white matter fibers. We saw that these pixel-based approaches can be sensitive to white matter degeneration in MS and can have a strong predictive value for cognitive impairment. And we also saw that longitudinal deterioration was mostly marked in progressive MS, which indicate that maybe this degeneration in white matter remains important to characterize further, especially in this phenotype. So I'd like to thank you for your attention and thank especially the financial support of RCEP for this project. Thank you.
Thank you very much, Ismail. We have time for 1 or 2 short questions. So,
very shortly, did you combine this with the functional MRI approach to have a proxy of what happened in the functional systems?
No, that's the next step.
And is this, can you apply these metrics on the gray matter region, such as cortex, where you have a lower level of myelination?
Not really, because here the idea is that in order to get these very sensitive measures, what you have to do is that you have to take out the effect of both CSF and gray matter. So that's very important to do that.
So it's for bundle in the white matter.
Exactly, it's very specific.
And last very short question, but is there a specific involvement of pathway connected to the thalami compared to other tracks? Or?
I mean, there was. They're just like, it didn't show up in our prediction analysis, but it was also very impacted. We saw like the specifically the anterior radiation of the thalamus were very implicated as well, but just not at the level of the prediction. So it's interesting because it's a difficult question. We did compare, and there are studies now that try to compare them. You have more information. That's something very important to know. I think you have more information, you have better association with clinical disability or cognitive impairment, that's for sure. But I think where it is very important is for the interpretation that we do from our data. I think that's where it's very important to consider maybe these kind of models compared to the normal ones, because with the normal ones, with the diffusion tensor, we know that we can have some, as I showed sometimes, we can have some higher FAs that could appear. There has been studies that showed like higher FAs over some kind of rehabilitation trials. So we have to think that maybe this is not the right interpretation and try to use maybe some novel models like this to maybe correct for that, and these maybe better have better specificity for that.
Thank you very much. So I think we have to move on. So the next talk will be given by Samantha Notebook, again from VMS Center in Amsterdam.
Yes, thank you for the opportunity to present our work here. And in this study, we use clinical MRI data to study the effect of natalizumab, vigolimod, compared to low-efficacy treatments on the development of brain atrophy in multiple sclerosis. These are my disclosures relevant to this presentation. Natalizumab and vigolimod are high-efficacy disease-modifying treatment options for patients with relapse-remitting MS. And despite their strong clinical and anti-inflammatory effects, the effects on brain atrophy are still largely unclear. In clinical trial data, they compared their effects on brain atrophy, and they found that for natalizumab, there was no difference with placebo, probably due to pseudo-atrophy effects. And for vigolimod, they found some positive results on the development of brain atrophy compared to placebo and to interferon beta. However, these clinical trials typically have a follow-up of like 2 to 3 years. So the long-term effects of these compounds on the developmental neurodegeneration are still largely unknown. Therefore, the aim of our study was firstly to investigate the effect of natalizumab and fingolimod therapy on the development of long-term brain atrophy compared to low efficacy DMT. And our hypothesis was that after the initial pseudoatrophy period, natalizumab and fingolimod will slow down brain atrophy compared to low efficacy treatment. And secondly, in this data set, we also, because we use clinical 3D FLAIR scans, we also want to see if we can validate expected longitudinal relation between brain atrophy and the development of disability. For our study, we included from our clinical database patients with a relapse-remitting disease course, aged between 18 and 65 years, and who have been treated with disease-modifying therapy. And we went back to their clinical records and collected age, sex, and diagnosis date, their medication history, and their EDSS scores. And we also collected their clinical 3D FLAIR scans, and we only included the MRI scans taken at least 1 year after start DMT to correct for pseudoatrophy effects. And we also only, because we wanted to study the longer-term effects, so we only included patients that had a longer than 2-year follow-up from the start of DMT, and we wanted at least 3 scans available to reliably determine the brain atrophy rate. For brain segmentation, we used a novel deep learning method called SynSec, which is robust against different contrasts and resolutions, and we use that on the high-resolution 1 millimeter clinical 3D FLAIR scans. And for brain volume outcome measures, we derived the brain volumes, ventricle volumes, cortical volumes, and thalamic volumes. Secondly, we also use a novel technique, source-based morphometry, to analyze the gray matter partial volume maps of all subjects obtained from the SynSec segmentation. And we spatially normalized all these partial volume maps, and then we ran independent component analysis to decompose this data into 10 gray matter patterns and the pattern loadings. And the pattern spatial maps, they represent the most covariant patterns of voxels across subjects. And the pattern loadings, they represent the amount of atrophy in a pattern for each subject. In total, we included 200 patients, from which 90 used low efficacy treatment, 67 natalizumab, and 43 fingolimod. And you can see that age, sex, disease duration, and EDSS at start treatment was similar across groups. However, the fingolimod group had a slightly higher disease duration at baseline at start treatment. And the total follow-up was 5 to 6 years after start DMT and similar across groups. We first investigated the effect on the whole brain volume rate, and we didn't find any differences between the low efficacy and high efficacy treatments. However, what we saw that the brain volume was decreasing over time as expected, and also age, disease rate, thalamic volumes, cortical volumes, there was no difference between treatment groups.
Usually atrophy is measured on the 3D1C. When you use this one, when you use FLAIR, which
yeah, it would have been perfect to do this like on the 3D-T1. However, in our clinic, they don't acquire these high-resolution scans due to time constraints. So what we have, also according to the MACNIMS recommendations, we only have a high-resolution 3D FLAIR, PDT2, and other sequences in our protocol, but we don't have this additional T1 weighted sequence.
Thank you very much. So I think we have to move on, and I ask the last presenter, Khushbu Punjabi from Marseille.
Good afternoon, and thank you for giving me the chance to present my study over here. Just before the lunch break, Mars or Snickers, what do you prefer? So I present to you a study, fMRI-based study of reference-based decision-making in multiple sclerosis. So to present you with some context why preference-based decision-making is important, most of the MS patients belong to the age groups of 20 to 50 years, which is the time period of making important life decisions like motherhood, career choices, life goals, etc. When divided based on their cognitive phenotypes, about 50% of these patients have mild to severe multi-domain cognitive impairments. And a major part of these cognitive impairments is decision-making. And about 34% of MS patients have been shown to make impaired decisions in risk-associated and ambiguity-associated gambling tasks. And as mentioned before, there has been shown to be gray matter atrophy associated with the areas implicated for these gambling-based tasks. In a behavioral study recently, Zariman and colleagues also showed that when presented with the same amount of information as the controls, MS patients made sampling errors of this information and still made irrational decisions. Why is all this important? Because in the pattern of shared decision-making with their physician, preference-based decision-making is important to take into account their life goals, values, and hence make the choice of a treatment plan. As I said, most of the studies in fMRI literature for decision-making in MS are risk-based decision-making or gambling. This takes into account the economic cost or the reinforcement associated with the choice presented. These studies exist in the literature, but preference-based decision-making, which takes into account discriminating between the categories, or discriminating and categorizing the information presented, they are missing, which is important for shared decision-making. So in order to fill this gap, our first objective was to identify the impaired functional networks in MS patients, which are involved in preference-based decision-making, and also to compare the global brain activity between controls and patients at the time of object value assignment. In order to do this, we adapted this task from Pissarro and colleagues, which is based on food. What better way to look at preference than food choices? So before the scans, participants rate 80 sweet and savory snacks on a scale of -5 to +5. And in the scanner, they are presented with combinations of these snacks based on 4 levels of these combinations based on the difference of value in their initial ratings. And lastly, to look at the object assignment brain activity, we asked them to re-rate these snacks in the scanner, the most preferred and the least preferred snacks. These are the demographics of the participants that have been recruited so far. An initial behavioral analysis showed that there was a reduced accuracy in the MS patients while making difficult decisions, that is, choosing between 2 snacks which were very closely rated. And so we used this as the basis of our functional analysis. We grouped the difficult decisions as 1, and the easier decisions with a bigger value difference of 2, 3, and 4 as a separate group. I must tell you, this is still an ongoing study, and I present preliminary results over here from the imaging data. So all the imaging data is 4 controls versus 4 patients. One important trend that we see here is that there's a shift in activations in the striatum from the caudate to the putamen in controls versus patients. And there's different localization or different recruitment of frontal areas like the superior frontal gyrus in controls and the paracingulate cortex in the patients while making easy decisions. This trend continues when we move on to difficult decisions. There's shift from the striatal structures to more pallidal structures and different peaks between the controls and patients. And the power of these peaks also reduces. So there's change in localization of activity, there's reduced power of this activity. Also, this same trend continues in object value assignment. There's more shift from more cortical activations to cingulate and striatal activations. And then, especially in negative rating, the amount of amygdala activations from patients to controls is reduced. One of the main future directions for us now is to complete the acquisition and recruitment of the patients. And this leads us to two questions. From the literature of decision-making, CODIT has been implicated to be a very important structure in object position, object identity, and object value assessment. And the cingulate is implicated in voluntary choice and value of actions. And we see that there is changed or reduced activity in these structures. As the speakers before me said very well, that there has been shown to be gray matter atrophy in these structures. Our next aim is to complete the functional analysis and then look at the gray matter atrophy, and then look if there are alternative compensatory networks being recruited to compensate for this gray matter atrophy in preference-based decision-making. And to do this, we will analyze the diffusion-weighted and the resting state data that we are acquiring alongside the functional data in this data set. And finally, this is the team working in Marseille, in Hamburg, and I thank the RCEP Foundation for funding our travels between Marseille and Hamburg. Thank you.
Thank you very much, Kishbo. One question? A short one?
Thank you, and congratulations for your presentation. I was just wondering whether there is a specific region within the cingulate cortex where you see this change. Because there is evidence of looking at parcellation of the cingulate, that different cingulate regions may have different roles or connections at least.
Yeah. So one of the important changes, maybe I have not presented those images here, is there's a shift of activity between the anterior and the posterior cingulate, especially in case of difficult decisions. Yeah. So that can be differently associated, for sure.
And what is your interpretation? What is happening? I mean, is it related to, I mean, it's speculation because you're still, doing the work, but...
One thing is that it could be related to connectivity with different structures. For example, the insula versus the striatum, because we see different activity over there as well. So yeah, this could be leading to a changed functional connectivity between the ventral frontal areas, the ventromedial cortex, the cingulate, and insula and the striatum, yeah.
Thank you very much. I think we are out of schedule. If there is no other questions, I propose to have a lunch break. Coming back in 45 minutes for the next session, the first session of the afternoon. Thank you very much for the speakers of this really incredible morning session, and see you this afternoon.
And in this session now, we are going into machine learning. We will welcome to start with Sinan Doyle, that is the CEO of Pixel, company in Grenoble. But initially you were trained in Dublin. You are an electrical and computer engineer. And you moved to France at INRIA. And then after some academic work, you co-founded and now be the CEO of Pixel. And you aim at bringing artificial intelligence to radiologists. So please, thank you.
Thanks very much. Yeah. That's a good resume of my life. I didn't even provide that, so you must have looked it up somewhere. So thanks everyone. Thanks to the organizers. Thanks to RCEP for putting in place this event. I'll just see, does that work? It does. Okay, so as was mentioned, Sinan Doyle, I did my PhD in machine learning and AI techniques for spatial systems in Trinity College Dublin, before coming to France for ostensibly a one-year postdoc at INRIA and INSERM, where I applied the methods that I did during my PhD to MRI imaging and MS segmentation in particular. So that was a long time ago, but the work that we did at INRIA and INSERM, also based at Grenoble Institute of Neuroscience, led to the creation of Pixel. So there's a big disclaimer. I know everyone skips over the disclaimer slides, but this one is unavoidable. CEO and co-founder of Pixel. So we were created in 2015 as a spin-out of INRIA INSERM. We've put in place a quality management system for the development of medical devices and CE marked our product Pixel Neuro. We're a team of 19 people at the moment. So we've grown from 3 at the start to 19 with a very active R&D division with 8 PhDs and a number of people doing their doing their PhD with us. And there's a format problem here, but it doesn't matter. The main points are there. What I wanted to talk about today is the work we did during the French Radiology Society Data Challenge, which was put in place to look at the ability to predict MS disability based on just imaging alone. And so we actually won that data challenge, and we were collaborated with a number of radiologists, neurologists on that, and I think it's kind of interesting to share it. So the underlying challenge that we have is there's the good news, first of all, is there's over 20 now treatments on disease-modifying treatments on the market for the treatment of MS. And the challenge that poses itself is how can we best optimize the treatment of patients so that they have a better outcome by giving them the right treatment at the right time. So prediction is key to this. If we can predict, we can act. And if we can understand the disability progression, we can start to inform the choice of treatment and understand the pathophysiology of MS in a better way. So we need tools to be able to do this. It's not something that's possible visually or in a simple way. And that's where machine learning then can come into play. But once we start to look at how imaging can help understand the clinical status of a patient and the progression, we're confronted with the clinical radiological paradox. So how can we resolve the fact that there can be a huge difference between what we see in imaging and what we actually see in the clinic, in the clinical status of a patient. And when we look at this image here and we understand that that is actually a patient with an EDSS score of 0, we start to understand the complexity of the task. So before we can predict, we need to be able to resolve the clinical radiological paradox, because it's not just to understand how imaging can explain the clinical status of the patient now, but it's if we want to go further and predict the clinical status of the patient in the future, this is something we need to take into account. So I just want to present 2 other examples. So this is a 46-year-old woman with an EDSS score of 3 and a 55-year-old man with an EDSS score of 3. So both clinically identical, we would say, without further information. And given those 2 examples, would be able to say which one of those 2, and just the information that I provided, which one of those 2 would in 2 years have an EDSS score of 6.5, and which would have stability and end up with an EDSS score of 3. So that was part of the task that we were set in the data challenge, and I can go back to that in a few minutes. So why is there a paradox? Well, if we accept the hypothesis that there is a correlation between what we can see in imaging and the clinical status of the patient, we have to explain why there can be sometimes a discordance between the 2. So either the difference comes from missing data, or data maybe that's not interpreted correctly, essentially noisy data. And what we can see is, we can say if we look at the clinical part, we can identify how we measure the clinical status of the patient and where maybe the errors could be located in that. And we know that, like, the relapse rate, EDSS score, other clinical scores can be very variable. They can be subject to inter-rater and intra-rater variability. They have their own, I'll go into the EDSS score in a minute, but it's kind of well known that it be very subjective. I also include in that category the ability maybe that the disability or the progression of the disease would be masked in some way by the plasticity or the cortical adaptation of the patient. On the imaging side, so this list is by no way exhaustive, and there was a lot of discussion earlier this morning about the different advanced imaging techniques we could bring into play to try and lend themselves to the prediction. But I'm focusing really on the routine follow-up. So what actually kind of information can we get from patients today without changing the clinical routine practice? There was a good discussion about what should be the next types of images that should be included in an MRI protocol for MS, and I think the answer that was given was there needs to be impact. We need to see the impact of those additional sequences on the treatment choices. So I think that when we're looking at the situation today, we have to say, well, there's information that's maybe not present in routine follow-up, like spinal cord lesions, because it's not systematically performed. We could try and bring that into a more frequent analysis. The presence of cortical lesions, so only 5%, I think, are detectable in FLAIR imaging. And even when you look at white matter hyperintensities, I think there's only 70% are visible in FLAIR. So there's imaging information that's just not present in routine follow-up that could have a predictive value. And then there's imaging information that is present, but it's not fully exploited. So the information is there, but we have difficulty seeing it, or we don't have the tools to be able to extract that information. And that's actually where we're focusing our work. So what can we put into place that will help extract that information from images that are already acquired in routine clinical practice? And so that brings me to the data challenge. It's a data challenge, and it was put in place to be a challenging data challenge. It was organized by the French Society for Radiology, SF4, in collaboration with OFCEP, the French Observatory for Multiple Sclerosis. And the challenge was to predict MS disability, so the EDSS score, 2 years after the imaging exam. And so we had access to just a single flare sequence, and the question was, can you predict? We used training. There was overall about 1,500 different imaging exams, split up into about 1,000 for training and validation, and 500 then that were set for testing. There was a time limit set that was to reflect the difficulties, or the need to have a solution to this challenge that would be usable in clinical practice. So we put ourselves in the situation where the patient is coming in for consultation, has their imaging exam, and needs to be able to, the neurologist needs to be able to, within the time of that consultation, decide on a treatment option. And the only other additional clinical data were the age and gender of the patient. So we collaborated with the Grenoble Institute, CSU Grenoble-Suga, Grenoble Institute of Neuroscience, and GHUCL, semi-private radiology group in Lille. And one of the challenges that we addressed, so I can list the things that were kind of maybe difficult points during the challenge, was one of them was the EDSS score, the use of the EDSS score. So it's well known that it has limitations, and that actually poses quite a bit of problem when we're trying to put in place an automatic system to predict disability. I think it's been spoken about earlier and in much detail elsewhere, but it's just I just want to mention that the lack of precision, the non-linearity, maybe the emphasis on motor functions, they were all lent themselves to maybe having maybe complicating the predictive task. The data distribution is as we see here. So it was heavily there was a heavy lean towards EDSS scores below 4.5, and that actually was reflected in the results that we saw at the end. So we had much greater predictive power in that range, and what we saw in the results of the challenge was that EDSS scores over 4.5. As we went up the EDSS score, it actually became harder and harder to predict. One maybe caveat to that is maybe the importance of being able to predict as you go up the EDS, the disease disability progresses, maybe it becomes less relevant. That's maybe a topic. So the data was actually very much real world conditions. So it came from 13 different cities all over France, 37 different centers. We have different different MRI protocols. We had 2D, 3D data, 1.5 Tesla, 3 Tesla machines, all of the different OEMs, constructors. So this is the data that was used for training. So overall, 856 data points. And so the idea was there was an initial flare acquisition, and then a follow-up 2 years after that exam assessing the EDSS score. We didn't have access to any other clinical information, information that could be extremely powerful to be able to predict the eventual disability. The type of MS, baseline EDSS score, the history of treatment, whether they were on treatment at the time, the history of relapses, the duration with which they had been diagnosed with MS, or even information coming from that could be ascertained from a T1 sequence like atrophy. So what was the solution to that? And I think this is really why they put in place such a challenging task. They really wanted to see how much we can leverage information that already exists in the flare sequence. So how can we go beyond what is currently reviewed in the clinical practice, as in looking at the stable, enlarging and new lesions, and how can we decompose maybe the lesions that are present into their constituent parts, being able to understand what are the characteristics of those constituent parts, and maybe that has some effect on, or some ability to reveal the underlying workings of the disease progression. So to do that, we echoed what we had put in place in our product, where we have a deep learning CNN, so convolutional neural network, which kind of mimics the optical cortex of the brain, and we feed that, we populate that neural network with data that's representative of the target population and that has been annotated well. Okay, so annotated not only just in terms of the hyperintensities in the brain, but what are MS-specific hyperintensities, and can we characterize those hyperintensities even further? We use transfer learning techniques to bring evidence from other models that were successful to bear on the task, and at the end we got an idea of how well we were implementing a prediction, the probabilistic map, and how to characterize individual lesions. So that fed into the characterization task that we set ourselves. So where we're trying to divide lesions into maybe lesions that have more sense from a pathophysiological point of view, classifying them into stable growing and new lesions, but also localizing them according to the diagnostic criteria. And we knew that to actually go further, to be able to, in a context where we only have a flare image, there's other I suppose effects that should be reflected in a solution that would effectively predict. And so we added a deep white matter tract atlas. So first we constructed it, and then we registered it to the target population. And we looked at how the lesion load and the lesion activity interplayed with the tracts, and that's from that information we were able to provide over 100 different features, so points of information that could have a predictive value to a variety of different predictors. Okay, so we had a CNN model, a random forest, and a manifold learning technique. And we used the aggregation of those predictors to actually arrive at a 2-year EDSS score prediction. So the interest in doing that is that the CNN model, so it's very powerful. It's what the kind of all the buzz in the past few years has been about very powerful, but lacks explainability, lacks interpretability, and we knew that we would need to be able to provide a kind of an understanding as to why we arrive at a certain conclusion for it to have any importance or any relevance in a clinical setting. So that's why we also put in place random forest and manifold learning techniques. So the advantage of the random forest technique is that it's very easy to explain why we arrive at a specific conclusion. And the manifold learning technique was interesting because it reduces from a high dimensional space to a low dimensional space relevant features for prediction. So we can get also an idea of what features are playing the most important role in the prediction. So here we have the list of the predictors that we put in place, and we, by combining them kind of cleverly, we're able to get an aggregated model which has a much better performance than each of the individual predictors on their own. We did compare it to an age only, so we're just using the age to arrive at a prediction of the disease progression. And that's kind of like a benchmark. We wanted to ensure that we weren't just tracking the age of the patient as a predictor, and we needed to ensure that we were actually getting information from one of these other sources that lend itself to the predictive task. So as I mentioned, did I say it there? Yeah, so this here we have the validation data set. We got 2.2 as the mean square error. And on the actual test data set, we got a mean square error of 3. So that was the task set on the day of the challenge. So we don't have access to any of the other information on the individual models because that was actually hidden from us. It was a blind test. But what we did see was that the mean square error for patients with EDSS scores less than 4.5 was 1.1. So quite a good performance given the task is to track EDSS score. And as we increased the disability of the patient in front of us, then we had more and more difficulty in being able to predict 2 years down the line what the EDSS would be. And that goes back to the fact that the population of data that was used for the training was heavily leaned towards patients with EDSS scores less than 4.5. So we would hope that with a larger data set, we would be able to address that. We would be able to reinforce the predictive power for all types of patients. So one of the interesting things that came out of the analysis, and in particular the use of the random forest predictor, was that we were able to determine what were the variables with most predictive power. And we saw that the lesion loads in certain tracts of the brain that were heavily involved in motor function came out as the primary variables that had a predictive power. We also had the age of the patient, obviously, and then interestingly enough, the volume of the lateral ventricles extracted from a flare sequence. So I suppose reflecting in some way as a surrogate biomarker for the atrophy in the brain, and that came out naturally from the analysis. The results of this then are published in the article if anyone wants to go into more detail. And so to go back to the example I presented at the start, this is one example from that challenge where the age-based regression for the 46-year-old female was 3, so it was a stable progression, and we got that as well. And for the 55-year-old male, the age-based regression actually predicted 3.5, whereas we got it right with 6.5. So I think it's only one example, but it's just maybe it demonstrates that there can be a benefit to using imaging to predict disease progression. And we tried to understand, well, why were we able to determine this EZSS score for this particular case, which looks quite, they look quite similar at the first time. What were the differences between these two patients that led to the different prediction? We saw that there was a different lesion load in the corona radiata, and there was actually slightly different ventricle volume, and it was those two features that actually made the predictor perform in this way. So going one step further and building on the work that we did in that challenge, we put in place a partnership, a collaboration with the OFCEP to get access to more data, but also then opening the door to using additional variables that could be interesting for prediction, like as I mentioned before, MS type, information on the EDSS and treatment history, and getting more information on the atrophy in different regions of the brain, cortical atrophy as well, that could be ascertained from the T1 sequence. So that's a study that's actually in place at the moment. We're performing that with OFCEP. And so that, I suppose, maybe next year we'll come back and present the results on that. And maybe I just finish by showing how we've tried to integrate that in parallel. So in parallel to the BreakOx project, we were very mindful of the fact that we want to be able to put these tools in the hands of clinicians, in the hands of researchers. And we've integrated with a PACS system in the hospital where we can access the patient FLAIR images, look at the uncertainty that the AI algorithm would have in detection and characterization of individual lesions, look at how they are superimposed with an atlas of tracts, and that's why basically to understand a bit more detail why the algorithm arrives at a certain EDSS score, because it's not just about the ability to do it, but it's about how can we explain why we arrived at that results and how can we interpret the results. So there's a whole other domain of work there that we need to look at. Once we're able to do it, how can people trust the algorithm? And that's maybe a topic for another day. And I'd like to finish maybe just by mentioning an honorable mention to the Primus RHU. So it's a related topic. I don't think there's anyone today talking about it, but it's a related topic, but it's interesting as well. So it's not prediction, but it's projection in multiple sclerosis. So using databases like the OFCEP database, but also clinical trial databases from pharmaceutical companies, Biogen and Merck are partnered in the RHU. And it's work that's performed with our friends in Rennes and Nantes. The ability to project a patient of reference into, a patient of interest into a patient of reference, population of patients of reference, understand that the trajectory of their disability, of their disease progression, match it with a patient in the patient of reference database, and essentially provide information to the neurologist as to the potential effects of prescribing a certain treatment to a particular patient. So it's interesting work. It's not prediction, it's projection. It's using huge databases, but is also could be very promising for addressing the issues. So thank you. Thanks.
Thank you very much. And obviously, this was not as simple as the abstract led to think, and there is a considerable amount of work and preparation and input. So before even asking a technical question, I'd like to ask the floor to the colleagues whether you have questions.
In the way you treated the data, did you take into account the lesion load, supratentorial lesion load? Because I think if I well understood, you had for the training and for the analysis as well, cohort, you had 35% of flare that were 2D. And as we know, lesions on flare 2D are very bad for the supratentorial, infratentorial way. Sorry,
oh, yeah.
infratentorial.
Yeah.
Sorry, excuse me.
Yeah.
And that's where that's 35 2D dimensional. So did you take into account infratentorial and not supratentorial lesion load for this analysis, please?
So it's a good question. The difference between infratentorial and supratentorial lesion detection, it's well known. It's something that we've focused a lot on. We've actually have a separate model for detecting infratentorial lesions because they have different characteristics to the supratentorial and need a bit more sensitivity to be able to detect them. So it wasn't something that we put in place specifically for the challenge, but it's just for the algorithms that we develop in our daily lives. That's something we addressed because it is the real world. We do get confronted with 2D data, and we need to be able to interpret that effectively. So yeah, we didn't discount any data or any information from coming from the 2D images. We just tried to maximize the chances of detecting lesions in the infratentorial region. Yeah.
Hi, thank you for the nice talk. Just had two short questions. First one regarding your model. If I understood correctly, at the end you considered a model with like you aggregated different models, right? And when you get like the interpretation of the outputs at the end, you only consider those that you can get, of course, from like random forest. So you probably have others, right, that are coming from the CNN that you don't know about, or
yeah, you're right. Yeah, exactly. It's a good point. Yeah, so we can only determine the predictive value of different variables from. So this is what you're talking about here, I think. So this is coming from the random forest model. Yeah, we could have got it from the manifold learning model as well, but we didn't. This is just from the random forest. And what happens in the convolutional neural network is a mystery. It comes out, it's got very good performance, but we don't know why, and that's the problem with CNNs. Yeah.
And for the let's say kind of general interpretation of the model, do you think that we can really say that it will predict disease progression, because you don't really have like a baseline EDSS, or is it more like a cross-sectional design that you have at the end, you know?
Yeah, so the challenge was set in such a way that we had to predict the EDSS score. It wasn't a binary decision of progression or stability. It was an EDSS score. Now we're changing that for the Breakox model, for Breakox project. It's not, even though we have access to the EDSS score at baseline, we are we will be predicting the EDSS score, but the actual outcome, the clinical point of interest, I think, for the clinician is progression or not. So it's not necessarily a case of having to predict the EDSS score, and part of that goes to the fact that we don't think that's a good metric to be using. I think it's well, it's all the faults that I listed earlier, but yeah, heavily reliant on certain functional systems and maybe not taking into account others, and who is to say what is the best functional system to be emphasizing. I think whose talk? I think it was in your. No, it was your. There was someone mentioned earlier that there gave a reference to the paper where a doctor would accepted that they're not the best at judging the quality of life for a patient. That's maybe goes back to that concept. Yeah.
Are there other questions? From the aim that you have to integrate that in a PACS, is the neural network accepting whatever plane, whatever matrix, or are there strict conditions on the examination that will be possible to?
Oh, so you mean in terms of the protocol that's put in place? So we do have quality control checks. We have to make sure that the data that we're analyzing is sufficiently close to the training data. Yeah, so there are control checks, and we will either give warnings if it's not so far away, or we will refuse to analyze if it's too far from the training data set. Yeah, that's the way we work at the moment. And so we put in place this system here to mimic the medical devices that we have already on the market, because we know that that's the demands, that's the threshold that we need to meet to be able to put a product on the market for that.
So you talk about data augmentation. So what was the strategy and the percentage of you have done?
So I should have I have some good slides, but they're not here, about the data augmentation techniques that we perform. We've put a lot of effort into that, because to be able to put in place a system that's robust, we need to be able to account for the variability that we see in the real world, and it's very difficult to get sufficient real world data to be able to account for all of that. So we do data augmentation to multiply the real world data to make a data set that is as diverse as possible. And we take into account maybe the MRI characteristics. So we're not applying techniques that would be applied to, by, I don't know, Google recognizing cats and dogs or whatever. We're taking into account the physics involved in acquiring an MRI. And we're able to do that to such an extent that we can, when we get an image, for example, that's acquired on a Siemens 3T, we would modify it so that we have the similar patient that was acquired on a GE or Philips. We can actually change the style of the image. That's the way we call it. The style of the image, so that it resembles an image acquired on a totally different MRI. That's one example. Then we also, use deformation techniques, all the standard artifacts. We add in artifacts. So that the eventual product is robust to all of that. Yeah.
Okay, so I think thank you very much for your presentation.
Thank you.
So don't hesitate to ask questions by the chat. It was not the case for the moment. So we're going to move to the next speaker. So it will be a remote speech from Giuseppe Pontillo. Dr. Pontillo is a neuroradiologist. He's performing, he's a Magnims Research Fellow at the University College of London. He's currently working at the Advanced Biomedical Science University of Napoli, Federico II, in the Department of Electrical Engineering and Information Technology. His research focused on the application of advanced neuroimaging techniques and statistical and machine learning methods for the in vivo characterization of CNS pathophysiology and its clinical correlates, with particular reference to neuroinflammatory and neurodegenerative disease. So he's going today to talk about stratification of patients using unsupervised machine learning with a single MRI.
Good afternoon, everyone. Can you hear me?
Yes,
Can you
perfect.
see the slides? Okay, it's perfect. Thank you so much for the introduction. I'm very sorry for not being there in person, and thanks to the organizing committee for inviting me to give this talk. As you said, I will talk about how to stratify patients with MS based on MRI using machine learning. Okay, trying to change slide. Okay, I have no relevant disclosure for the topic of this talk. I'm going to give a very rapid introduction about the general topic, and then I'm going to talk about the two big families of machine learning approaches that we can use for the specific purpose of stratifying patients with MS based on MRI. Just to put everything in context, this has been already expanded in the previous talks, but basically multiple sclerosis is a very heterogeneous condition from the neurobiological point of view, from the phenotypical point of view, from the genetic point of view. Of course, when we talk about multiple sclerosis, we know that we are including a wide spectrum of pathophysiological mechanisms, a wide spectrum of clinical manifestation, etc., etc. MRI gives us a window into brain and spine pathology in this case, because it provides us with objective disease markers. So it's the ideal candidate tool to provide input features to stratify patients. And handling this disease heterogeneity is crucial for personalized clinical management, because of course we want to know if a patient is more likely to respond to a specific treatment. We want to know if a patient is more likely to worsen over time, to be able to tune clinical management based on the individual patient characteristics and ultimately to ameliorate the prognosis. So basically we can obtain information from MRI. In classical descriptive analysis, we just look at average association at the group level. Of course, this is super interesting because it provides us with some mechanistic insights about the pathophysiological mechanisms of the disease. But from the perspective of the individual subject, this might be not that useful because the individual subject might be very far away from the average at the group level. So we need to stratify subjects. So we need to separate subjects in different subgroups that share common characteristics, and then look at the specific association of subgroups with the clinical outcomes of interest. And if we push this concept even further, we can go to personalization, where it's basically a stratification where a group is composed of just one subject, which is the individual patient. Machine learning offers us many tools to deal with this heterogeneity. By definition, this has been explained before. With machine learning, we are able to learn patterns from large data sets, and then we can do prediction at the individual subject level on external subject. And of course, the models are optimized in order to maximize the accuracy, the predictive accuracy on unseen subjects. You know that the field of machine learning application to neuroimaging is exploding. If you look at the results of a PubMed research, including the keywords neuroimaging and AI, you can see that it's a clearly exponential curve, and we are at the explosion phase. This depends on a lot of factors that are facilitating this explosion. First of all, the increasing availability of large neuroimaging datasets, but also the computational performances are ever increasing. There is the introduction of new algorithms. There is increasing awareness on methodological challenges and also best practices, because of course applying machine learning to neuroimaging is something that has some caveats, it has a lot of biases. So there is increasing awareness not only on the potentiality of the methods, but also on the limitation of the methods, and also the introduction of explainable AI techniques that are slowly transforming the black boxes that we thought were machine learning models to at least glass boxes, where we can try to understand why the model makes specific predictions. The first family of tools that we have to deal with disease heterogeneity and to stratify patients is the big family of disease progression models, which are a family of mostly unsupervised machine learning techniques that estimate the most probable sequence of events within the disease course and or separate different subgroups based on specific characteristics, and they do that based on cross-sectional data. we said that we are dealing with disease heterogeneity. We can conceptualize disease heterogeneity in terms of temporal heterogeneity and phenotypic heterogeneity. Temporal heterogeneity is just the difference that you have between the different stages of the disease. You can have more advanced stages and more early phases. While the phenotypic heterogeneity is the difference that you have between groups of subjects that differ in terms of specific characteristics and also in terms of progression patterns over time. Based on the specific algorithm, we can tackle the specific aspects of heterogeneity. Of course, if you look at the literature, all these family of models have been mainly developed and applied to primary neurodegenerative conditions, which are possibly the most natural field of application for this kind of approaches. This is just a partial overview, but of course, this kind of models have been applied to MS as well. And one family of models that have been applied to MS is the event-based models, where you just deal with the temporal heterogeneity. You estimate a sequence of events over the disease course. And in this work, led by Dr. Eshaghi, who will talk right after me, so I will try not to go too deep into this, with a very large multicentric cohort of patients with MS, they used as biomarkers volumes of gray matter areas defined according to a parcellation scheme that was ADRAS defined based on the neuromorphometric ADRAS, and they defined a sequence of events that characterize the evolution of MS over time, where the event here is the specific gray matter region becoming atrophic, where atrophy is defined based on the deviation from the healthy population. So what they find was that basically atrophy of the cingulate cortex, of the brainstem, and of the thalami are early events in the natural course of MS. This pattern is relatively constant across clinical phenotypes, with some minor differences. For example, cerebellar atrophy seem to happen earlier in relapse onset forms compared to primary progressive forms. But most important, the stage change over time correlates with the disability accumulation as measured by the annualized increase in EDSS. A very similar approach was used also by another work from the Amsterdam group, where they tried to expand the same approach by including additional MRI and clinical biomarkers. They did that on a smaller cohort of subjects from a single center, and they considered as MRI biomarkers not only regional gray matter volumes, but also mean upper cervical cord area, lesion burden, but also more advanced techniques. So they took eigenvector centrality averaged for the major resting state networks from fMRI. They took mean FA of major white matter tracts, and they also included cognition with a pretty wide battery. They found that basically gray matter atrophy of the cerebellum, the thalamus, and microstructural damage of the corticospinal tract are basically always early events. While where they did the comparison, this you can see on the right is a positional variance diagram, which is a kind of a usual kind of plot that you can see in disease progression models. On the x-axis, you can see the stages. On the y-axis, you can see the biomarkers. In this case, they are ordered. And the opacity of each square encodes the probability of a biomarker event happening at that specific stage. They did a first trajectory going from healthy controls to MS subjects, and this is the results that you can see. Then they did the same, but going from low EDSS to high EDSS and going from cognitively preserved to cognitively impaired. And they found that for these two additional models, patients with higher disability and patients with cognitive impairment tended to have earlier disruption of functional centrality in the DMN and earlier spinal cord atrophy. These two models. There is another subgroup of models called SUSTAIN, which stands for subtype and stage inference, that combines ideas from clustering and event-based modeling in order to tackle both temporal and phenotypic heterogeneity. Basically, it estimates different subgroups within the big group of patients that are characterized by different trajectories of biomarker alterations over time. Of course, sustain comes with different flavors, but the most used one is the one relying on the linear Z-score model, because of course these models are interpretable, are super useful, but of course they make a lot of assumptions on the nature of the disease progression. The most used one relies on the assumption that disease progression can be described as the linear evolution of cumulative biomarkers alteration over time, where biomarkers alteration are defined in terms of deviation from a reference norm, so Z-scores. And the assumption here means also that the biomarker needs to change over time in a monotonic manner. So basically, it has to go in a specific direction. It can't go backwards. And this assumption is very well fitted by atrophy, because of course, gray matter volumes, brain volumes are something that tends to decrease, tends to go in the same direction, even in healthy aging. And this is also more pronounced in disease. So basically, the end product of sustain is that it estimates different subgroups of subjects, and each subgroup is characterized by specific trajectory of biomarker alterations over time. And then it also provides a probabilistic assignment for each subject to a specific subtype and a specific stage within the subtype. Here you have similar positional variance diagrams. Here again, x-axis we have the stages, y-axis we have the biomarkers, and here the color of the squares encodes the level of biomarkers alterations. Of course, this is arbitrary, but usually this kind of model, we tend to use Z-scores level of 1, 2, or 3, meaning mild, moderate, and severe alteration of the biomarker. Again, Dr. Eshag in a very beautiful work with a huge cohort coming from clinical trials and observational cohort. They took as biomarkers gray matter lobar volumes, the lesion burden measured in T2 weighted sequences, and the normal appearing white matter T1, T2 ratio as a measure of normal appearing white matter microstructural damage. They found that the optimal number of subtype was 3 subtypes that were labeled according to the early events in the sequence as cortex-led subtype, normal appearing white matter subtype, and lesion-led subtype. This is not only interesting in terms of the insights that this model provides on the disease mechanisms, but this is also very much clinically meaningful because, for example, when they looked at the association with the risk of confirmed disability progression and of relapse rate, they saw that the lesion-led subtype was associated with a higher risk of confirmed disability progression and a higher relapse rate over time. And also it was associated with a positive response to treatment. So basically what we did in Naples was to try to replicate this kind of approach in a more circumscribed setting. So single center, just patients with relapsing remitting multiple sclerosis. And to try to use this approach to really stratify patients in a clinical setting, comparing the classification of sustain against a long-term follow-up, a 10 years follow-up, where we had EDSS, and so we classified in terms of reaching of EDSS milestones. We had the BICAMS test to test for cognition, so we classified in terms of number of BICAMS tests that were altered, and also in terms of transition to secondary progressive course. As biomarkers, we considered the lesion burden, and also gray matter volumes, this time for a more fine-grained parcellation of the brain obtained according to the AAL Atlas. You can see on the right just an overview of the overall workflow. So basically, we segmented the scans to obtain MRI-derived features. MRI-derived features need to be Z-scored with reference to a normative population. We used baseline data to train and cross-validate the sustain model. The cross-validation here needs to define what is the optimal number of subtypes and also to have a look at the consistency of progression patterns over cross-validation faults. Once we obtained the optimal number of subtypes, we fitted the final model on all the training data, and then we applied the trained model to the whole data set, so also longitudinal scans. And then once we had for each subject, subtype, and stage, we went on to look at the association with clinical variables to see if this classification was biologically meaningful and also if it was prognostically relevant. Of course, this kind, depending also on the sample size, you often need to reduce dimensionality. It's not something that you can 100 features, especially with the sample size that we usually deal with. So we had to reduce dimensionality. We did a feature selection step by selecting those MRI biomarkers that are more likely to be altered in MS. The results of the feature selection was a final number of 11 features, including T2 lesion load and grammar volumes of some regions that we know tends to be particularly prominently involved in MS, including the thalami, the insular cortex, the cingulum, and the occipital cortices. From the cross-validation procedure, we found that the best fit was obtained with the model with two subtypes. And these are the two subtypes. Basically, based on the earlier events, we labeled two subtypes are deep regamator first subtype and cortex first subtype. Basically, this is very close with the results from Eshagi's paper, because the atrophy of deep gray matter regions tends to be very close in terms of the sequence of events to lesion accumulation. And of course, we didn't have the normal appearing white matter subtype because we didn't really have a measure of microstructural integrity at the level of the normal appearing white matter. So next step was to, once we had the subtype and stage assignment for every subject, to try to understand if this classification makes sense. Of course, for such a classification to make sense, we expect that the subtype tends to remain stable over time, and it did. In the light of the longitudinal time points, we had a stability that was above 80% in terms of subtype. And also we expect stages to increase because overall MS is a progressive disease, so we don't expect things to go backwards. And indeed, stage tended to increase over time with an average stage increase, annualized stage increase of 0.20. And then when looking at the clinical outcomes, the baseline sustained stage correlated with EDSS, but also it correlated with long-term 10 years clinical outcomes in terms of disability milestones, in terms of transition to secondary progressive course, and in terms of cognitive impairment. As for the subtype variable, the deep gray matter first subtype was associated with greater EDSS at baseline and was also associated with an higher risk of being cognitively impaired at 10 years follow-up. So just to wrap up about the final results, baseline EDSS correlated with both subtype, and in particular, deep gray matter first subtype had higher EDSS, and stage, of course, higher stages corresponding to higher EDSS. Long-term EDSS correlated with the baseline sustained stage. Long-term cognitive impairment correlated with both subtype and stage at baseline and also with their interaction, and long-term transition to secondary progressive course correlated with baseline stage. So just to wrap up about disease progression models, we have seen that they're a very nice tool to stratify MS patients based on MRI-derived features. The classification that we obtained is biologically meaningful and is also clinically relevant, especially from a prognostic point of view. And not only these kind of models provide insights into disease mechanism because they tell us something about the sequence of events occurring in MS, okay, but they can also be used to effectively stratify patients, both in the clinical trial setting and also in the clinical practice setting. And with this, we can move on to the second part of the talk, which will deal with another family of approaches relying on machine learning that we can use to stratify MS patients. So a little bit of introduction about brain age modeling and brain age paradigm. The brain age paradigm is by now a concept that is pretty well established in the neuroimaging and neuroscience world. Basically, most of you, I guess, are already familiar with this concept, but very rapidly, we use machine learning from simpler to more complex models to model chronological age as a function of brain MRI. We usually use structural MRI, but we could do this with whatever modality. And we could use raw images, we could use derived metrics, whatever. And so by doing so, we train and validate the model, we obtain a model of healthy brain aging. And the results, by now, if you look at the state of the art in the literature, the best models that you can find in the literature achieve a mean absolute error below 3 years. So you can have very accurate models to predict chronological age based on brain MRIs in healthy subjects. Once you have the model, you can apply the model to unseen subject to generate a prediction of age based on brain MRI. Once you have the brain age prediction, you can compare the predicted age against the real chronological age of the subject. This difference, which goes by the name of brain predicted age difference or brain age gap, or you can call it however you want, is considered a measure of brain health. Why? Because it expresses the deviation of the individual subjects from reference healthy aging trajectories. So basically, if a subject has a positive brain pad, it means that his brain looks older than you would expect based on his chronological age. On the opposite side, if a subject has a negative brain pad, it means that his brain looks younger than you would expect based on the chronological age. With this concept in mind, you can understand that this is a concept that we can easily apply to basically all the diseases that affect somehow the brain. Because of course, if you think of an healthy brain, an healthy aging trajectory, and I'm talking about brain aging, whatever insult, whatever pathology can shift this trajectory and can cause a deviation from the healthy aging trajectory. With BrainPad, we measure the amount, the magnitude of this deviation. And of course, this deviation, the amount of this deviation will encode the relevant information about the disease process. And in fact, alterations of BrainPad have been demonstrated in a wide spectrum of conditions. Basically, all the neurological or psychiatric conditions that affect somehow the brain can have some increase in BrainPad. Of course, this is good because it means that we have a very sensitive biomarker, but this also means that the biomarker is not that specific because it is sensitive to a wide range of very different pathologies. Again, if you just look at the literature, the most natural field of application was primary neurodegenerative disorders. But as I said, this has been applied to almost every condition of the central nervous system. This has been applied to psychiatric condition, mood disorders, schizophrenia, IHV, so whatever. And of course, it has been applied as well to MS. This study from the group of Oslo was the first study applying the brain age paradigm to MS subjects. And as far as I know, it was the first study demonstrating that patients with MS have an increased brain age gap compared to healthy controls. What they did was to select an internal population of MS subjects. They had 3 time points per subject, plus an internal reference cohort of healthy controls. They compiled an external dataset of healthy controls from public dataset. They took 3D-T1 images, and they derived metrics based on free surface segmentation. And using an extreme gradient boosting algorithm, they modeled age as a function of MRI-derived measures. They built both a whole brain, a global model with all the features extracted by free surfer, and they also did regional models where they took free surfer measures only for specific subregions of the brain. What they found that basically MS subjects have a higher brain pad compared to healthy controls. And the effect size was 4.5 years, meaning that on average, a person with MS in their cohort had a brain that looked 4.4 years older than the corresponding healthy control. And you can see from the distribution plot on the right, you have all the regional models, and on the top row, on the bottom row, you have the global model. And you can see that basically all the regional models deviated from healthy controls, but the highest deviation was found for the subcortical and cerebellar model. And a similar degree of deviation was found for the global model. Not only they did this at the cross-sectional level, they also demonstrated that when they looked at the longitudinal time points, there was a significant increase in brain PAD over time, meaning that the predicted age tended to increase faster than the chronological age. And this is a clue that if you look at brain PAD longitudinally, you will be able to sense something that is disease-related and that happens on the top of healthy aging. This was the first demonstration of an application of the brain age paradigm to MS, but this has been replicated in a much wider study from UCL led by James Cole, where they took a larger multi-center clinical population of MS subjects, including longitudinal time points. In this case, the brain age model was obtained from pre-processed gray matter and white matter maps, again, from a dataset compiled off of public datasets, and of course, based on 3D-T1 images. And the algorithm was a Gaussian process regression. Again, they found that patients with MS have higher brain PAD values compared to healthy controls, and this is expected somehow. But they also found that the amount of deviation in terms of brain PAD between patients and controls depends on clinical phenotype. If we look at the estimated marginal means, we can see that the highest deviation is found in secondary progressive subjects, where we have an estimated marginal mean above 8 years, meaning that on average, secondary progressive patients have brains that look 8 years older than healthy controls. And of course, as expected, the lowest deviation was found in CIS patients, where we had an estimated marginal mean of slightly above 2 years. And then, of course, they went on to look at the association with clinical variables, and they found that higher brain PAD values cross-sectionally were associated with higher EDSS values. Not only this, they also replicated this kind of analysis in the longitudinal setting, and they demonstrated that the rate of change, the annualized change in brain PAD correlated with the annualized change in EDSS. This was significant basically only in the relapsing remitting and CIS subgroups, meaning that the faster your brain PAD increases over time, the faster you will accumulate disability. And also they did a survival analysis where they demonstrated that patients with higher brain PAD values at baseline were associated with a higher risk of developing confirmed disability progression. So again, towards the prognostic value of brain PAD as a biomarker. This is what happens regarding the relationship with the clinical disability. But what is the relationship with cognition? Has anyone done something like that? They indeed have done it. From the Bruxelles group, it was a small cohort, local cohort. Of course, they trained, as always, the brain age model on external healthy controls. This time, it was a very simple model based on ordinary least square regression based on MRI-derived features. But again, they obtained brain PAD values for MS subjects, and they correlated brain PAD values with SDMT. And they saw that there was a significant correlation between brain PAD values and SDMT in the expected sense. So the higher the brain PAD, the worse the performance at the SDMT. So that they suggested that brain PAD could be a surrogate measure of cognitive impairment in MS. So far, so good. We have seen brain age, what brain age can mean in MS. But all these models, all the standard models of brain age that we use, that we see in the literature, most of them rely on 3D-T1 images. We have said before that according to guidelines, a 3D flare acquisition is not mandatory in the routine follow-up of MS subjects, so it is not always routinely acquired, while a 3D flare acquisition is mandatory and it is usually routinely acquired. So to increase the translational impact of this kind of approach, let's try to see what happens if we build the brain age model based on the flare contrast rather than the 3D-T1. This was a work developed at UCL. Basically, there was a very small clinical population, so this is something that is already in progress. We need some more clinical validation. But in terms of the brain age model, we took 3D-T1 and 3D flare scans for more than 1,500 healthy controls collected from different centers. We build in parallel models based on 3D-T1 and models based on 3D flare. And we tested 3 different 3D convolutional neural network architectures, specifically an inception ResNet, a DenseNet, and a simple fully convolutional neural network. The first result of this analysis was that basically, in terms of performance, the model relying on the flare contrast wasn't really far from the performance of the T1 standard T1-based models. The difference was not statistically significant. But then next question was, okay, the performance is similar, but are they also equally sensitive to MS effects, MS-related pathology? And probably yes, because on this very small set of 27 CIS and 26 MS subjects, we compared BrainPad with healthy controls. And for both models, we found that CIS and MS subjects had significantly higher BrainPad values compared to healthy controls, with the difference that with the T1-based models, the magnitude of this difference was higher than with the FLAIR model, but this needs further clinical validation. And another possible expansion of this concept of brain age in MS, which is a rather conceptual one, basically in the classical brain age paradigm, the target clinical population is compared against a model of healthy aging. Of course, the model has been trained on healthy subjects, so it will capture those aspects of brain pathology that most resemble healthy brain aging. And while this assumption could make sense in some pathology, especially primary neurodegenerative disorders, this might be reductive in conditions like MS, because of course we know that MS differs from healthy aging not only in grade, but also in nature, because we have demyelinating lesions in MS, while in healthy aging we have very few white matter lesions that so won't be captured by the model, and also the spatiotemporal pattern of atrophy will be different in MS compared to healthy aging. Just to give an example of this, all the models that we have seen so far, they trained the model both on lesion field and non-lesion field T1 weighted scans, and results weren't really different because, of course, the model was not sensitive to white matter lesions because the model didn't find white matter lesions in the training phase on healthy subjects. So when an MS subject is presented, the model won't capture the presence of white matter lesions. So what if we model age or even disease duration directly in MS subjects as a function of brain MRI? In this sense, we would obtain not a model of healthy brain aging, but a model of MS-specific aging, so a model of disease progression, basically. And the idea behind this work that is currently in progress, so this is super preliminary, is that the MS-specific brain predicted age difference would provide an MS-specific biomarker for disease severity that could be more accurate than the classical BrainPad obtained from healthy aging models. And of course, this is not really a new idea, because the idea of taking a relevant indicator and contextualizing it by referencing it to its distribution in a population of patients with similar disease duration or with similar age is something that is already present in the MS field with EDSS, because there we have the MS severity scale and we have the age-related MS severity, where we take EDSS as a simple clinical indicator of disease severity, and we contextualize it against distribution of EDSS in patients with the same disease duration in the case of MS severity scale, or of patients with the same age in the case of age-related MS severity. If we expand this concept, we could do this with brain MRI, and that's the idea behind the MS-specific brain predicted age difference. This is very preliminary, so it's by now we are just at the feasibility part of the study. So we took a large multicentric cohort of patients with relapse onset MS. We did the usual 80-20-20 split, training, validation, and test. We use a 3D DenseNet architecture. We built parallel models with a T1 contrast and 3D flare, just to show that there is, just to investigate if there is any difference. And of course, for being able to understand why the model makes certain prediction, we also did explainable AI using guided backpropagation, we obtained saliency maps. In terms of performance, the first thing is that the model performance is quite good in the sense that with this sample size, we obtain a mean absolute error with the T1-based model of 3.27 years, which is quite close to the best that you can get on healthy subjects. And this is somehow already a clue that the model trained on MS subject is looking at different things compared to the model trained on healthy controls, because a model trained on healthy controls on this cohort would output absolute error in the order of 5, 8, 10 years. And the other information here is that the flare-based model is quite similar in terms of performance to the T1-based model. And also in terms of interpretability, this is just an example case, so this needs to be done at a wider level. But if we look just at the single subject, you can see that the regions that most contributed to the age prediction were the regions around the ventricles, corpus callosum, and the thalami. I mean, this can be meaningful, especially because if we look at the saliency maps that we find in the literature with the healthy brain aging models, there the significant parts tend to be more diffusely distributed, and especially along the pericortical CSF spaces. There is no, the thalamus is not that important in this model, so this could be, again, a clue that this model might capture some MS-specific things happening in the brain. But of course, the clinical validation part will come after this, and we will know if this measure is more accurate than the classical brain age, the classical brain pad. And so to close with the brain age part, we have seen that the brain pad matrix is sensitive to MS and also to the degree of severity of brain damage related to MS. It is associated with physical disability, both cross-sectionally and longitudinally. It correlates with cognitive performance, and also it has prognostic relevance because higher brain pad values are associated with a higher risk of confirmed disability progression over time. And also finally, that MS-specific brain age models might provide more specific and so more accurate disease markers, but we will discover this in the near future. And that's it. That's the end of my talk. So thank you so much for your attention. If you have any questions, I'm happy to answer.
Thank you very much, Giuseppe. I think there is one problem with your microphone. The last sentence, we could not hear you.
I hope it's just the last.
Okay, that's fine.
Okay, if it's just last, I just said thank you so much for your attention, and if you have any questions, I'm happy to answer. Is it any better now?
Yeah, it's perfect. Thank you.
Okay. I hope it was just the last part.
Thank you very much. Very interesting talk. One question, had you already looked to other parameters that are closely related to age? So, for example, walking speed is a classical outcome that is related to age and a very good predictor as well for mortality as well in the broader population.
Yeah, I haven't done this yet. I have T25 footwalk data for the cohort that I'm analyzing right now. So this is something that I will do. I remember that on the paper from the Oslo group, they tried to correlate also the 9-hole peg test.
For your talk, I have a question. We are talking about brain age, but we know that disability in MS is mostly related to spinal cord. So according to the brain pad, have you any correlation with some spinal cord marker, such as atrophy, or I don't know?
Not that I'm aware of. The few studies doing brain age on MS didn't have spinal cord measurement available. So, of course, this is something that when you correlate the brain age measure with disability, this is a black spot that we are not really investigating because we know that spinal cord damage has a big impact on disability and we are not really looking at that. Ideally, in a conceptual framework, you could even do a spine age framework. I don't think no one has ever done this. But so far, from the literature that I'm aware of, and from the data that I have right now, I don't have spinal cord data. This is a black spot in the relationship between brain age and disability, in the sense that we are not really recording this information.
Okay, and very short last one. Have you any data on pre-symptomatic MS?
Not pre-symptomatic, but for the study that I'm doing right now, the validation, the external test cohort is intended to be a CIS cohort. So I don't have the pre-symptomatic stage. It would be really nice because, of course, if you are able to demonstrate that this biomarker is meaningful at a very early stage in predicting the longitudinal evolution, of course, it's a very relevant information, but I don't have pre-symptomatic. I have just people after the first demyelinating event. And that's where I'm going to do the clinical validation. And we will see what happens there, but I don't have pre-symptomatic. If you have any, please send it to me because I understand the relevance of the question, of course.
Thank you very much, Giuseppe. We're going to stop here. Thank you again. So we have a 15-minute break if you just want to take a short coffee. And then we're coming back at 3:45.
welcome back. Very ready. Okay, very good. So now we'll have the third speech in this machine learning session. The talk will be given by Dr. Arman Eshaghi, who is a medical doctor from Tehran. And hello, we see you on the screen. Then you had your PhD in neuroscience from UC London, from the University College of London. And you were part of the network of Progressive MS Alliance. And so you worked with most of the famous names of MS that we all know. And now you speak to us about MS subtypes and brain age modeling identified using machine learning. So the floor is yours.
Thank you very much for the introduction. And also I would like to thank the organizing committee for having invited me to give this presentation. So in the next 40 minutes, I'm going to talk about, as was mentioned, on staging and stratification of multiple sclerosis, but also specifically on classification, how we subtype or classify MS patients, which is becoming more and more important because we have more treatments and we have a completely new disease compared to the past few decades. I'll mention a few parts of the literature, the work we have done, the work we are doing and others have done, and in an aspirational way, I also look to the future. What are the beats that are missing that we need to do in the MS field, very specifically using MRI, but also outcome measures, clinical measures, which we would need for being able to develop ways using MRI to subtype patients and to stratify patients. So I think this meeting is quite well placed to start by Charcot's classification of MS. I believe the first person probably in the modern literature, modern medicine, who looked to classify MS was Charcot, and he used the clinical presentation and also the post-mortem manifestations of the disease to classify MS into spinal, cerebellar, cerebrospinal, and abortive MS. This changed a bit over the years, but the basic parts of his classification remained that as one of the very first classifications of the disease. We see Pierre-Marie, he was again at the same place that Bruno Stankov is today and his team. And what he did, he was the student of Charcot, and he looked at ways of introducing the chronic progression of MS into the classification of disease. So he introduced a temporal pattern or a temporal progression into what Charcot has done over the years. After that, we see Otto Marburg, who was probably the first non-French famous neurologist in MS. What he did, he tried to look at also acute MS, and these are his classifications, which built on top of Charcot and Pierre-Marie over the years. Otto Marburg himself was from Austria, and he also had as we know, we have the Marburg MS these days is a acute MS, but he was also very aware of the insidious progression of disease. He had a stationary type for multiple sclerosis. Over the years, other big names, and they tried to classify MS, either try to rate disability, as we know very well on EDSS, different classifications, how disease evolves, and also people who tried, such as Ian MacDonald, tried to incorporate the new technologies in the 70s and 80s, including VEP, evoked potential, and then later MRI, into classifying. First diagnosis, of course, classifying and rating patients to be able to then treat patients, although there was no treatment at the time. And at the time, one of the big criticisms for these kinds of classifications was, what's the point of doing this for a disease that you diagnose and basically say adios? As soon as you know the disease, you cannot do anything for it. Obviously, we are in a completely different era. We do have treatments to treat MS, and I think that has to be celebrated, but that requires a paradigm shift in how we define MS. So we get to the modern era of treatments, including more recent classification of MS in 1996, we see we classified MS, and this is an oversimplified schematic presentation of what Fred Lublin in 1996 and his clinical trials team, which were convened by National MS Society in the US. They looked as the well-known ways that we classify MS: relapsing, remitting, secondary progressive, primary progressive, and also progressive relapsing, which I didn't mention because it's not used anymore. But we see in 2013, we have new concepts in classification of MS. You see on the right, we have a concept of active disease. We have a concept of progression. But we do need a paradigm shift, because the problem is that none of these ways we classify MS match the underlying disease biology. It was mentioned on multiple occasions during the meeting this morning that we need biomarkers, of course, including MRI, to be able to push the paradigm, to break new ground by reintroducing redefining multiple sclerosis classifications. So this way of classification of disease, as I mentioned, has been so far symptom-based. It's not just specific to MS. We also see this in other fields, such as Alzheimer's disease, what you see in this slide. We have been using symptoms, but we are moving towards ways of using the disease biology, underlying changes, disease mechanisms, to try to be symptom agnostic, because same symptoms might be the results of different underlying mechanisms. But what is really important when you think of classification of the disease is how you stratify, how you stage a disease. And again, I give an example of Alzheimer's disease on the right, because I feel in terms of classification, data-driven classification, the field of Alzheimer's disease is ahead of us in MS. So we have ATN way of based on the pathophysiology of Alzheimer's disease. On A, that stands for amyloid, T for tau, and also neurodegeneration. We may have different modalities, including PET, for example, biofluids, biomarkers from CSF, from blood biomarkers, and also obviously in neurodegeneration, we look using MRI. But again, what's really important, as also mentioned here, MRI is not really specific to the underlying pathophysiology. That's always a problem. But that can be, we can use other modalities to try to fill that gap. So one of the first attempts on our side at UCL to be able to start to stage the MS in a computational way using machine learning. So we use machine learning because AI, artificial intelligence or machine learning, gives us the opportunity to be objective at the same time, hopefully unbiased. And it also gives us the opportunity to look at scale, the data that we humans, radiologists, neurologists, neuroscientists, we cannot look at on our own and manually. So what we see here is a paradigm called event-based model, which was invented at UCL by Danny Alexander's group. The idea here was to use the brain atrophy to stage MS, and we used the data from the MAGNIMS consortium. What we found that, well, you see ABC, these are different MS subtypes based on the 1996 classification. We see that there are, first of all, the atrophy or the brain shrinkage happens in stages. When we use T1 weighted MRI to stage patients, it happens in stages. So we see there are areas of the brain, such as thalamus, hub areas, you may think of it in a network point of view, that are affected early on. For example, also precuneus, precentral gyrus, insula, these are areas that act as networks. What is really striking when you compare different MS types, we see that they are more similar than different. So as expected, the MS classification, one of the messages, take-home messages which will come out of my talk, is that the MS clinical types that we have, they are not based on disease biology. They're really not different under the underlying pathophysiology. But if you use the EBM, event-based model, to stage patients, as you see in the bottom right, patients with primary progressive MS, for example, they have a faster rate of progression in the stages, MRI-based stages. So that's one way of using MRI to stage patients. There are others, but what the next step would be, once you have staging, is to be able to subtype or classify patients. These two things, they happen in parallel. So the disease progresses, but at the same time, patients may have these different classes of disease. So this is a work done by the group in Basel. They use MRI and principal components analysis and also ICA to be able to find data-driven groups of patients. What we see, they found 4 different groups solely based on T1-weighted MRI and brain atrophy, in a way, brain volumes. And what they found that when they looked at the serum neurofilament, which wasn't used to classify patients, these patients were different. For example, group A, they had higher neurofilament potentially because of higher neurodegeneration. So that's, again, the data-driven classification of patients is what's being done here. Our work, which was also mentioned by previous speakers, including Giuseppe, is to use ways of using what I showed you on event-based model, which is a machine learning paradigm, but in a more intelligent manner, in the sense that we do not assume different MS types. They follow the same trajectory, but we leave it to the machine, to the AI, to decide how many subtypes we have. The first question we asked, this is a data from Progressive MS Alliance for more than 9,000 MS patients. You can have a look on the publication in the bottom. With the first question we asked how many MS subtypes we have. So number 3 came, using again different ways of quantifying the number of subtypes. What was really interesting is that we found 3 different groups of patients who have a lesion dominant pattern. You see there the progression from early lesions to later progression to the atrophy. This color here shows the severity of the abnormality. Patients who had a diffuse white matter damage, which we looked at using a crude, I would say, measure of T1, T2 ratio, but that's the only measure that's available at scale in clinical trials, also potentially in clinical practice. And the other group of patients were the patients who had predominant atrophy, brain shrinkage in the cortex, which we call them cortex-led patients, who later on develop more severe lesions. What is really striking, we see that patients who we identified as lesion-led, we looked at the clinical trial, randomized control clinical trials. On the right, you see patients with lesion-led had about 80% increased treatment effect according to the rate of EDSS worsening, whereas patients with cortex-led, they were less likely to respond to high-efficacy treatments. So here we're looking at the high-efficacy treatments of, for example, in progressive MS, including, for example, ocrelizumab and other high-efficacy treatments. The other parts of this study is we also looked in placebo groups of the clinical trials retrospectively. We looked at the potential for CDP, or confirmed disability progression, confirmed after 6 months. As expected, patients with lesion-led, they were also more likely, as you see here, to develop CDP, to become more disabled over time, which we also could reproduce it in an external cohort of patients. So we are not alone to think about the mechanism-driven. Benedetta Bodini, she mentioned this review of recent Lancet Neurology in her talk. So this is exactly the same idea, that to use mechanism-driven frameworks and ways of classifying patients, to move away from historical classifications of symptoms toward the underlying disease biology. Clearly, MRI is not the only one. We definitely need, as was mentioned by Bruno Stankov's questions again and again, and also others, we need to complement MRI with other biomarkers, of course, including blood CSF, potentially PET, OCT, visual effect potential, but also others. I'll mention later in my talk how we can develop new biomarkers to be able to use for classification of MS. But what's the use of having a data-driven, mechanism-driven classification of MS? It's really hard to imagine what that can look like in MS. So in my talk today, I'm going to draw on lots of examples from other fields in medicine. This is one example from lung cancer. So we're looking at a trial that's being run right now. It was published in Nature a couple of years ago. This is led in Birmingham in the UK. It's a trial on lung cancer where patients go through the standard of care therapy, and if they don't respond to that, they go through the high throughput genetic screening, and then they are stratified. So the title of this workshop is stratification. They're stratified based on the genetic mutations into different groups, and they receive, based on the genetic mutation, they receive stratified treatment. So stratification, is a common ground between the traditional medicine, what Charcot was doing, and individualized precision medicine, which is the future, next, I would say 100, 200 years. So that's where we are right now. We're trying to stratify before we will be able to do that at the individual level. So what happens is that this kind of stratification, mechanism-driven classification of MS would allow us to be able to develop treatments for pathophysiology, part of the pathophysiology for which we cannot have treatments. We do not have treatments, including, for example, progression of MS, which we cannot do that much about. We are very good in stopping inflammation. We're not really good in stopping progression or at all. So again, this is one example how patients on the right side, you see, they receive very different treatments, CDK, for example, CDK6 inhibitors or LAK inhibitors, exactly depending on what kind of mutations they have. I really don't think genetic high throughput screening is the right thing to do in MS, but it gives us ideas how we can use MRI, other measures to have mechanism-driven classification. So I continue again, getting back to MS, looking at the ways of stratifying using prognostic models. Again, when I say stratification, we're looking at ways to look at the future, how patients may change over time. So one area is my group and myself we're working on is prognostic modeling. So the MRI, including MRI, but also blood biomarkers, OCT and others, they can be input to the models. And what we can do, we can develop AI machine learning models where you identify and calculate a risk for patients for an outcome. The outcome usually is EDSS, is a very crude outcome, but the outcome is used. Towards the end of my talk, I try to look at other potential biomarkers we can use. And also we should be able to tell our patients the time it may take for them to develop a special kind of event. So the risk tells us two things, whether something will happen, whether I'm going to be wheelchair bound. But the other question, when that is going to happen, is it 6 months, 1 year, 2 years? That's the other way of stratifying patients. So this is a work that's not yet published. On the left, we use different MRI measures, but also including clinical measures in the about 22 clinical trials on close to 9,000 MS patients. What we have in the middle is there are three different AI machine learning models. We merge the results together, and what we calculate is a sum of a risk score. We use different models because different models, they have weaknesses and strengths, and if you merge them together, you're more likely to have a risk score that is more meaningful for patients and can be better used to predict the future. So what we see here is when we use that AI model as a deep neural network model also, what we look at it is we can use the data, clinical data, but also MRI data, and when you mix them together on the right, you'll be able to stratify patients using just baseline data to predict what's going to happen in terms of the risk of developing disability progression, what you see in the vertical axis over 2 to 3 years. So this is just one of the ways we can use AI in predicting the future. And again, another question, how can this be used? One way of using it is to run clinical trials in a paradigm which I call prognostic enrichment, to try to enrich clinical trials using patients who are higher risk for a specific event. And this is what we looked at. For example, you see a 3-year clinical trial. We did in silico simulations for sample size analysis. And if you could enrich clinical trials using MRI and clinical data for patients who are higher risk, you have about 10-15% increase in the sample size. And as I showed you, about a third of patients, they were in this high risk group. So you also end up excluding 2/3 of patients, which also may have its own problems. In any case, there are ways, in my opinion, moving forward. The other aspect of stratifying disease is using brain network models. This is the work done by Elisa Colato, who was my PhD student. She looked at the clinical trials, specifically in secondary progressive MS. She used MRI and extracted brain structures that they co-vary together, the volumes of which they co-vary together. So the hypothesis is that if there are two brain regions that they co-vary together, they're likely to be connected, maybe functionally or structurally. In this paradigm, you wouldn't need the DTI or functional MRI, and you can do this in clinical trials, potentially in the future in clinical practice. So we're looking at two different networks, which we call them component 2 and component 20. And what Elisa used, she used ICA, independent components analysis, which is a well-established method on brain MRI. And what we looked at, this is the hazard ratio of risk of confirmed disability progression to stratify patients. And what we see using this, these two are the network measures. So you see, we can't predict about, but the hazard ratio of about 30% increased chance of progression for every unit increase in the network load compared to, for example, the measures that we do deep gray matter, 28%. Whether or not this 28%, 30% are statistically significant is a completely different question. But in my opinion, it shows that the network models, they have the potential to be used, or at least to complement what we have as the conventional ways of looking at brain. I'm going to skip this slide. Giuseppe gave us a very good understanding and an overview of brain age, and he presented this brain path. What I'm going to look at is what's going to the next few years, what we're going to see and what we need, what are the fields to get to the point where we can stratify patients with MRI and other measures in a much improved way. So one of the issues, in my opinion, that we have, especially in the field of AI, machine learning, is the way we develop models. We try to gather evidence. So we really suffer from low quality of research, and I do believe it's a pervasive issue. It's just how research funding works, that most of the work done by AI machine learning communities is what we call offline validation. We develop something, it looks nice, we just move on. What we need to do as a field, and we're really good in running randomized controlled trials. We have lots of treatments. Other fields in neurology, they look at us to have ideas about clinical trials. We need a similar way of generating evidence for AI, for MS classification using AI and technologies that we see here. For example, we need safety, utility, large-scale phase 2, phase 3, even phase 2 trials for AI machine learning models to be able to say they can actually help patients. So you cannot just show it retrospectively and just have a panel of experts and just publish their review paper and convince the whole community to have a new classification. I really think we really need to have strong evidence to be able to shift the paradigm. So clearly there is no example in the field of neurology. I give an example in the field of cardiology, how AI and machine learning can be used for helping clinician to make this decision. So this is a study done, is a pragmatic clinical trial in Nature Medicine done for patients who are suspected for cardiac failure, who need to go to expensive echocardiography. But before you do that expensive part of the screening, you want to do ECG. And the question is, can AI help the clinicians to do that kind of decision making? And the one important part is we're comparing this here is the clinicians, doctors who have access to AI results to those who do not have access to AI results. We're not comparing AI versus humans, which I think is fundamentally wrong and will never work out really. So the idea here is that these patients or the doctors who had access to the results, the ECG interpretation from the AI, they could better, as you see, the diagnosis of cardiac failure, and the further echocardiography was much better, as a 2.1% versus 1.6%, and this was statistically significant. So that's a template for us to be able to move forward. The other problem that we have when we come to use MRI to develop measures is, unfortunately, I mentioned this many times, we do not have the right outcome measures to be able to assess MS patients. For almost everything, we rely on EDSS, disability, and even time walk tests and so on, which are used in clinical trials, less so in clinical practice. The problem is that they're very crude. When you have an outcome measure that's crude, you cannot stratify patients using MRI, any other biomarker. So I think we need to go back to the drawing board. So these are examples. I don't think these are successful examples, but at least in a research setting, these two, what you see on the left and right, the floodlight is an application developed by a pharmaceutical company where it's used in some clinical trials with mixed success for example, assessing cognitive function. On the bottom right is another work done by the Amsterdam group, for how fast patients with MS they can work with their smartphone, and that can be used, for example, to score disability. I really don't think these are, in my personal opinion, these are the ways to move forward, because the patients, they usually don't do these kinds of activities, at least in a daily setting, and some of these settings, they also don't assess patients in a natural environment. So again, I'm just giving examples of other fields, because I think we need to learn and to develop, to think out of the box. So one of the fantastic outcome measures I came across the past few months is to use remote monitoring of patients, successful remote monitoring. So this is one example of looking at the body posture in patients with Duchenne muscular dystrophy to develop digital biomarkers. So we're not talking about measuring walking distance or how well patients can perform, but just develop new biomarkers. What you see on the left is the biomarkers that they use for Duchenne muscular dystrophy. Is called 6-minute walking distance. It's very crude. You would expect with the disease progression, this should go up in children. Whereas when the patient posture was used and using AI, they used the kinetic posture of patients to develop a digital biomarker, which they call this kind DMD, again, using the posture changes using during the clinical visits, but patients doing daily activity living. So that's what DMD is for. They could develop a biomarker, digital biomarker that you see goes up, the disease progresses. And what we see, the variability compared to the left is much lower. This basically means that, for example, this is very similar to our problem in the MS field, where we have a very noisy measure such as EDSS. We need thousands of patients to run a phase 3 trial. With this kind of measure, if we can reduce the variability, you can also increase reduce the sample size, increase the power, and have faster, and also be able to better stratify patients using other biomarkers, of course, including MRI. Another example, again, is to be able to monitor patients. Again, another example from Nature, published a few weeks ago, to be able to monitor patients during their sleep. So what was done was using AI outcomes, patients who were in the prodromal stage of Parkinson's disease. We see, even compared to the clinical assessments and the assessment of clinicians, when they are constantly assessed during their sleep on the pattern of breathing, we see that the constant monitoring of patients without the need to do anything, patients can be monitored remotely. It's possible to develop the biomarkers with a less variability, so we can be more confident. So this is clearly not related directly to MS, but it gives us a template how we can move forward to be able to have better biomarkers, to be able to develop better imaging biomarkers. If we don't have good outcome measures, we won't be able to have good imaging biomarkers. And that's why I brought this up in this meeting. I'm going to summarize and wrap up my talk. So I discussed why do we need AI? Why do we need artificial intelligence? So there are two aspects to it. First, it will allow us to understand the data we have, the MRI, the PET, or whatever data you have. It also allows us to develop new things that they don't exist now, new biomarkers. There are lots of different future potentials for this. I showed you one example of decision aid systems. The hope is to be able to add machine learning stratification to clinical decision-making system to be able to improve what we do for patients. The problem is we need different outcomes. We cannot use crude outcomes for developing that. And the other area is the lengthy path to do this kind of research. The time it takes for a treatment for MS from the basic science, animal models, to prescription for patients is about 40, 50 years. And that's the same for AI. If we have a new model, it will take 30, 40 years for that if we are about to prescribe that in a clinical setting, to take that to the patients. That requires funding. That requires for us understanding, to thinking out of the box and designing a research in a way that can be and stand up for scrutiny of clinical trials. So in the end, I want to thank my funders. I'm funded by National Institute for Health and Care Research, which is the UK government body. Most of the work that I've done was obviously not done by myself, but lots of my colleagues at UCL, Queen's Square Institute of Neurology, I'm also an affiliate member of Neuro, McGill University, especially with Doug Arnold and the group in Montreal. And also I would like to thank you for your attention.
Thank you very much. So the paper is open for discussion. I think Bruno Stankov.
Hello, very good talk. Nice to hear you. I think it's a very general question that I will ask. Do you think if we want to include artificial intelligence in the clinical practice, that we are at the stage where we should look for new models, or whether we should use existing model and try to apply them in the clinical setting? And if yes, what would be your recommendation as a trial design, to validate them?
Thanks, Bruno.
It's quite broad.
My apologies for not. No, I think it's a very relevant question, and apologies for not being there in person. I do think so. There's a huge difference in what we do in the research setting from what we do in the clinical setting. So the papers we publish, including what I have done so far, is done in a research setting that does never generalize to the clinical setting. So I would think we do need real new models. I do think to be able to, in a very basic setting, or perhaps for the purposes of this meeting, MRI, one example on lesion segmentation, we do that well in research setting. I do want to see models, new models, where we can do them in a clinical setting, and that's different. We have in clinical practice, for example, in the hospitals in Paris, you do different protocols. We have different protocols in London, so we need new ways of having models that can work on the data. MRI is just one example. It's not just MRI. We have a lot of data, clinical data, and could you think of also blood biomarkers or other biomarkers? So my first answer would be no. We need to. I think we should go back to the drawing board. We should rethink the research questions we ask, but the research questions that can be done in a clinical setting. And I do think with the advent of new systems in the hospitals, IT systems, but also with the advances in technology, the border between research and clinical practice is becoming finer. It's becoming easier to trespass this border. And I do think we should have the courage to think and use the clinical data to develop models for processing that kind of data. And to keep it very short, but I want to give an example in clinical trials. The models we use in clinical trials, they won't work in clinical setting. That's one example. But I think that this is a lot more that we should discuss. It's not just clinical trials.
Are there different opinions on that? I mean, really, I fully agree with your view of being proactive, because no matter what, there will be the medical doctor that will be the responsible, and that's just one information among others. So that's up to us to take it into account. And we have very many different fields that have already experienced about that. I'm thinking about meteorological, because that's the colleagues we're working with in Toulouse in the aeronautics, providing us with the CNNs. And well, it's something that works in meteorology because the data is easy to enter. In fact, in medicine, that's much more difficult, but no one expects that meteorology is 100% reliable, and that's the same in whatever tools we can produce. Won't be all reliable, but that's one help. I think you took the microphone. You want to react?
Yeah, I just had a question maybe related to that. Like, if we say, and I think we've seen that many great models that we have in research settings cannot really be generalizable in the clinical setting. Do you think that maybe, if we go back to MRI, do you think that maybe we still didn't find the right biomarker to move with to the clinical setting? Do you think that we still need to find the right one? Maybe that's also one reason.
I think I do agree. Clearly, we do. I don't think we have the right biomarker. Yeah, I do. I think that's part of the problem. But just taking one step back is that if we develop an idea in a research setting, I think we should develop ideas in a clinical setting initially, using clinical data. If you don't use clinical data, if you don't use clinical MRI scans, so the clinical MRI scan by definition is an MRI scan that was not acquired for research. So we have a lot of data. Clinical, the hospitals, we have a lot of data that we can. So I think the first step is a very practical step, is to, instead of using data from a curated data, you would want to look at the data that's not really curated for research manner, and then you may end up having different biomarkers. Although I do think we have quite valid biomarkers in clinical trials. For example, appearance of new lesions, a brain atrophy, for example, in a clinical setting at the group level. So I'd say the basic or the next step for me would be, or I think for the field would be, to think at least how we can replicate that in a clinical setting as a first step. But of course, you're absolutely right. I do think we would also need new biomarkers. And I'd mentioned this, how we can develop new biomarkers. That was one example. Of course, it was not an MRI, but that's one way of we can think about. I think MR fingerprinting was mentioned in this meeting. So that's one of the ways of thinking about new ways of developing also new biomarkers and using the technology we have, which we didn't have 2 years ago even, to do so.
Arman, thank you for this fantastic talk. I've got perhaps a very naive question. So you show that with your new approach, you change the paradigm of stratification. You get 3 groups of patients according to the different parameters you have entered in AI. I would like to know if you may have a new paradigm, a new set of groups, including new parameters, as you said you showed just before, in terms of new clinical assessment, and what could be the consequences on the choice of a treatment, of a future treatment.
Absolutely. So thanks very much for the question. Usually when you start a question, I was saying it's a naive question, it's usually not a naive question. It's an expert asking a very spot-on question. So so what I showed you in a study from 2021, which I've done, was on clinical trials. You're absolutely right. I think in a previous question again from Bruno, it came up. We didn't, for example, include spinal cord in disability. If you are interested in walking disability, motor disability, spinal cord should be included. So that's, these are low-hanging fruits. I would say the feasible outcome measures that we can immediately use. Yes, I'm looking into incorporating that again in a clinical setting. So we're using now, as we speak, data from hospitals to do so, and again, MRI measures that we haven't used before. That's one thing. And the other thing is the outcome measures. I fully agree. So we don't have the outcome measures. The problem there is that we also don't have the data. So to be able to look at the new outcome measures, we need to generate new data for these outcome measures, and sometimes that's not easy. So we are bound, within the next 2, 3, 4 years, we're bound to use be creative with what we have. What we have accumulated over the past 20, 25 years. In a way, if you know what I'm trying to say, is that you're using AI by definition, you need to have access to really big data sets. So I think that's the stumbling point for developing new, incorporating new measures, whatever that they are. Could be advanced MRI, could be other measures that I didn't include, even blood biomarkers, for example. So, it's always a trade-off between the data availability and what we can do at scale in a way that we can also validate across centers and so on. And of course, running these big studies across centers is not cheap. It's extremely expensive.
You have more comments? Thank you very much. And thank you again. We have 3 more short communications, and Jean-Philippe will call on the first one.
So first of all, thank you very, very much, Arman, for your talk. And so we're going to have the first short communication from Tom Fuchs from Buffalo Neuroimaging Center. He's going to talk about quantifying disease pathology and predicting disease progression in MS with only clinical routine T2 FLAIR MRI.
Hello, everyone. So my name is Tom Fuchs. I'm currently an ECTRIMS postdoctoral research fellow. I'm in Vrije Universiteit in Amsterdam right now. But all the work I'm showing you is from, it's already published. It's work that I did with the Buffalo Neuroimaging Analysis Center where I finished my PhD. And I sort of retitled my talk once I saw what was in the program, because I'm focusing entirely on T2 FLAIR methods, and I think in the context of what everybody's spoken about, what I'm really talking about is practical imaging prediction for the next clinical age, where if we're going to be applying stratification models or quantitative MRI metrics, and when I say quantitative, I just mean continuous measures, using MRI, we have to do it on what's available in the clinics. So the group in Buffalo has for many years been focusing on T2 FLAIR and developing automated quantitative metrics for just that purpose. And so a lot of the work I'm showing you is based on not what I've done, but it's sort of an amalgamation of their work. So we've already sort of established that T2 FLAIR is the most robustly available MRI sequence in clinical environments. And so I think, and I know I'm not the first person in this workshop to declare it as a really good target for these sorts of quantitative metrics to be taken into the clinical age. So let's look at what we've done. So there's 2 questions I tried to address with this paper. One is, how well does T2 FLAIR metrics together, how well do they correlate with existing measures you might get from even just T1 weighted imaging, which I'm calling scientific quality, because even high resolution T1 weighted imaging isn't always available in clinics. And then how well does that prognosticate patients? So we have 5 so far that we've developed in Buffalo. Lateral ventricular volume through a methodology called NeuroStream. Thalamus volume through a methodology called Deep Gray. Both of them using convolutional neural networks to produce automated quantitative images. A new one we very recently developed, medulla oblongata volume, and that's meant to stand in for spinal cord, which is often not imaged, but perhaps we can use this as a proxy and a representative of spinal cord atrophy. Salient central lesion volume is a method developed to try and get around issues of perhaps limited windows in clinical scans or problems of infratentorial imaging. It's a method that specifically focuses on sort of the central region of the brain and hopes to improve automated lesion quantification in that way. And then a simple network measure, network efficiency, not meant to introduce conceptualization of how the brain works, but just to introduce the concept of where lesions are matters, so it sort of accounts for lesion localization. So with those measures in mind, let's look at the group that I applied this to. It was a database of about 130 patients, all with a 5-year follow-up. So we have these MRI at baseline, and we can track disease change over the follow-up. You see a median EDSS of 2.5 at baseline, and that's relevant because we're going to talk about EDSS change, and an average age of 47. So you actually, this is a slightly older group than you often see in these sorts of research environments. Okay. So with those 5 measures in mind that I just mentioned to you, and all of them are acquired from, in this case, 2D T2 flare imaging, where the resolution is about 2 millimeters. And I first did a principal component analysis on these measures just to see what the sorts of variability there are to expect in them. And there's 2 major dimensions that account for most of the variability in the data. The first one I call my sort of network dimension, where it's thalamus, network efficiency, and lesions. And my second dimension is mostly accounted for by the lateral ventricular volume and medulla oblongata volume, so I'm calling it my atrophy dimension. And in the fourth quadrant there, you'll see that people with progressive MS tend to vary more in the atrophy dimension than you might see in the relapsing phase. Okay. Then now here, my sort of ground truth is always compared to measures from T1 weighted imaging, 3D T1 weighted imaging, and using either FIRST or FreeSurfer metrics. So you'll see in graph A that if I'm going to take those 5 T2 flare metrics together in a simple regression, that I'm pretty good at being able to, for instance, predict thalamus volume with an R² of 0.9. I've got brain volume at 0.5 R², and really they're all at about that, either 0.5 or up to 0.9 ability to be able to predict what you would get with human intervention and higher resolution imaging. And the messiest one is network efficiency being compared to a diffusion weighted imaging, but even that one I think we did pretty well. Then here's this, I call this like pseudo prediction, because predicting disability 5 years later isn't necessarily prognostic, because you could just be predicting what they had the year that you got them as well. But just for the sake of argument and comparison to the T1 weighted imaging data, I have this graph here where we see that you can predict EDSS with an R² value of 0.279, so about 30% of the variability in EDSS being explained with those 5 measures. And for SDMT, even better, with an R² of 0.38 in all subjects. And compared to the, oh, and I don't have the T1 comparisons here. Okay, well, I have them in my next slide. And here's disability progression. And here we're looking at, so disability progression just as a 3-strata EDSS change. So this is actually, we'll say, prognostic in terms of change over 5 years. And here we do see that we're able to correctly classify in about 70% of people using just the T2 flare metrics, and using the standard research quality data, which actually also accounts for cortical volume. It does pretty much just as well, a little bit better, 72% correctly classified in terms of whether or not they progress, and in this case a higher R² value, but in both scenarios they're significant systems. And I want to point out here that if you look at the beta values and p-values of each of the individual metrics in this 5-flare model, you'll see that none of them actually stood out as an individually significant predictor, but it's the 5 together that produces a meaningful model. So my point in conclusion of pointing that out is that the variability of all 5 is more relevant than the variability of perhaps one individually, and that's because they're capturing really different disease processes, right? So we're accounting for atrophy, we're accounting for lesions, we're accounting for atrophy in different locations. Missing from the T2 flare, metrics, I think, there's a future where we can get more out of it. As Dr. Doyle had said, no, I forgot how he said it, but he worded it very well. But anyways, perhaps we could have better cortical metrics. Perhaps we could integrate, for instance, the T2 flare brain age that we saw before. But I think that I tend to agree with the workshop speakers that this is a nice target for quantitative methods, and they seem to be working relatively well and can do so probably even better in the future. So here are my conclusions, as I think I've already stated them, that they're doing pretty well. They correlate well with our research quality data. They are prognostic to some degree. And not only could we apply these in clinical, perhaps in future clinical work, but even today, we could integrate methods like these to do more analyses of legacy data sets, where people have historical data sets that pretty much consistently have T2 flare data, and we could ask better and more questions that perhaps we did in the past. So, thank you. Oh, of course, I should mention the very smart people who did more of the work than I did on these projects: Robert Zavadinov, Michael Dwyer, Niels Bergsland, Ralph Benedict, Bianca Weinstock-Gutman, and Dan Yakimovsky as well. If you'd like to see more, this is already published data, and that's where it is.
Thank you very much. Any questions? Perhaps I'm going to start. You show that for the prediction, so you get almost 70% of a good classification. Did you try to include in that the cognition scores and the clinical scores for the prediction of EDSS progression? It could be interesting because your goal is to be able to predict with a single flare, but you can also use perhaps the clinical data at this point.
Yeah, I think that's a very good point. I think we naturally could have produced a stronger prediction model if we had included demographics and especially SDMT. I think SDMT is lost in a lot of these trials where they could be quite these studies where it could be quite helpful. For this study, I really wanted to state how well the T2 flare metrics work standalone, and I agree in future work that the combination ought to be helpful. As Dr. Asagi was saying in his talk, even things like blood biomarkers could be better integrated into combined models, yeah.
And you said that you add the medulla oblongata as a new feature for this prediction. So what is really the added value of putting this cross-sectional area of this region? So this is more related to the starting point of a spinal cord also. And so what is really the gain when you integrate that instead of just taking let's say, not the brain, but the other DGN and cortical measurements?
What is the benefit of the methods I used? The benefit is they were all validated.
Of medulla oblongata. So when you include in your...
medulla oblongata volume versus a cross-sectional area? That's a good question, and I actually don't have a good answer. Niels Bergsland, who developed the method, might have more to say about it than I do. I think he felt that that cross-sectional area was more limited than medulla oblongata volume, and if we could create a proxy measure of volume to be a more accurate representation than just a cross-sectional area, then why not? I suppose was his argument when I spoke to him about it. Yeah. Okay, all right.
So thank you very much.
Yeah, thank you.
So now we can ask for the next speaker, Anna Stolking from Leuven. Very good. So it's a collaborative work between imaging and neuroscience from Leuven. And Anna is speaking about multichannel diffusion. Yeah. Oui, ça, non. Donc on est... Pardon, sorry.
Okay, so I guess it's me now. Yeah. So I'll be going to talk today about multi-shell diffusion-weighted MRI characterization of chronic active lesions in multiple sclerosis. And I guess we all know already what paramagnetic rim lesions are, but I'm just going to give you a short recap again so we're all on the same page. So paramagnetic rim lesions are chronic active lesions with subsiding inflammation at the lesion edges. And in histopathology, this is characterized by accumulation of iron-laden microglia and macrophages, causing a hyperintense and susceptibility-weighted MRI that we can visualize with MRI, basically. PRLs are associated with increased disability and axonal damage, and it has also been shown that the diffusion MRI is actually able to characterize in vivo PRL tissue damage, but the specificity of diffusion MRI models is very limited. So what we wanted to do in our work basically is to compare 4 different multi-shell diffusion MRI models, and we used for this DTI, Diamond, and NODI, which are already quite well known, and used a new or novel developed MRI model for microstructure fingerprinting. While DTI is pretty commonly used, it has its limitations, as we already know now, by using only like a sum of the fascicles within a voxel, while Diamond is able to differentiate between crossing fascicles. NODI, on the other hand, is compartmentalizing within a voxel free water, interneuroid, and extraneuroid compartments. And microstructure fingerprinting uses a completely new approach. So while these 3 models mainly use very difficult equations to kind of find the best fit for the voxel, the microstructure fingerprinting uses Monte Carlo simulations of either single or crossing fascicles to best match the output within each voxel. So what we did is we scanned 44 patients at a 3 Tesla scanner and segmented 367 lesions. Of those were 202 PRLs and 165 were non-PRLs. And the lesions were segmented on FLAIR images, and the PRL assessment was done on susceptibility-based MRI, mainly on the face. We obtained also multi-shell diffusion MRI for each patient and obtained the T1 maps derived from MP2 RAGE images. And basically what we could see is that both the DTI and the Diamond model were able to show that the fractional anisotropy was lower in PRLs compared to non-PRLs, and that the mean diffusivity and the radial diffusivity is higher in PRL versus non-PRL, as we would suspect. If we check now the NODI and the microstructure fingerprinting model, we can see in the NODI model that the neuroid density index is decreased in PRL, as we would suspect. And interestingly, also in the microstructure fingerprinting model, we could see that the weighted fraction volume of the fibers is decreased in PRL versus non-PRL. Okay. So basically, we could show that in all 4 models, we were able to see that, in fact, PRL do have decreased tissue integrity or axonal integrity and decreased axonal density. The main reason why we did this analysis basically was the microstructure fingerprinting model can be further improved by using more accurate Monte Carlo simulations. So this could be a very promising method for the future because we can further improve the white matter simulations, basically. What we wanted to do then in the next step is basically also visualize this axonal damage. And what you can see here is a non-PRL lesion and the PRL lesion. First thing to notice is that PRL lesions are significantly larger than non-PRL lesions. This has already been shown in literature. And if we then check the tractography, we can actually see that PRL lesions have a significantly lower tractional density than non-PRL lesions. Yeah, that's it.
Thank you very much. Sorry. Questions?
That's very interesting and very novel with the PRL, but could you remind us about the similarity of information between the diffusion and the contrast agent, such as gadolinium enhancement?
Can you specify a bit of question? I didn't quite get it, to be honest.
About diffusion imaging.
Yes.
And contrast gadolinium enhancement, not the rim that you described. But is it already stated that
if gadolinium-enhancing lesions show differences in diffusivity? To be honest, I don't know. I think it should be because there is in gadolinium-enhancing lesions, in contrast to non-gadolinium-enhancing lesions, you have active inflammation going on. The axonal damage wouldn't be as bad as in non-gadolinium-enhancing lesions, but to be honest, we haven't looked into that yet, but this is a further step we're working on.
So, do you have an idea about the impact of susceptibility effects on your measurements for diffusion? Because the PRR will have more irons, so a shorter T2 star, and does it influence the way you are quantifying your tracks or your characteristics with the different models?
That's a good question. To be honest, I'm not quite sure if I can answer that right away. So we're using basically the flare only to really segment the lesion. We're not using any information of the flare images within our models or any further analysis. But I would guess that the accumulation of iron would influence our diffusivity as well. Does this answer your question? I'm not quite sure.
Yeah, I just want to know if you have some differences in terms of models, and that can be related, in fact, to the susceptibility. Did you look at your different parameters across models with for example, QSM or the amount of low signal within your
No,
your
not
lesion?
yet.
No, but it's really interesting to see the ability to get different features with different models. Yeah. Okay, thank you very much for this very interesting presentation. So the last talk of the session will be remote. Hello, Lina. So Lina Anderhalten is from Berlin, and she's going to present investigation of inflammation-promoted gadolinium retention within the central nervous system in the EAE mouse model and ex vivo. So, please.
Thank you very much for the introduction. I hope you can all hear me well.
That's okay.
Nice. And also, thank you very much for giving me the opportunity to participate in this workshop also online and to give a short talk. So during the last years, as an MD PhD candidate, I've been working on gadolinium retention in the EAE mouse model. So the mouse model of MS actually, comparing neuroinflammation, so inflamed brains with healthy controls, and also checking for gadolinium contrast agent toxicity in an ex vivo model. So as you all know, gadolinium-based contrast agents are used for the diagnosis of pathologies with blood-brain barrier disruption, like multiple sclerosis, as they diffuse into the tissues where the barriers are disrupted and then enhance the contrasts. And since 2015, there has been evidence that these contrast agents can actually accumulate inside various body tissues, especially after the application of linear contrast agents, will also lead to retention inside the brain, not only the bones, the liver, and the kidneys, and so on. So as you see in the picture A, basically the ideas or what you have to know about the contrast agent types that exist is that there's a macrocyclic type, which is stable inside the body and thought to be eliminated directly via the kidneys, while in the case of linear contrast agents, they can actually dissociate inside the body, leading to accumulation as they either bind to macromolecules or to insoluble phosphates. So what we have seen in 2019 in our lab is that actually the short-term retention after the application of linear gadolinium-based contrast agent in the EAE model is increased compared to healthy controls, so that this neuroinflammatory state somehow promotes the the short-term retention of gadolinium inside the brain. questions arising from this are now, does neuroinflammation also promote the cerebellar gadolinium retention also in the long term? And what are the differences between linear agent and macrocyclic agents? And does this gadolinium retention also have any neurotoxic effects on inflamed and non-inflamed brain tissue ex vivo? So what we did was using this longitudinal animal study comparing EAE mice, so the animal model of MS, to get the neuroinflammatory state inside the brain, to healthy controls in a longitudinal setup, and doing a baseline MRI in terms of quantitative T1 relaxometry, and then injecting either a linear type or a macrocyclic type of these agents intravenously to the mice, and then doing follow-ups 1 day, 10 day, and 40 days after the last injection. I will just only focus on the long-term date, so on day 40, because this was also the aim of the study, to look for the long-term retention and its effects. And what we were able to show is that using quantitative T1 relaxometry, that indeed the linear-based contrast agent gadopentate caused within the cerebellum a T1 shortening inside the cerebellar nuclei in the healthy controls, but also the EAE animals. Whereas for the gadobutrol, there was no obvious T1 shortening we could see by qualitatively looking at the images. But then on the other hand, quantifying this, we could see that indeed it was true that the gadopentatide caused a remaining signal until day 40, while the signal of gadobutrol compared to baseline values was diminishing towards day 40. And what was also really interesting was that there were significant differences between healthy controls and EAE animals in the case of gadopentatide until day 40, suggesting that there are indeed differences in the gadolinium retention comparing neuroinflammation and healthy controls. We then did laser ICP-MS, so laser ablation, inductively coupled plasma mass spectrometry. And on day 40, we were able to confirm that indeed in the healthy controls, there was less gadolinium retention compared to the EAE animals. As you can see here for the linear agent, there is indeed in the healthy controls accumulation of gadolinium inside the cerebellar nuclei, which we saw also in the MRI. But in the EAE animals, there were on day 40, after the last administration of contrast agent, still some accumulations also inside the cortical areas, which I think is really interesting. And then in the case of gadobutrol, we couldn't see any remaining gadolinium deposition inside the brain on day 40. And also interestingly, inside of the cerebellar nuclei, the gadolinium was overlapping with areas of high iron content. And then coming to our ex vivo model, which we used in the study, where we tried to assess the toxicity, the neurotoxic effects of gadolinium-based contrast agents. We used this model of brain tissue surviving on membranes 2 or 3 weeks ex vivo inside the incubator. We basically isolated hippocampi from the mice and then cut them into slices of 350 micrometers, cultivating the slices and adding both gadolinium-based contrast agents, just as in the in vivo setting, and then simulating the inflammatory status by adding the inflammatory mediator TNF-alpha. And we could see that after a 48-hour gadopentatide incubation, so after incubation with this linear agent, at 50 millimolar concentration, the cells started dying. So here the purple dots are dead cells, whereas in the healthy controls, we couldn't see any dead cells. And also for the gadobutrol, there was no enhanced cell death. And then quantifying this again, interestingly, we could again see that TNF-alpha had increased the cell death additionally. So to conclude and sum this up, we can say that actually the gadolinium retention after gadopentotate application persisted on the long term, so until day 40 in the mice, which is actually correlating to a few years of the human age, whereas the gadobutrol was efficiently cleared from the brain until this day 40. And using this ex vivo model of hippocampal slice cultures, surviving ex vivo, we could see that the gadopentotate, but not the gadobutrol, so not the macrocyclic agent, appeared to be neurotoxic at a concentration of 50 millimolar. And that this cell death rate was even increased under simultaneous TNF-alpha treatment ex vivo. So why could this be that actually the neuroinflammation is leading to more gadolinium retention inside the brain? Of course, it's logical that if the blood-brain barrier is disrupted, there will also be an elevated uptake of gadolinium-based contrast agents into the brain. But we don't think that this is the only reason, because we could prove the long-term retention of gadolinium. So we think that actually the gadolinium is binding inside the brain due to some tissue changes during inflammation. For example, extracellular matrix changes or changes in the composition of extracellular matrix components, thereby leading to new binding sites or more binding sites for gadolinium, and then hence also leading to increased gadolinium binding and neuroinflammation in the EAE model. Thank you really much for your attention, and I'm open to take any questions. Thank you.
Thank you very much. Do we have some questions in the room?
Well, maybe I missed the point, but did you have an explanation about why the cerebellum is the target of this deposition, as it is observed in human? This is very interesting.
Yeah, in the last years, there have been many studies on gadolinium retention in the brains of healthy patients. And people always look at the dentate nucleus, which is inside the cerebellum. So we basically decided to take this area of the brain as a region of interest for the first analysis. But we will also look at midbrain slices soon. Because we saw that probably the choroid plexus will also be a predilection site for gadolinium retention inside the brain.
So you don't have any idea about why there is a larger affinity in the cerebellum compared to the other brain regions?
Oh yes, probably I misunderstood your question, sorry. So the idea, or there are some theories about this, especially for the area of the cerebellar nucleus, that this area is really nicely vascularized. So many vessels are in this area. And this could be a reason why basically more gadolinium contrast agents are going inside this area and then staying there. And also, it has been reported that this area, especially also not only the whole cerebellum, but especially the dentate nucleus and the cerebellar nuclei, contain a lot of iron and also zinc and other metals that could potentially cause a binding of gadolinium by an exchange of ions. So the idea is here, the idea of transchelation, that basically structures containing ions, endogenous ions, exchange their ions with gadolinium, then leading to a really fist gadolinium binding in these areas. I hope this is answering your question.
Other comments or questions? Well, otherwise, thank you very much, and Jean-Philippe is going to conclude.
Thank you. Thank you very much for your presentation. So I hope you enjoy this day as I do. I learned a lot, and it was. I would like really to thank all the speakers, all the moderators, and the participants on site and remote. I think we have a lot of new projects to think together, and I hope that we will get more exchange concerning these different topics and different programs. Finally, I would like to thank the RCEP member, and especially Virginie Grember and Emmanuel Plassard for the logistic and all the organization of this day. And we can say that we will come back next year, first Friday of February, with a new program. So thank you very much. It was really a pleasure.